Hello guys, good evening. Hope everyone is doing really good here today. Guys, in this today's class, we are going to discuss about physiology, the rapid revision of physiology. The main aim of this class is to make sure that we cover as many topics as possible. Okay? In the sense, all the important topics which are needed for your FMGE exam. So in the next 4 hours, we'll be doing highly important topics. So I just don't want to waste any further time. Just let's start our talk. Okay? Now, the first system I have selected is highly important system as the cardiovascular. After cardiovascular system, we are going to discuss respiratory system. Later, we are going to start the central nervous system. The first three chapters are very important because these chapters, you don't understand these chapters, you don't understand patho as well as you don't understand the medicine. So the first three chapters I will be going little slow. Okay, little slow, but the other chapters. Oh, hello. Are you in here? Hello. What is the problem? You are language.
Hello, hello, hello. Is it clear, guys, now? Still not clear? Now it's fine. Okay. Yeah, okay. Now it's fine. Okay, guys. Now the first chapter which we are starting is cardiovascular system. Now in this cardiovascular system, the first topic which I have chosen here is the action potential of SA node. We all know the SA node is the pacemaker of the heart. Okay, it's a pacemaker of the heart, which means it's a self-stimulatory in nature. Now this SA nodal cell is a self-stimulatory in nature. See here, I am showing you the action potential. See, the resting membrane potential of SA node is how much? Direct question. The resting membrane potential is minus 60. Now, see, the resting membrane potential is not actually resting. Okay. Now the resting membrane potential is going towards the threshold. Please concentrate, guys. In SA node, automatically by default, for every 0.8 seconds, what happens is, see, the potential is reaching to minus 40. So this potential is called as a pacemaker potential or restless membrane potential. Restless membrane potential. Okay. So from minus 60, it goes to minus 40. First point. Now later on what happens? Whenever minus 40 is attained, immediately the cell is getting electrically activated. Now this phase which I am showing you, which I am highlighting, this phase is depolarization. Okay. Air saver. Air server. I think it's gone. Problem. Will you they lose connection? Huh? Guys, give us 1 minute. Guys, there is some technical issue. Just give us 1 minute. Seems everyone is having good discussion in the chat. Hi Ganesh Reddy. Yes, I'm good. I'm really good. I'm really very much enthusiastic to have this class, but I don't know why there is some technical issue which has happened. Today's session is enough for solving MCQs? Absolutely. The answer is absolutely. Yeah, sure, sure. So whatever the kind of questions you have, you just post it in the chat box. As much as possible, I will try to answer. Because like if I keep on just answering the questions which are coming in the chat box, I cannot complete all the chapters. Okay. So as much as possible, I will try to do it for sure. Okay. Okay, guys. I hope it's everything good now. Okay. Let's continue, guys. Now, what we are discussing is the action potentials in the essay note. Now, this phase, okay, this phase which I am highlighting right now, this phase is called as phase 4. Okay, phase 4. Now, this phase 4 is restless membrane potential. Restless membrane potential, which is something specific to the nodal cells, or which is something specific to the pacemaker cells. Now, once from minus 60, once minus 40 is attained, once this potential is attained, now what happens? Now, depolarization will occur. Now, this phase which I am highlighting right now, this phase is the phase of depolarization. Now, after depolarization, once the cell is activated, now immediately what will happen? Now, cell again will become inactivated. Now, this phase, now this blue color phase which I am highlighting right now, this phase is the phase of repolarization. But as far as exam point of view, what you should know, just these points. So, what is the resting membrane potential of a SNO? It's minus 60 millivolts. Actually, it is not resting membrane potential, it is the restless membrane potential. From minus 60, it will go to minus 40. Immediately, depolarization will happen. So, what is the first phase? The first phase, see here, is known as the phase 4. Okay, the first phase is known as the phase 4, which is called as a pacemaker potential or restless membrane potential. Now, why this electrical fluctuation is happening, sir? Why? The potential is moving from minus 60. See, the potential is moving from minus 60, it is going to minus 40. Why? Why? Because of influx of, see, it's because of the influx of which ions? It's because of the influx of sodium ions. Because of the influx of sodium ions, as well as because of the influx of little amount of calcium ions, this restless membrane potential is achieved. So what I am saying, sir, the phase 4 restless membrane potential or the pacemaker potential is because of influx of sodium into the cell via which channels? Funny sodium channels, also called as HCN channels. And this restless membrane potential, the movement from minus 60 to minus 40 is also because of entry of calcium into the SA node via which type of channels? T type of calcium channels. It's a T type of calcium channels. T means transient calcium. So again, what you need to know for your exam, it's very simple, guys. The first phase, see here I am highlighting this phase is because of entry of sodium into the cells, entry of calcium into the cells. Little amount of calcium will also come. Now, sodium is coming via which channels? Funny sodium channels or leaky sodium channels or HCN type of sodium channels. And calcium is coming into the cell via which channels? Calcium is coming via T type of calcium channel. T type. Now, after this, what is this phase after attaining the threshold potential? Immediately depolarization is happening, right? Now, this depolarization is due to influx of calcium. So, depolarization of SA node is because of influx of calcium. Why? Which type of calcium channels? D type of calcium channels? No, it's the L type of calcium channels are long-standing calcium channels. Please see here, the after phase 4, now what we have is phase 0. What exactly is phase 0? phase 0 is nothing but depolarization, activation. Electrically, the cell is becoming positive. Okay, the SA node is becoming electrically positive. Now, this depolarization is because of influx of calcium channels. Which type of calcium channels? L type of calcium channels, not T type, L type of calcium channels. That kind of question that will come in your exam is T type of calcium channels are working in which phase? Phase 4. L type of calcium channels are working during depolarization or phase 0. Now, after depolarization, what do we have? After depolarization, we have repolarization. SA node is getting inactivated. Now, why SA node is getting inactivated, or why the SA node is becoming electrically negative? It is because of efflux of potassium out of the cell. Guys, very, very important. Lot of time this question has been asked. The repolarization is dependent on potassium efflux. Potassium is going out of the cell. Potassium is going out of the cell. Okay, that causes repolarization. So, let's write it down here. The phase 4 repolarization is due to potassium efflux. Now, SA node completed. Pacemaker completed. Now, let's see some important points which you need to know. Sir, SA node is the one which determines the heart rate. If SA node is firing 72 times, heart will beat 72 times. If SA node is firing 100 times, heart will beat 100 times. So, heart rate is dependent on the number of action potentials which are generated by the SA node. So, for example, if you can block these channels, see, if you block the HCN type of sodium channels or the leaky sodium channels, I have said you, HCN sodium channels, leaky sodium channels, these channels are the ones which will bring the potential from minus 60 to minus 40. Now, if you block these channels, what happens? If you can block these channels, what happens? Heart rate will automatically come down. So, those persons who are having tachyarrhythmias, those persons who are having tachycardias, now we have to decrease the heart rate by using a kind of drug called as ivabradine. Okay, so ivabradine, the name itself is there. Bradine means bradycardia. So, ivabradine causes bradycardia, it decreases the heart rate by inhibiting which channels? By inhibiting leaky sodium channels or funny sodium channels, which will bring the resting membrane potentials towards the threshold minus 60 to minus 40. Okay, done. Now, after this, after seeing the phases of action potentials in the SA node, now let's directly jump into the action potentials in the ventricular myocyte. Okay, right now I am talking about myocardium cell, the heart muscle. Normally, heart muscle, is it going to be self-depolarized? Is it going to be self-activated? No. Okay, so normally, see, it is having resting membrane potential. The phase 4 resting membrane potential. So, this phase 4 is the resting membrane potential. Whenever it is getting electrically triggered, whenever it is getting electrically stimulated, what happens? Depolarization will happen. See, this is the depolarization. So, first we have phase 4, later we have phase 0. Now, after we are having phase 2 and phase 3. Again, phase 4 is coming. So, just like SA node, it is also having phase 4, phase 0, phase 2, phase 3. Now, let's see what are the important points which you need to know. Sir, what is exactly this phase 4? The resting, right? So, phase 4 is the resting membrane potential. What is the resting membrane potential of ventricular myocyte? It is minus 90. Just try to recap. What is the resting membrane potential of SA node? Resting membrane potential of SA node is minus 60. Okay. Now, after phase 4, what do we have? Phase 0. What exactly is phase 0? Depolarization. Depolarization is dependent on which channels? Remember, in SA node, depolarization is due to influx of calcium. But in ventricular myocyte, depolarization is dependent on sodium. The sodium influx which causes the depolarization of ventricular myocyte. Now, later what do we have? Phase 2. See, please concentrate here. Phase 2 actually. What exactly is this phase 2 looking like? It's looking like a plateau, right? It's a plateau. It's a plateau stage. Now, which means the cell is, the electrical potential of the cell is not fluctuating. It's a plateau. Why? Because the number of positive ions going out is equivalent to the number of positive ions coming into the cell. The amount of efflux is equal to the amount of influx. So, what exactly is happening in the plateau stage? Very simple. Here, potassium is going out of the cell. As usual, potassium is all the time going out of the cell. Potassium is leaking out of the cell. At the same time, what is happening? Calcium is coming into the cell. What is the importance of this calcium? It will help in contraction of the heart muscle. So, potassium positive charge is going out, calcium positive charge is coming in. So, in the phase of plateau, what exactly is happening? It's because of the calcium influx which helps in contraction of the myocardium as well as potassium efflux. Later what happens? Even this myocardium, it will have to undergo relaxation. Now, phase 3 is repolarization. This phase 3 is repolarization. Again, the cell is becoming electrically negative. So, it's because of what? It's because of the potassium efflux. Everywhere, remember, repolarization is due to efflux of potassium. Even in the SA node, phase 3 is because of potassium efflux. Here, even the ventricular myocyte, phase 3 is because of the potassium efflux. Okay, completed. And direct single liner questions which are kept on coming in the exam is, see, we all know in the heart, we are having 3 layers. We are having epicardium, myocardium, endocardium, outer to inside. Epicardium, myocardium, endocardium. Normally, depolarization will happen from where to where? Depolarization, okay, first SA node fires. Now, this action potential is getting delivered to the entire heart. Now, who will depolarize first? Which layer will depolarize first? The endocardium. So, all the time depolarization, your heart is made in such a way that depolarization will travel from endo to epi. But repolarization, inactivation will happen from epi to endo. Okay, nature have made your heart in such a way, those cells, they are maintaining the electrical potentials in such a way. Depolarization is all the time from endo to epi, and repolarization is all the time from epi to endocardium. Okay, so direct single liner questions which you need to know. Now, after knowing about the SA node, let's talk about the AV node, guys. AV node. We all having SA node? AV node is there. Action potential will come from SA node, it will come to the AV node. Now, AV node, it's having slowest speed of conduction. Now, once the action potential from SA node, it will come to AV node, the action potential is going to get slowed down. Now, in the AV node, the action potential is going very, very slowly. Okay, now why? Why, sir? It's because of presence of least number of gap junction. As there is least number of gap junctions, the action potential is not getting forward. Okay, the action potential is going slowly. Okay, so it's having the slowest speed of conduction, we know. It's having least number of gap junctions, and this AV node is also called as the gatekeeper of the heart. Okay, this AV node is the one which allows, which transmits the action potentials from the SA node to the ventricles. From the SA node, action potential have to come into the AV node, and via the AV node, only via the AV node, the action potentials will come down into the bundle of his Purkinje fibers and depolarizes the entire myocardium. Okay, so this AV node is considered as the gatekeeper of the heart. Now, sometimes what happens is, see, AV node is the place of slowest conduction. Sometimes what happens is, the electrical potentials which are coming from the SA node, they will be completely blocked in the AV node. This is called as a conduction block. So, what is the most common site of conduction block? SA node, AV node, bundle of his Purkinje fibers. The most common site of conduction block is again AV node. The most common site for the conduction block or the heart block is AV node. AV node is gatekeeper of the heart. After seeing, let's talk about the Purkinje fibers. What are the important points which you need to know regarding Purkinje fibers? The Purkinje fibers are these fibers are the cells which are having the fastest speed of conduction. The slowest speed of conduction is seen in, the slowest speed of conduction is seen in AV node, but the fastest speed of conduction is seen in the Purkinje fibers. Okay, why? Because presence of higher number of gap junctions. Higher number of gap junctions are present there. Okay. Now, after this, the most important topic which you need to know for your exam is heart blocks. Okay, heart blocks. See, guys, actually the heart blocks is the main topic of internal medicine, but still I would like to take the advantage because this is very, very important topic. Okay, sure, short question. Now, how many types of heart blocks are there? There are 3 types of heart blocks. First degree heart block, second degree heart block, third degree heart block, everyone knows. Now, before understanding heart block, you need to know some important points about the PR interval and the ECG. Every student knows that this is the P wave due to atrial depolarization, P wave. After P, you are having Q wave, R, S and T, P, Q, R, S, T. These are the waves. But here what I want you to know is something called as a PR interval. Okay, what exactly is PR interval? Starting from P, okay, starting from P and starting to Q, not R. Okay, not R. So this interval, okay, starting from P to the starting to Q wave. So this interval is called as a PR interval. Now, what exactly this PR interval signifies? See, exactly during this phase, during this PR interval, the action potential is coming from the SA node. See, starting from here, action potential, now it is coming down to the AV node and it is going through the AV node, So this entire phase, this entire duration is represented as PR interval. So what is PR interval? Action potential from the SA node is going to the AV node and through the AV node. So all these events or all these phases are just represented as PR interval. Okay. Now, why we are discussing about this PR interval? It's because in heart blocks, PR interval will be prolonged. We'll discuss now one by one. See, let's just recap what we have seen. PR interval, what exactly is happening? Action potential, it's traveling from SA node to and through the AV node. From the SA node, action potential is going to the AVN, means AV node. What is the normal duration of this PR interval? So, normal duration of the PR interval is 0.2 seconds. Okay, 0.2 seconds is the normal duration. Normal entire heartbeat is 0.8 seconds, right? So, this PR interval is accounting for 0.2 seconds. In ECG, you will get almost 3 to 5 small square. That's not important. At least very important point which you need to know is the PR interval is accounting for how much time? 0.2 seconds. Now, next what you need to know. For example, think logically and tell me, if PR interval is prolonging means, automatically what happens to heart rate? By logic you can say, if PR interval is taking more time, automatically heart rate decreases. The impulse is going slowly, so PR interval is prolonged, automatically heart rate decreases. So all the time, remember, very important point, it's a statement, direct statement, it's a fact that PR interval always inversely proportional to the heart rate. If PR interval is prolonging means heart rate is decreasing. Okay. Now let's talk about what exactly is first degree heart block. Very simple. PR interval is more than 0.2 seconds. Okay, simple. Please see here. PR interval more than 0.2 milliseconds. Sir, how we can know that the PR interval is more than 0.2 milliseconds? What is the normal duration of PR interval? Normally, it will fit in 5 small squares. It will fit in how many small squares? Guys, it is going to fit in 5 small squares. If you are having PR interval, please check the screen. Okay, it's gone. Not coming. Yeah, we are back. So, what exactly is first degree heart block, guys? Again, I will repeat, don't worry. So, in first degree heart block, what is happening is the PR interval is more than 0.2 milliseconds. The PR interval, now it's getting prolonged. Okay, more than 5 small squares. So, this is what exactly is first degree heart block. So, first degree heart block means very simple. The PR interval is prolonged more than 0.2 milliseconds. Now, in which conditions you will see this first degree heart block? That's a very important MCQ which you need to know. The first degree heart block is something seen in rheumatic heart fever because of that group A beta hemolytic streptococci. You all have studied, right? So, please know that rheumatic heart fever, the PR interval is prolonged. Along with rheumatic heart fever, the PR prolongation can also be seen in hemochromatosis and sarcoidosis. So rheumatic heart fever, hemochromatosis, sarcoidosis, all are these conditions where the PR interval is prolonged. Okay, PR interval is prolonged. You can ask me why PR interval is prolonged. You just tell me in rheumatic heart fever what exactly is happening. Okay, what exactly is happening? Aschoff nodules are there, right? So Aschoff nodules will interrupt the conduction. For example, take them as Aschoff nodules. Because of the Aschoff nodules or because of the hemochromatosis, iron deposition, okay, or because of sarcoidosis where there are granulomas, because of all these pathological conditions, the impulse is not properly getting transmitted to the AV node. The impulse is getting delayed. Okay, the impulse is getting delayed. So what happens? Automatically PR interval is going to be prolonged. So just tell me, first degree heart block means prolongation of PR interval. Prolongation of PR interval more than 0.2 milliseconds, or PR interval is sitting more than 5 small squares. Seen in which conditions? Rheumatic heart fever, sarcoidosis, or hemochromatosis. Okay. Now, what we have to do? If there is, usually you don't need to do anything for first degree heart blocks. They are not that dangerous. If at all you have to treat, you can give atropine. Okay. So what is the treatment we can give for the PR interval first degree heart blocks? It is the atropine. And I have said you what exactly is first degree heart block. PR interval more than 0.2 milliseconds. PR interval is prolonged. Now after discussing, let's talk about second degree heart block. In second degree heart block, we are having two variants. What are they? Mobitz type 1. See, Mobitz type 1 and Mobitz type 2. Okay, there are Mobitz type 1 and Mobitz type 2. Now let's see what exactly is happening in Mobitz type 1. Mobitz type 1 is also called as Winky-Back phenomenon. Mobitz type 1 also called as Winky-Back phenomena. Now please look at this image, guys. Are you able to appreciate? See, here the PR interval is normal. Later the PR interval is little prolonged. Later the PR interval is furthermore prolonged, which means there is progressive PR interval prolongation. First it's normal, later it's a little bit prolonged, later it's furthermore prolonged. So there is progressive PR interval prolongation. Now later what happened? See, there is a dropped beat. There is P wave, but after P there is no QRS. So what is happening in the second degree heart block? In the second degree heart block, there is progressive PR interval prolongation and there is sudden drop beat. Okay, this is what exactly is Mobitz type 1 or Winky-Back phenomena. Okay, now let's see what exactly is a second degree heart block, that is Mobitz type 2. Mobitz type 2 variant of second degree heart block. Now here this is a very dangerous type of heart block. See, most of the students what they will think is third degree heart block is more dangerous. Third degree heart block is more dangerous. Usually people think like that. Students think like that. No, it's the Mobitz type 2. Mobitz type 2 is a dangerous heart block. Okay, now what exactly is happening? Please first let's look at the ECG. See here, PR interval is normal, not prolonged. It's normal. PR interval normal. PR interval normal. It's not prolonging progressively. It's fixed. PR interval normal. But suddenly there is a dropped beat. Suddenly there is a dropped beat. Now this type of heart block is called suddenly the impulse got blocked in the AV node. Okay, I shouldn't say AV node, but later I will say suddenly there is a dropped beat. Heart is not beating. So this type is called as Mobitz 2 type of heart block. Now, if you look here, the very important point which you need to know for your exam is actually here the PR interval is not prolonged. In the first condition, PR interval is prolonged more than 0.2 milliseconds. Even in the second degree heart block, Mobitz type 1, there is progressive PR prolongation. Progressively, the PR is prolonging. But in which type of, this is a very important MCQ, in which type of heart block, the PR interval is not prolonged. See here, it is staying fixed. Why PR interval is not getting prolonged? Do you know? This explanation is very important. You need to know for your exam. See, in Mobitz type 2, the PR interval is not prolonged. Why? Because see here, the block is not in AV node. See, usually this is SA node. Here is AV node. After AV node, what do we have? Bundle of his. Later we have Purkinje fibers. Right now, do you know where exactly the block is? The block is in the bundle of his. Okay, so where exactly is the block? The block is in the bundle of his. If the block is in the bundle of phase, is there is any problem in the conduction from SA node to AV node? There is no problem. SA node to AV node and through the AV node, there is no problem. So PR interval is not prolonged. Why? Because the block is infranodal. Below the AV node, there is block. This type of block is called as the infranodal heart block. So for your exam, very important point is, which type of heart block is infranodal heart block? The infranodal heart block is Mobitz type 2. Mobitz type 2 second degree heart block. Okay, and this is most dangerous heart block. Why? Because in this type of heart block, the heart rate will be falling down to almost 20 beats per minute, 20 beats per minute, 15 beats per minute. Okay, now why, if you ask me, sir, SA node is actually producing the action potential. No doubt that action potential is also coming to the AV node, but action potential is not going down. Action potential is not going down. So here the action potential is blocked. Now what happens? Now heart is under the control of Purkinje fibers. See, even Purkinje fibers can generate the action potentials. Even Purkinje fibers can also depolarize. They can also act like a pacemakers. Now whenever the block is here, now the heart rate will be under the control of Purkinje fibers. So Purkinje fibers can generate a maximum of 20 beats per minute. So the person who is having type 2 heart block, Mobitz type 2 heart block, is having a heart rate of just 20 beats per minute or even less than that. So very important point which you need to know for your exam is, so what is the most dangerous heart block? It's the Mobitz type 2, not the third degree heart block, not the complete heart block. Okay. Now, what we have to do? What is the treatment in this condition? The patient is having severe bradycardias. Now he cannot even go for the operation. Okay, you cannot even keep the permanent pacemaker. Now these patients should be kept on temporary pacemakers. Okay, the person is having severe bradycardia. The heart rate is just 20. Now what we have to do here? The treatment is temporary pacemaker. Very important. Mobitz type 2 heart block. The treatment is temporary pacemaker. And two more important MCQs which you need to know is, sir, what is the most common arrhythmia in post-MI patients? Okay, see, imagine that I'm the patient who is having myocardial infarction. Imagine I am having myocardial infarction. After myocardial infarction, usually the patient will have arrhythmias. What is the most common arrhythmia? If they ask you, the answer is ventricular fibrillation. But if they ask you what is the most common bradyarrhythmia, bradyarrhythmia means very less heart rate. What is the most common bradyarrhythmia in a post-MI heart? In a post-MI patient, the answer is Mobitz type 2 heart block, the dangerous heart block. So Mobitz type 2 heart block is the most common bradyarrhythmia. But the most common arrhythmia is ventricular fibrillation. Okay. And I have already said you this is the most dangerous because it causes sudden cardiac death. Sudden cardiac death. So which type of heart block will cause sudden cardiac death? Type 1, first degree heart block, or Mobitz type 1 heart block, or second Mobitz type 2. Mobitz type 2 will cause sudden cardiac death, guys. Very important. Now after this, okay, after doing the treatment at temporary pacemaker, now let's discuss about the third degree heart block or the complete heart block. Okay. Now here the key word which you need to know is complete AV dissociation. AV dissociation means atria are contracting on their own, ventricle is contracting on their own. Atria and ventricles, they are not in sync. Okay, they are not in sync. Normally atria have to contract, later ventricle have to contract. For every P wave, you need to have one QRS. So one P wave, one QRS, one P wave, one QRS. But here there is AV dissociation. Why? Because see, in this type of heart block, please let me tell you. Let me write it down here. Normally this is the SA node, this is AV node, this is bundle of his. Later you are having Purkinje fibers, right? See, what exactly happened here is completely AV node is gone. Completely AV node is gone. No impulses are traveling from SA node into the ventricles. So what happens? SA node is generating the action potentials. These action potentials are controlling the atria, but the action potentials are not going into the ventricles. So now what happens? As the AV node is not conducting any impulses, we will call it as complete heart block. Absolutely, the impulses got blocked. Okay. Okay. Now what happens? Now the ventricle is under the control of bundle of his. Now bundle of his. Now it will control the ventricles. Usually SA node will produce maximum number of action potentials. So more P waves will be there when compared to the number of QRS complexes. Okay, let me here I have just hand drawn here. See, one P wave, second, third. Three P waves are there, but only one QRS is there. This is T wave. Okay, don't confuse it with P wave. Usually T waves are little bit tall. So one P wave, second P wave, but only one QRS. So other P wave. In this hand drawn image, I have shown you 1, 2, 3, 4, 5, 6. 6 P waves are there. But how many QRS are there? Only 2 QRS are there. So whenever you see such kind of abnormality in ECG, definitely this is AV dissociation. AV dissociation. Okay, let me show you in the ECG also. See here, please look at one P wave, second P wave, okay, third P wave, fourth P wave, fifth P wave, sixth P wave. 6 P waves are there. But how many QRS complexes are there? There are only 3 QRS complexes. So AV dissociation. The moment you listen about this word AV dissociation, there are only two possibilities. Okay, in a clinical integrated question, if you see this word AV dissociation, there are only two possibilities. What are they, sir? But one is the third degree heart block. Okay, so let me come here. See, let me write it down. The number of P waves and the number of QRS complexes are not matching. Okay, are not matching. There is AV dissociation. Now, there are two possibilities for AV dissociation. I have already said you. One is third degree heart block, where the impulse is completely blocked in the AV node, and the other possibility is ventricular tachycardia. Don't worry, we will discuss. Even in ventricular tachycardias, there is AV dissociation. So, what are the two conditions where you will see AV dissociation? One is third degree heart block, and other is ventricular tachycardia. Now, what we have to do? See, here the treatment is permanent pacemaker. It's not the temporary pacemaker, not that dangerous. Yes, it's of course it's not good, but still you can go with the the surgery implanting the permanent pacemaker. So permanent pacemaker is the option, but temporary pacemaker is used for the treatment of Mobitz type 2. Mobitz type 2. Atropine is used for the treatment of first degree heart block. First degree heart block. Okay, completed, guys. So heart blocks, 3 important heart blocks are completed. Now I will ask you a few important questions. You just tell me. Direct question, sure shot question. In which type of heart block PR interval is fixed? In which type of heart block PR interval is fixed? Come on, I am checking the chat box. In which type of heart block the PR interval is fixed? Fixed PR interval with sudden dropped beat. Fixed PR interval, guys. Here, see here, the fixed PR interval is seen in Mobitz type 2 heart block. Okay, Mobitz type 2 heart block. Charging pin. Okay. Okay. Now, after seeing the topic of heart blocks, now let's jump into the topic of cardiac cycle. Okay, a very important topic for the exam, cardiac cycle. Okay, without understanding this cardiac cycle, it's impossible to understand the entire medicine. This is the basics. These are the basics. I hope you have already studied all these points because you are already the exam going batches. Now, let's see one by one important points. What is the normal duration of the cardiac cycle? So, the entire heart, okay, the atrial systole, atrial diastole, ventricular systole, ventricular diastole, everything completes in 0.8 seconds. Okay, everything completes in 0.8 seconds. Now, what are the phases of cardiac cycle? The first phase is called as the atrial systole. Okay, the first phase is atrial systole. Now, see here, I'm just showing you the heart in a very simple way. Okay, the 4 chambers, atria, these are the atria, and down, these are the ventricles. Now, first what is happening, sir? Atria are contracting. See, I have just put here the plus symbols, which means the atria are contracting. When atria are contracting, what happens? The blood is going to fall into the ventricles. How much blood is going, sir? How much filling is happening? 30%. So, atrial systole is accounting for how much percentage of filling of ventricles? How much percentage of filling of ventricles? Only 30%. Only 30%. Okay. 70% of the ventricles filled by passively. We will discuss later. But right now, what is the important point which you need to know? Sir, atrial systole. Okay, atrial systole will account for filling of 30% of ventricles. Now, important MCQ. Now, this atrial systole, the contraction of atria will cause any sound. Actually, in a healthy individuals, it does not cause any sound. But in pathological conditions, it do cause a sound. So that is the S4 heart sound. Now direct question which you need to know is, sir, S4 heart sound is heard during which phase of the cardiac cycle? S4 heart sound, also called as the atrial gallop rhythm. Atrial gallop rhythm is due to the kicking of the atria, the contraction of the atria. S4 is heard during atrial systole. Okay, so heard during atrial systole. So I'm just drawing here the timeline. Okay, hand-drawn timeline. So first write down. First you are having S4. S4 is there first. Okay. Now after atrial systole. Okay. Now what do we have? Before going that, see here. Usually I have write it down here. 30% of the ventricles. 30% of the ventricles are filled due to atrial contraction. 30% of the filling of the ventricles is because of the atrial contraction, but almost 70% of the ventricles will fill by passively. Simply ventricles will fill. There is no need of atria actually. Okay, blood will directly, even without the contraction of atria, blood can directly come into the ventricles. Okay. Now after atrial contraction, what do we have? Isovolumetric contraction. Okay, isovolumetric contraction. Remember first point for your exam. Whenever you listen the word isovolumetric, iso means same volume. Volume is not changing. No blood is coming in, no blood is going out. But what is happening? Contraction is happening. Isovolumetric contraction. First important point which you need to know. What is the status of the valves? What is the status of the valves? See here. Here is the mitral valve. This is the mitral valve. Okay. Mitral valve is closed. Why? Because if, for example, think logically, if mitral valve is open, what happens? Blood is going to regurgitate back. That's very bad. So mitral valves are closed. So no blood is coming down into the ventricles. And think about the aortic valves. These are the aortic valves. Even aortic valves are closed, and here the pulmonic valves are also closed. So whenever you listen the word isovolumetric contraction, during isovolumetric contraction, all valves are closed. No blood is coming in, no blood is going out. But ventricle is contracting. Now, first question. Isovolumetric contraction starts with what? Sir, first, when the blood coming from atria into the ventricles, immediately what will happen? Mitral valve is closed, tricuspid valve is closed. First, valves are closed. These valves are first closed. Now, the closing of these valves will cause S1 heart sound. So, mitral valve is closed and tricuspid valve is closed. M1, T1, mitral closure, tricuspid closure will cause S1 heart sound, lub, first heart sound. Okay, it's due to the closure of atrioventricular valves, mitral valve, tricuspid valve. Okay, there is no inflow of blood and no outflow of blood. Okay, now some important questions which you need to know. See, no blood is coming in, no blood is going out. So what is the amount of blood present in the ventricle? This blood which is present in the ventricle, this is called as the end diastolic volume. Okay, end diastolic volume. Okay, at the end of the diastole, how much amount of blood is filled inside the ventricle? Usually in you and me, in healthy individuals, almost 120 to 140 of ml. Okay, 120 to 140 ml of blood is going to fill inside the ventricles. 120 to 140 ml of blood is going to fill inside the ventricles. Now, what are the important MCQs? Now, let's see. So, after S4, what do we have? We have S1 heart sound. S1 heart sound. So, mitral valve closed, tricuspid valve closed. After S1 heart sound, what do we have? Which phase is there? Isovolumetric contraction. So, this is the phase of isovolumetric contraction. During isovolumetric contraction, what is happening? Ventricle is contracting. When the ventricular volume decreases, what happens? The pressure inside the ventricle increases. So, the pressure is increasing from 10, 20, 30, 40, 50, 60, something like that. So, pressure is increasing inside the ventricle. Completed. Now, after that, isovolumetric contraction. What do we have? Which phase is there? So, it's the ventricle systole. Ventricular systole. Now, what exactly is happening in the ventricular systole? See here, normally, the pressure, whenever the pressure is reaching 81 mmHg, normally inside your aorta, the pressure, resting pressure, take it as 80 mmHg. All the time in the aorta, the pressure is 80 mmHg. But whenever you increase the pressure to 81 mmHg inside the ventricle, left ventricle, what happens? There is more pressure inside the left ventricle when compared to aorta. So immediately what will happen, sir? Immediately the aortic valve is opened. Immediately the blood from the ventricle is going into the aorta. So very rapidly the blood is going out. And still the ventricle is contracting. Ventricle is still contracting. See, ventricle is contracting and increasing the pressure from 81 to almost 120 mmHg pressures are generated. So with such a high pressures, the blood is moving into the aorta. So this phase is called as rapid ejection phase. A rapid ejection phase. Okay. Now, what is the importance of this rapid ejection phase? We will discuss in a minute. Now, after rapid ejection phase, what happens? Now, the pressure inside the ventricle is coming down, coming down. Okay. Again, it's gone. Fi is there? Hmm. GO2, GO fiber, desktop, 6N. Yeah, I'm checking the screen, guys. Is it connected? Sorry for the inconvenience, guys. It's not in my hands. I'm not a technical person. Okay. Now, what is happening? The pressure from 120 it's getting back to 80 mmHg. Okay. The pressure is again coming down, but still see, the pressure inside the left ventricle is more than the aortic pressure. See, pressure is coming from 120 to 115, 110, 105, 100, something like that. Even during this phase, blood is ejecting out. This phase is called as slow ejection phase. So first there is rapid ejection. After that there is slow ejection. So I can say here the ventricular systole is divided into two phases. The ventricular systole is divided into rapid ejection phase and slow ejection phase. Now let's just jot it down all the important points. So ventricular systole starts with opening of the aortic wall. See, once this aortic valve is opened, there is rapid ejection. So what is the first event? The pressure should have to cross 80. The pressure should have to cross 80 and it should become 81. So immediately the aortic wall should have to open. So first event is opening of the aortic wall. Now opening of aortic wall, does it cause any heart sound? Opening of aortic wall, does it cause any heart sound? Yes, sir. Opening of aortic wall causes heart sound which is called as ejection click. So ejection click is because of the opening of aortic wall as well as pulmonic wall. See, I am not discussing about the right side of the heart. Whatever the events happening on the left side of the heart, same events will also happen on the right side of the heart. Okay, here on one side, just give me one minute, guys. Hello, hello. Hey, everything is good. So whatever the events happening on the right side of the heart, same events are also happening on the left side. Same events. Okay, but let's start, guys. So aortic wall opens, which causes the ejection click. Okay, it causes the ejection click. Now, one by one. So what exactly is rapid ejection phase? What is happening in the rapid ejection phase? See, the pressures are moving from 81 mmHg to 120 mmHg. So during rapid ejection phase, most of the blood will leave the heart. Which means 2/3 of the stroke volume. 2/3 of the stroke volume. This is the question which was asked. 2/3 of the stroke volume will enter into the aorta during which phase? Rapid ejection phase. After rapid ejection phase, what do we have? Slow ejection phase. During slow ejection phase, the pressures are coming from 120 to again falling back to 80. Okay. Well, during this phase also, some amount of blood is going. So how much amount of blood is going? 1/3. 1/3 of the blood is leaving the heart. Okay. Now, after this, see here the events. The events are first aortic valve opens, causing the ejection click. Later, rapid ejection phase, slow ejection phase. See, once the pressure comes below 80, what happens? Aortic wall is again going to close back. Once the pressure falls below 80, okay, heart is relaxing, right? Heart is relaxing. So once the pressure comes little down to 80, immediately what happens? This valve will close. So the closure of the aortic valve on left side and the closure of pulmonic valve on right side will cause second heart sound. Okay. So aortic valve closes, creates the second heart sound. Now let's write it down, the events. First we have seen S4 heart sound. Okay, atrial contraction. After atrial contraction, what will happen? Now ventricle will start to contract. That is isovolumetric contraction. Before isovolumetric contraction, first the mitral valve will close and the tricuspid valve will close, causing the S1 heart sound. So now after that, what do we have? Isovolumetric contractions. After isovolumetric contraction, aortic valve opens. Aortic valve opens and causes the ejection click. Blood is ejecting out. Ejection click. After opening of the aortic valve, what happens? There is rapid ejection phase and slow ejection phase. After slow ejection phase, what happens? When the pressure comes below 80, what happens is aortic valve closes and pulmonic valve closes, causing S2 heart sound. So why I am saying in detail is because they will ask you S1 heart sound is coming after which heart sound? Just tell me. S1 heart sound is heard after S4, or which heart sound precedes? Which heart sound precedes S1? Who is coming before S1? S4. Okay. Which heart sound comes after S1? Just tell me. After S1, you can hear ejection click. Ejection click. Okay. It's because of the opening of aortic valve and pulmonic valve. Now, after this, sir, what is happening? After ventricular systole, the next event is isovolumetric relaxation. So, again, isovolumetric. Whenever you hear about the word isovolumetric, no blood is coming in, no blood is going out. All valves are closed. All valves are closed. Okay. Now, what is happening in isovolumetric contraction is simply the ventricle is relaxing. The pressure is going from 80, it's coming down to 70, 50, 20, 10, 4, almost to 0. The pressure inside the ventricle is coming down, coming down, coming down. The ventricle is relaxing. Okay, the ventricle is absolutely relaxing. This is isovolumetric relaxation. What is the important event which you need to know? See, during isovolumetric relaxation, again the heart is receiving the blood. From where? See, the oxygenated blood from the lungs is coming into the left atria during which phase? This was the question asked in one of the exam. Left atria starts to receive blood from the pulmonary veins during which phase of cardiac cycle? Isovolumetric relaxation. What is the status of the valves? Just tell me. What is the exact status of mitral valve, tricuspid valve, aortic valve, pulmonic valve? All valves are closed. Heart is simply relaxing. Okay. So just tell me, isovolumetric relaxation starts with closure of this valve, right? What is this valve? Aortic valve. After the closure of aortic valve, now simply ventricle is relaxing. 80 to 70, 70 to 60, 60 to 70, something like that. 60 to 50. Okay, ventricle is relaxing. Okay, pressure is coming down. So what I just want you to know is, see, after S2, what do we have? Which phase will be there? Sir, after S2, the phase, whatever is there is called as the isovolumetric relaxation, sir. But here I want you to know some more important points. Normally, you need to know this. The phase between S1 and S2, the phase between S1 and S2 is called as a systole, sir. The phase between S1 and S2 heart sound is called as a systole. Now, in systole, what are the events which are happening? The events are isovolumetric contraction, rapid ejection phase, slow ejection phase. Now, after S2, what we are having is the diastole. So, after S2, the phases, whatever I am going to discuss right now, are all coming under diastole. See here, important point which I want you to know. See, after S2, what is there? Isovolumetric relaxation. Heart is relaxing. Important point is, guys, are you able to appreciate the small gap I have given intentionally? That small gap, the small period, the first phase of diastole is called as the protodiastole. Don't think too much about it. Protodiastole is a small phase, milliseconds phase, small phase between S2 and isovolumetric relaxation. So, what is the first phase of diastole? If someone comes to you and asks you what is the first phase of diastole, it is protodiastole, the phase between S2 heart sound and isovolumetric relaxation, a small phase. This phase is called as the protodiastole phase. Protodiastole. After protodiastole, what do we have? Isovolumetric relaxation. Done. Isovolumetric relaxation. After isovolumetric relaxation, what is the next phase? See, ventricle is absolutely relaxed. After ventricle is absolutely relaxed, what is the function? What should happen? Again, it have to fill the blood. Again, you need to fill the blood. You need to fill the ventricles. I have already discussed with you. See, in the phase of isovolumetric relaxation, left atria is filling with the oxygenated blood. Now, you know what will happen? Now, when the ventricle is completely relaxed, when the ventricle is absolutely relaxed, what happens is this valve, what is it valve? This mitral valve and the tricuspid valve, they will open. they will open, and all the blood from the atria, left atria and right atria is going to fall into the ventricles. Do you need any contraction for this? No. Simple opening of the valves, will let the blood from the atria into the ventricles. So this passive filling. So what is happening is opening of mitral valve and tricuspid valve. Okay, now this opening of these valves will also cause a sound called as opening snap, MCQ. Okay, all these are like, I'm just trying to integrate with the medicine. Now opening snap is because of, opening of mitral valve and tricuspid valve. Now questions which you need to know. Sir, what are the events which are happening during rapid ventricular filling? During the phase of rapid ventricular filling, ventricles are filling how much percent? 70% filling of the ventricles. Okay. See, after isovolumetric relaxation, what do we have? We are having a heart sound. What is that? Opening snap. See this line, opening snap. Once the valves are opened, after the opening snap, what do we have? Rapid ventricular filling. The rapid ventricular filling. Now, important MCQ which you need to know is, so when the blood suddenly falls from atria into ventricles, when the blood is falling from the atria into ventricles, in pathological conditions, not in a normal person, in pathological conditions, it will cause a heart sound which is S3. That falling of blood from atria into ventricles will cause S3 heart sound. In you and me, this S3 is not heard. Okay, it's very small sound. Okay, the decibels is very less, so you can't hear it. So see, during rapid ventricular filling also you are having the small sound. What is that? S3, sir, S3 heart sound, which is called as the ventricular gallop rhythm. Don't forget. What is atrial gallop rhythm? Have you see this S4? S4s are atrial gallop rhythm. Atrial gallop rhythm is due to the contraction of atria. During atrial systole, you will hear S4. But right now I am discussing about S3. Sir, S3 is heard during which phase? S3. Now tell me, S3 is heard during rapid ventricular filling. 70% of the ventricles are filling passively. Okay, 70% of the ventricles are filling passive. Now after this, what will happen? Very simple, guys. See here. After rapid ventricular filling, you need to know some important points. Ventricles are filled. 70% ventricles are filled. Now what should happen? Further 30% should fill. Further 30% should fill. That is, again atrial systole should happen. Okay, again atrial systole should have to happen. This is the phase of, see this one right now I am highlighting. This is the phase of atrial systole. But remember, after rapid ventricular filling, I have just highlighted this phase which in green color. What is this green color, sir? This green color is the phase of diastasis. Now, what is happening in diastasis? Nothing is happening. Heart is just still like this. No blood is moving, nothing. Just heart is still like this. Which means the heart is having least cardiac motility, least cardiac motion. Now even blood is also not circulating. So this phase is happening during diastole. So diastase is a phase of diastole where there is least cardiac motility. Diastase is the phase of least cardiac motility. So if you want to visualize the heart, what is the best phase? Atrial systole, isovolumetric contraction, rapid ejection phase, slow ejection phase, or isovolumetric relaxation, rapid ventricular filling, which phase? Diastasis. So diastasis is the phase of least cardiac motility. So it's the best phase to visualize the heart on echocardiography. Okay, echocardiography. Now see here, I'm just showing you the phases. Diastole. See, this is S2, and here is again S1. The phase between S2 and S1 is called as a diastole. All this S1 and S2 is systole. S2 and again S1 is diastole. In the diastole, how many phases are there? One by one. See, the first phase is protodiastole. After protodiastole, what do we have? Isovolumetric relaxation is there. After isovolumetric relaxation, there is rapid ventricular filling. After rapid ventricular filling, there is diastasis. Now, what will happen again? 70% of the ventricles are filled. Again, atria will contract. See, this is again this violet color thing. This phase is again atrial systole. Atrial systole will happen. That causes which heart sound? S4 heart sound. After S4, again you are having S1. Okay, so important point which I want you to know is there are 5 phases in diastole and 3 phases in systole. What are the 3 phases in systole? Isovolumetric contraction, rapid ejection phase, slow ejection phase. What are the 5 phases in diastole? Protodiastole, isovolumetric relaxation, rapid ventricular filling, diastasis, and atrial systole. Atrial systole is a phase of diastole. Don't forget. Okay, so these are the important points which I want you to know regarding the cardiac cycle. I hope I have cleared, I made the cardiac cycle as simple as possible. Actually, we can discuss the entire cardiac cycle for almost like 1.5 to 2 hours. But I made it like a very simple way. Okay, in a very simple way. Now just close your eyes and think. S4 heart sound is because of atrial systole. Okay, clear? Opening of aortic valve will cause which heart sound? Ejection click. Okay, opening of tricuspid valve and mitral valve. Okay, opening of tricuspid valve and mitral valve will cause opening snap. Okay, now before going to the exam, at least know the sequence. So first there will be S1. Start all the time. Start with the S1. Sir, S1 will be there. After S1, you are having isovolumetric contraction, rapid ejection phase, slow ejection phase. After that, you are having S2 heart sound. After S2, you are having protodiastole. After protodiastole, you are having isovolumetric relaxation. After isovolumetric relaxation, you are having opening snap, rapid ventricular filling. After rapid ventricular filling, there is diastasis. After diastasis, there is again atrial systole. S4 heart sound will be heard. Okay, done, sir. Now, direct questions which you need to know. In the entire medicine, you are having 3 low pitch heart sounds. Okay, 3 heart sounds are considered as a low pitch heart sounds. What are these 3 heart sounds? S3 heart sound, that's the ventricular gallop rhythm. S4 heart sound is the atrial gallop rhythm, and the tuber plop sound. Okay, this tuber plop sound is also considered as a low pitch heart sounds, which means you cannot hear these heart sounds with the diaphragm. Okay, you cannot hear these heart sounds with the diaphragm. You have to hear them with the bell side of step. Okay, bell side of the stethoscope. You can only hear these heart sounds from the bell side of the stethoscope. S3, S4 and tuber plop sound. Now you can ask me, sir, what exactly is this tuber plop sound and in which condition you will hear this tuber plop sound? See, this tuber plop sound is seen in a condition called as atrial myxoma. What exactly is this atrial myxoma means? Very simple. Let me show you. See, this is left atria. This is the septum, right? Intraatrial septum. From the intraatrial septum, now you are having a tumor, pedunculated tumor. Now this tumor will move, it will just hit to the mitral valve, it will hit the mitral valve and will cause a sound, it will cause a buzz. So it's called as a tuber plop sound, seen in which condition? Atrial myxoma, it's pedunculated tumor, it will move and it will cause a murmur. Okay, so atrial myxoma is most commonly seen in which side of the heart? It is most commonly seen in left side of the heart. Now when you will see this tuber plop sound, MCQ, a low pitch heart sound, whenever you hear this word, this is the key word. Whenever you hear this word, a low pitch heart sound heard after opening snap. What is opening snap? You already know. Opening of this valve, opening of mitral valve, opening of tricuspid valve will cause opening snap. So the low pitch heart sound which is coming after opening snap is tumor plop sound. So the patient is having atrial myxoma. So this tumor plop sound, when it is heard, it's heard after opening snaps. Okay, done, completed. Guys, is it clear? Yeah, sure, definitely I will do JVP. Definitely sure. Okay. Guys, shall I continue? Now, see, here I am showing you S1 and S2. Okay. So, what is the phase between S1 and S2? We all know this is the systole. And the phase between S2 and S1 again it is diastole. Now, here I have shown you a wave. What exactly is this wave? Is the murmur sound, abnormal sound. So, an abnormal murmur is heard continuously during the systole. So, what kind of murmur is this? So, this type of murmur is called as the pansystolic murmur. So, this type of murmur is called as a pansystolic murmur. A murmur heard during entire systole. Pansystolic murmur, or you can also call it as holosystolic murmur. In the exam, the kind of question that will come is, pansystolic murmur is seen in which condition? Or holosystolic murmur is seen in which condition? Okay, murmur is there continuously in the entire systole. Now, this pansystolic murmur is seen in 3 conditions, which is mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. Okay, it's very simple. See here, I'm not going in detail, but anyway, see, here is the mitral valve, here is the tricuspid valve. For example, if these valves are not closing properly, if those valves are not closing properly, both mitral valve as well as tricuspid valve. Now, during systole, during the ventricular contraction, okay, during the ventricular systole, what happens? Now, unnecessarily blood will jet back into the atria. Here also, the blood will jet back into the atria. So, will that cause a murmur or not? Abnormal sound or not? Yes, abnormal, definitely sound will be there. During when? During the entire systole. So, during the systole, during the contraction of ventricle, blood is ejecting back into the atria, creating a murmur, sir. This murmur is called as a pansystolic murmur or holosystolic murmur, seen in mitral regurgitation as well as tricuspid regurgitation. For example, imagine there is a defect over here. There is a small gap, a small tunnel is there. Now that is ventricular septal defect. This is a ventricular septum, there is a defect. So whenever ventricle is contracting, what happens? Blood is coming to the right side of the heart, because on the left side of the heart there is more pressure is there, right? Here the pressure will be 120 mmHg, but on the right side of the heart, the maximum pressure you can have is 25 mmHg. Okay, left side heart is having more pressures when compared to right side of the heart. So what happens? Blood will move to right side, right? Shifting will occur. So this will also cause a murmur during the entire systole. So again, holosystolic murmur can be heard in ventricular septal defect. So close your eyes and tell me just, holosystolic murmur or pansystolic murmur is seen in three conditions: tricuspid regurgitation, mitral regurgitation, as well as ventricular septal defect. That's it. Now let's continue with the other MCQ which you can get in your exam is, see, again there is a murmur which is heard during entire systole and also heard during entire diastole. So murmur which is continuously present, this type of murmur is called as a continuous murmur or machinery murmur. Okay, continuous murmur or machinery murmur. Can you tell me in which condition you will hear such kind of murmurs, continuous murmurs? Anyone? In which condition you will see this machinery murmur or continuous murmur? The answer is patent ductus arteriosus. Okay, see, patent ductus arteriosus means is very simple. Let me show you as simple as possible. I just don't want to waste the time. This is the left side of the heart, left ventricle, and this is the right ventricle. From the left ventricle, who is going to come out? From the left ventricle, aorta is going to come out. Okay, this blood vessel which I am showing is aorta. And from the right ventricle, who is going to come out? Pulmonary trunk. Pulmonary trunk is going to come out. Normally, during intrauterine life, okay, during intrauterine life, there is a connection which is present between, present between right ventricle and left ventricle. This is called as ductus arteriosus. Okay, after delivery, what happens is this ductus arteriosus is going to be completely collapsed. It is going to be completely obliterated. But if it is continuously open means, if it is open means, what happens? If it is open means, from the left side of the heart, blood is going to jet into the right side. From left side, the blood is coming into the pulmonary circulation. So will it cause murmur or not? Yes, it will cause murmur. Continuously, blood is coming from the left side into the right side. So this is called as continuous murmur or machinery murmur, which is seen in patent ductus arteriosus. Okay, this is very important, which you need to know. You can also have this kind of phonocardiograms in your exam. See here, I have already taught you. So what is this? S1, S2. What is the phase between S1 and S2? Systole. And what is the phase between S2 and again S1? Diastole. Now let's see the murmurs one by one. See, this is the murmur. Systolic murmur or diastolic murmur? The first murmur, systolic or diastolic? Definitely systolic murmur. Pansystolic murmur or holosystolic murmur? See, the pansystolic murmur or holosystolic murmur. Just try to recap, guys. Pansystolic murmur or holosystolic murmur is seen in which conditions? Mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. Okay. Now the second murmur which I have taught you, a murmur which is present in systole as well as a murmur which is present in diastole. Systole, diastole. This is continuous murmur or machinery-like murmur which is seen in patent ductus arteriosus. Now you guys can ask me, sir, here again there is one murmur which is also present in the systole. See, this is a pansystolic murmur, but the murmur intensity is a little different. Okay, please try to compare both of them. Here the murmur intensity is same from starting to end in the entire systole. The murmur intensity is same, but I am just teaching you one more murmur where intensity rises and again falls down. It's coming a diamond shape. So crescendo, decrescendo murmur. So the moment you hear about this word, crescendo, decrescendo murmur, in which type of heart conditions you will see crescendo, decrescendo murmur? It is seen in aortic stenosis. Aortic wall is stenosed. Okay, it's very simple. Even if you want to have the explanation, see, think this is the left ventricle, just left ventricle. Okay, now from the left ventricle, what is coming out? Aorta is coming out. Think that this is the aortic wall. Okay, think that this is the aortic wall, which is the stenosed. It's not completely open. It's not completely open. It's calcified. Now what happens? Now when the ventricle is contracting, blood will rush out. Okay, like zzz, zzz, something like this. So increase the intensity and decrease in the intensity. So blood is coming out like a jet via small orifice. Via small orifice, blood is ejecting out. Okay, so this is crescendo, decrescendo murmur. Something like this. Okay, via the small orifice, blood is ejecting out. So crescendo, decrescendo murmur is also, yes, it's a systolic murmur. It's a pansystolic murmur, but intensity increases, decreases. seen in aortic stenosis as well as hypertrophic obstructive cardiomyopathy. Put 10 star mark. This is very, very important. Crescendo decrescendo murmur. Crescendo decrescendo murmur is seen in which type of cardiomyopathy? Okay, I am not teaching the pathology. Crescendo decrescendo murmur is seen in which type of cardiac pathology? It is seen in hypertrophic obstructive cardiomyopathy where there is subvalvular aortic stenosis. In this condition also there is aortic stenosis. Okay, I hope I have discussed some of the important murmurs with you. Is it clear? Shall I continue? Guys, shall I continue? Is it clear? Shall I continue, guys? Am I going fast? Just tell me. If you feel like I'm going fast. Yeah. Some guy is asking about the regurgitation part. See, if you want to know, just know it. Now there is a murmur. Okay, here is a murmur which is seen during which phase? S2 and S1. This is the diastole, right? Between S2 and S1, this phase is called as the diastole. Now the murmur which is heard in the diastole, that is in the early diastole. Okay, this is the early diastole. The murmur is not there continuously. The murmur is there the early part. So this is early diastolic murmur. So that too, the murmur is decreasing in intensity. The murmur is decreasing in intensity. So this is diastolic decrescendo murmur. Diastolic decrescendo murmur, which is seen in aortic regurgitation or aortic insufficiency. Usually this is not needed for your exam. Okay, just forget it. If the person is suffering with aortic regurgitation, okay, what type of murmur you will hear is diastolic decrescendo murmur. Okay, if you want to know little about it, see like something like this. See, here is the aorta. Usually you are having aorta somewhere over here. Let me explain to you. Now, what is happening in aortic regurgitation? In aortic regurgitation, this valve is not properly getting closed. Aortic valve is not properly closed. When aortic valve is not properly closed, what happens? Blood is going to come back into the left ventricle. Blood is going to come back into the left ventricle. When, sir? When? During diastole, right? So, during diastole, the pressure inside the left ventricle is less. The pressure inside the left ventricle is less. The pressure inside the aorta is 80. So, what happens? The blood is going to come back, regurgitate back. So, what kind of murmur you will hear? Definitely, the kind of murmur you are hearing is diastolic murmur. Okay, diastolic murmur. That too, diastolic decrescendo murmur. Diastolic decrescendo. Okay, so completed. Now, just forget about it. Now, let's talk about a very important concept, which is the pressure volume loops. Okay, so pressure volume loops. Lot of times the question has been asked. Pressure volume loop. See here. If you have properly understand the cardiac cycle, this is very simple, very simple. All the time, let's start from here. Start from the point number A. Okay. See. Point number A is noting us here end systolic volume. End systolic volume. So, what exactly is this end systolic volume? Ventricle is contracted. Normally, in the ventricle, how much blood will be there? Guys, see, in the ventricle, almost 120 to 140 ml of blood will be there. Even after the contraction of ventricle, see, even after the contraction of ventricle, stroke volume is went out. Stroke volume is out. But even after the contraction of ventricle, some amount of blood is still present inside the ventricle. Some amount of blood is still present inside the ventricle. How much is that? Almost 50 ml, sir. Very, very important is the end systolic volume. Almost 50 ml of blood is still present inside the ventricle even after the contraction. Okay, so 50 ml, only 50 ml is there. Now, what should happen? This ventricle have to fill, right? Ventricles have to fill. Now, what is happening is ventricles are filling like this. How can we say ventricle is filling, sir? Because see this axis. Okay, this is the x-axis, right? Now, on x-axis, please see what we are having is the volume 40 ml, 60 ml, 80 ml, 100 ml, 120 ml. I have said you. So, what happens? Almost 120 ml of blood is going to be filled inside the ventricles. Okay, so 120 ml of blood is going to be filled inside the ventricles. So, what is happening from phase A to phase C? A to C, what is happening? Ventricles are filling from 50 ml to 120 ml. Okay, let me clear. Now, later what is happening, sir? On the y-axis, See here on the y-axis, what is there? Pressures are there. On the y-axis, what do we have? Pressures. Okay, 40 mmHg was 60, 80, 100, 120, 140. Now see, once you have 120 ml of blood inside your ventricle, what should happen? Ventricles have to contract. Now, when the ventricle is contracting, what happens? The pressure inside the ventricle will shoot up. The pressure inside the ventricle, now see, it is moving till 80. Only the pressure is increasing. Ventricles are contracting. Now, tell me what is happening from C to D. This is isovolumetric contraction. So, from phase C to D, don't worry, I have given every event here downside. From phase C to D, what is happening? This is isovolumetric contraction. Ventricles are contracting. Ventricles are generating a pressure of almost 81 mmHg. Okay, they are generating a pressure of 81 mmHg. Once they generate 81 mmHg, immediately what will happen? Which valve will be opened? Sir, aortic valve is going to be opened. Once aortic valve is opened, immediately what will happen? Rapid ejection phase is going to happen. Now see, blood is ejecting out, but still ventricle is contracting, right? And ventricle is generating how much pressure? 120 mmHg pressure, sir. Ventricle is generating 120 mmHg pressure. Okay, ventricle is generating 120 mmHg pressure. Now after that, what happens? After rapid ejection phase, now ventricular pressures are coming down. From 120 mmHg, the pressures are coming down to 80 mmHg. The pressures are coming down to 80 mmHg. But still the blood is ejecting. So this is slow ejection phase. Direct questions you will get in your exam. See, what is this phase? D to E. D to E is rapid ejection phase. What is the phase between E to F? It is slow ejection phase. Later on, what will happen? Now, see, rapid ejection phase completed, slow ejection phase completed. Now, what is happening? Ventricle is relaxing. Ventricle is relaxing. No blood is coming in, no blood is going out. Simply ventricle is relaxing. So this is isovolumetric relaxation. So see, the pressure inside the ventricle is coming down from 80. The pressure inside the ventricle is also coming down almost to 4-5 mmHg. Okay, so what is this phase? From F to A. From F to A, this is isovolumetric relaxation. Isovolumetric relaxation. Okay. Now, whenever your pressures inside the ventricle, are decreased, which valves are going to open? Ventricle is absolutely relaxed. So which valve will open now? Again, tricuspid valve and mitral valve, they will open. Okay, the mitral valve is going to be opened. Now, when mitral valve, see here, this is the place where when the pressure inside the ventricle, is coming down, mitral valve opens. Again, filling will happen. So this is left ventricular. I am talking about only the left ventricle. Left ventricular volumes and left ventricular pressure. The changes in the left ventricular volumes and left ventricular pressures we have seen here. Now, I will ask you some questions. You just tell me. In your exam, the kind of questions. Okay, let me just clean everything. Once this question was asked, they will ask you this phase. Okay, they will simply mark this phase. Okay, they will keep an arrow. So what is this phase? C to D. What is happening? There is no volume change. Volume is not changing. Only pressure is changing. So what is this? Isovolumetric contraction. Pressure inside the ventricle is. One more time the question was asked. Please see. They have kept an arrow over here. And they have asked which valve is going to open. What is this? This is the rapid ejection phase, slow ejection phase. Blood is ejected out. Okay, blood is ejected out. Now what will happen? Which valve closes? Aortic valve closes. Okay, when the pressure is coming below 80 mmHg, immediately aortic valve is going to be closed. Okay, so this is left ventricular pressure volume loops. All the phases here I have given in the PPT, in the PDF, whatever I am going to share with you. There you can have everything. Okay. Now after this, let's talk about the jugular venous pressures. Okay, JVPs, jugular venous pressure waveforms. Guys, to understand the jugular venous pressures, you need to know some basic points. Here is the right atria. Okay, right atria. Take it as a right atria. Whatever the pressure changes happens in right atria, those pressures are going to be transmitted into the internal jugular vein. How, sir? See here. Right atria is receiving blood from where? Superior vena cava. Now, superior vena cava is nothing but a combination of right brachiocephalic vein as well as this left brachiocephalic vein. This right brachiocephalic vein is a combination of right subclavian vein and internal jugular vein. So what I am saying here is, if you have any pressure change over here, that pressure changes are reflected in the internal jugular vein. Okay, you can see the changes in the pressure in the internal jugular vein. Any change in right atrial pressure will reflect as change in internal jugular vein pressure. For example, if right atrial pressure increases means internal jugular vein pressure increases. If right atrial pressure decreases means the pressure inside the internal jugular vein also decreases. So this is jugular venous waveforms. According to the changes in the right atrial pressure, the pressures in the internal jugular veins also will vary. Now let's see what are the waves. A wave. First of all, see what are the waves which are coming in jugular venous pressure, JVPs. A wave, C wave, X wave, V wave and Y wave. Now, what are these waves? Why there is pressure changing? For example, see, you can clearly see this A wave, the pressure is increasing, and here in C wave again little increase in pressure. In X wave, the pressure is going down. The atrial pressure is going down, right atrial pressure is going down, and the internal jugular vein pressure is also going down. Now, why this will happen? Let's see one by one. Okay, let's see one by one. Now, what is the first event, guys? In a cardiac cycle, let's take what is the first event? Atrial systole, right? Atria are contracting. When right atria contracts, all the time I am talking about right atria only, not left atria. Right now I am talking about right atria. Right atria is contracting. Will pressure inside right atria increases or not? Yes, sir. First, pressure inside the right atria increases, as well as the pressure inside the internal jugular vein increases. So, A wave, see, it's a positive wave. A wave is because of right atrial contraction. Okay, the pressure is increasing the internal jugular vein. So, A wave is right atrial contraction. A for atrial contraction. After this, atria relaxing. The pressure inside the atria will come down. The pressure inside the jugular veins also come down. So, pressure is falling down. The next wave, what is this next wave? This is the C wave. Little elevation in the pressure. Why little elevation in the pressure? The C wave is because of the ventricular contraction. Ventricles contract. Okay, the ventricles contract. Now, whenever the ventricle is contracting, the tricuspid valve, see, just let me show you. This is the tricuspid valve. When ventricle is contracting, the tricuspid valve bulges into the right atria. Okay, the tricuspid valve bulges into the right atria. So, what happens is, there is increase in the pressure inside the right atria. So, that increase in the pressure will also reflect as increase in the pressure in the internal jugular vein. So, first there is A wave, later there is C wave. Okay, now what will happen? Later, you are having X wave. X wave is a negative wave. Okay, the pressure in the atria is going down. The pressure inside the internal jugular veins is going down. Why? Why? It's very simple. Ventricle is relaxing, heart is relaxing. When ventricle is relaxing, see, okay, when ventricle is relaxing, again the tricuspid valve, whatever have gone into the atria, it's coming down. So what happens is, right atrial pressure decreases, internal jugular vein pressure decreases. So X for relaxation, ventricular relaxation, decreases the pressure inside the atria also. So remember it like this: A for atrial contraction, C for isovolumetric contraction of ventricles, and X for atrial relaxation. Now later what happens? Later you are having this V wave, again positive wave. Now why there is this V wave? V for venous filling. Atria will receive the blood, right? All the venous blood again should have to come into the right atria. Blood is coming into the right atria. Right atria is filling with the blood. When right atria is filling with the blood, automatically pressure inside the atria will increase. So V wave is because of the venous filling. Okay, V wave is because of the venous filling. It's a positive wave. And Y wave, again from the atria, blood is going to fall down into the ventricles. From the atria, blood is going to fall down into the ventricles. That is atrial emptying. Pressure inside the right atria decreases, internal jugular vein pressure decreases. Now, very simple. Sir, how many positive waves do we have? The positive waves, there are three important positive waves we have here. Are these waves. First wave is A wave due to atrial contraction. C wave is due to isovolumetric contraction of ventricles. Pressure increases in the right atria, pressure increases in the internal jugular veins. And V wave is because of the venous filling. Atria are filling with the venous blood. So pressure inside the right atria increases, pressure inside the internal jugular vein increases. So A wave, C wave and V wave are the positive waves. What are negative waves? Negative waves in the sense, the internal jugular pressure going down, internal jugular vein pressure going down, right atrial pressure is going down. Why? Why the pressure inside the right atria is going down? It's because ventricular relaxation. Ventricles are relaxing. Tricuspid valve is going down. So atrial volume also increases, pressure inside the atria will come down. Okay, and why there is this Y wave? Y wave is because of atrial emptying. Atria are emptying blood into the ventricles. When blood goes from atria into the ventricles, okay, so automatically pressure inside the atria will go down. So automatically jugular venous pressure will also go down. A wave, C wave, V wave, and X wave and Y wave. Okay, these are the waves which you need to know. Important MCQs, especially from the patho point of view. In which conditions A waves are absent? A waves are absent in atrial fibrillation. So what exactly is atrial fibrillation? First of all, in atrial fibrillation, atria are not contracting. Atria are just like shivering like this. Atria are shivering like this. So whenever there is no atrial contraction, there is no A wave. Here, the A wave is because of the atrial contraction. Pressure increase in the jugular veins. In the condition of atrial fibrillation, there is no atrial contraction, so no A waves are seen. They will use you. Okay, they will use these terms. Just I'm not going to explanation because if I'm going to explanation, it's taking a lot of time. I will go a little fast from now. Okay, so large A waves. Large A waves are seen in which condition? Normal A wave, you know it. If you have a large A wave, okay, large A waves are seen in pulmonary hypertension. Direct question. Pulmonary hypertension and pulmonary stenosis. In the conditions of pulmonary hypertension and pulmonary stenosis, you are going to have large A waves. These are abnormal things. Okay. In which conditions you will see Canon A waves. The moment you hear about this word Canon A waves, the Canon A waves are seen in complete heart block. Guys, have you able to recollect complete heart block? That is AV dissociation. The number of P waves and the number of QRS complexes are not matching. So in Canon A waves are seen in complete heart block, guys. Okay, complete heart blocks, at least that one thing you need to know. And large V waves. Okay, large V waves are seen in tricuspid regurgitation. Just try to by heart them. Okay, if I go into explanation, like actually these are all patho related topics, I just don't want to go into the explanation part. Absent A waves, atrial fibrillation. Large A waves are seen in pulmonary hypertension or pulmonary stenosis. Canon A waves are seen in complete heart block, and large V waves are seen in tricuspid regurgitation. Now, very important MCQ which I want you to know is this one MCQ we kept on asking in the FMGE exam. Give me 1 second. Normally, what happens to the JVP during inspiration? Okay, for example, right now I am inspiring. What happens whenever I am inspiring? What happened to my thoracic volume? Thoracic volume increases, so automatically the pressures inside the thorax will fall down. Right atrial pressure fall down, jugular venous pressure fall down. So during inspiration, normally JVP decreases. Okay, JVP is going to decrease during inspiration. This is something normal, very important. But what happens if JVP increases? Okay, what do you call this? With inspiration, if jugular venous pressure increases, means that is known as Kusumal sign. So Kusumal sign is increase in JVP with inspiration. In which condition? Very important. It is seen in a pathological condition called as constrictive pericarditis. In the condition of constrictive pericarditis, we will have Kusumal sign. What is Kusumal sign? JVP is increased during inspiration. It was supposed to be decreased, but it is increased. Okay. Now, after this, JVP concept also completed. Okay. How many waves are there? A, C, X, V, Y. I have given you A for atrial systole, V for, it's already like I have already explained, right? So you just try to by heart. Now after this, let's talk about the concepts of BP regulation. What you need to know. So there is something called as a baroreceptor reflex. All the time your BP is getting monitored. Your BP is being monitored with the help of baroreceptors. Now where do we have these baroreceptors? Baroreceptors are present in carotid sinus as well as aortic sinus. Okay, in the carotid sinus and in the aortic sinus. Okay, aortic arch, I will show you, don't worry. See here, this is something called as aortic body or aortic sinus. Sorry, it's not aortic sinus, it's a carotid sinus, right? Here is the carotid sinus, this is the carotid body or carotid sinus, and this is arch of aorta. Okay, here is the arch of aorta. These are the places where the baroreceptors are present. What exactly are these baroreceptors? They are all the time monitoring the BP, your BP and my BP. All the time these baroreceptors are checking whether the BP is normal or not. Okay, so now where are these baroreceptors present, sir? MCQ. Baroreceptors are present in two places. One is carotid sinus as well as aortic arch. Now from these baroreceptors, information have to go into the central nervous system, right? Central nervous system have to get the information. So what are the afferent fibers? Information is going to the central nervous system via which cranial nerves? 9th cranial nerve and 10th cranial nerve. Please look at here. See, from the carotid body, 9th cranial nerve, which is called as the herring nerve, MCQ. So from the 9th cranial nerve, information is going to where? The nervous system. Okay, all the information about the BP is going to the central nervous system. From the aortic arch, information about the BP is going to the central nervous system. The name of this nerve is called as the Science nerve. Okay, here this is Herring's nerve and this is Science nerve. 9th cranial nerve and 10th cranial nerve. So Herring's nerve and Science nerve, these are the afferents to the central nervous system which are taking the information about the BP. Now all this information is going where? The medulla oblongata. Who is sitting in the medulla oblongata? Nucleus of tractus solitarius. So nucleus of tractus solitarius is the center. So in the baroreceptor reflex, who is the center? The nucleus of tractus solitarius. Okay. Now, if there is any fluctuation in the BP, the nucleus of tractus solitarius will regulate the BP. For example, BP is going up. What will happen? Now, this nucleus of tractus solitarius will inhibit the sympathetic nervous system, stimulate the parasympathetic nervous system, so it will decrease the heart rate. We'll discuss one by one, don't worry. See, baroreceptors, they are all the time sensitive to BP, right? Our BP. Which BP is systolic BP or diastolic BP? No. These baroreceptors are sensitive to mean arterial pressure. This was the MCQ which was asked. Not the systolic BP or not the diastolic BP. The baroreceptors which are present in the carotid body as well as the aortic arch, they are sensitive to mean arterial pressure. Now, what exactly is the formula for mean arterial pressure? Mean arterial pressure is equal to, sir, diastolic blood pressure plus 1/3 of the pulse pressure. Very, very important. We all know what is the diastolic blood pressure. Normal diastolic blood pressure is 80. Now, students will get confused here. What exactly is pulse pressure, sir? Sir, pulse pressure means systolic BP minus diastolic BP. What is the systolic blood pressure? 120. What is the diastolic blood pressure? 80. So 120 minus 80 is how much? 40. So 40 divided by 3. See, I have shown here 1/3 of the pulse pressure. Normal pulse pressure is 40. Normal pulse pressure is the difference between systolic as well as diastolic blood pressure. Systolic 120 minus 80. So how much? 40. So pulse pressure is 40 divided by 3. How much will get? 13. So pulse pressure is 1/3 of the pulse pressure is 13. So see here 80 plus 13 is 93. So in you and me, what is our mean arterial pressure? Map. Mean arterial pressure in you and me is 93. The average. Very simple. Try to understand like this. Sir, what is your BP? If someone comes to me and asks me what is BP, I will say during systole it is 120, during diastole it is 80. The person will be like, no, little irritated. Don't tell me so many values. Tell me one value, average value. That is mean arterial pressure. Mean arterial pressure in you and me is somewhere around 93. The formula for mean arterial pressure is diastolic blood pressure plus 1/3 of the pulse pressure. Okay. So diastolic blood pressure plus 1/3 of the pulse pressure. Okay. For example, how is baroreceptor reflex works? For example, by any reason, if your BP is increasing, you are seeing like something which you don't like, your BP is increasing. Now, whenever BP is increasing, via the Science nerve, via the Herring's nerve, the information is going to the nucleus of tractus solitarius. Now, what this nucleus of tractus solitarius will do? Now, the nucleus of tractus solitarius will inhibit the parasympathetic nervous system. It will inhibit the parasympathetic nervous activity. It will stimulate the, it will inhibit the sympathetic nervous system. It will inhibit the sympathetic nervous system. It will stimulate the parasympathetic nervous system. When parasympathetic nervous system is stimulated, what happened to heart rate? Heart rate comes down. Heart rate comes down. So, if you increase the BP, the center nucleus of tractus solitarius, it will stimulate the parasympathetic nervous system and inhibit the sympathetic nervous system and decreases the heart rate. So, in a healthy individual, if you increase the BP, there will be reflex decrease in heart rate. So, this law is called as Mary's law. Put 10 star marks. That much important. Okay. So, what exactly is Mary's law? Mary's law means if you increase the BP, there is a reflex decrease in heart rate in healthy individuals. Increase the BP, heart rate decreases. This is Mary's law. Guys, I know I am discussing a lot of points because at the end of the day, after the exam, you should come back, you should feel like, I have attended the class, all my questions are done. Okay, I can simply say like, 3-4 important points, like, 3-4 important concepts I can leave. But all these are previously asked concepts. Okay, so don't worry, like cardiovascular system and respiratory, they are big. Okay, central nervous system we can do. After that, we'll go like very fast. So Mary's law is, what exactly is Mary's law? What exactly is Mary's law? If you increase the BP, automatically there is reflex decrease in heart rate. Now after that, let's talk about a concept called as clamping of the carotid sinus. Okay, clamping of the carotid sinus. See, this is common carotid artery. We all know this is common carotid artery. Now this common carotid artery is going to bifurcate into external carotid artery and internal carotid artery. Okay, now before the bifurcation point, here we are having carotid sinus. We have discussed, right? In the carotid sinus, there are baroreceptors. In the aortic arch, there are baroreceptors. Now these fellows, which I am just highlighting here, these are the baroreceptors. Now what I am doing is, okay, I'm just playing. What I am doing is, I'm just clamping the carotid sinus. Okay, clamping. Where I'm clamping, I just put a clamp here above the carotid sinus. Whenever you put a clamp, okay, whenever you put a knot here, what will happen? Blood is coming and accumulating here. Okay, blood is not going forward. Blood is accumulating over there. Now, lots of blood is coming there and accumulating there. So, what happened to the pressure in that area? Pressure increases, BP increases. So, these ninth cranial nerve is taking the information to the nucleus of fractal solitary that BP is increasing. Okay, giving the information that BP is increased, BP is increased. So, whenever you clamp the carotid sinus above, what happened to the heart rate? Heart rate decreases. This is Mary's law, right? Whenever you increase the BP, actually here I haven't actually increased the BP. At that particular place, artificially I have increased the BP by clamping the carotid sinus above. So this causes the decrease in heart rate. This we have already studied in the Mary's law. The heart rate is decreased. Now, what happens if you clamp below the carotid sinus? See, here you are clamping below the carotid sinus. Whenever you clamp below the carotid sinus, no blood is coming here. So what happens here? The BP here, the BP is decreased in this particular point. So ninth cranial nerve is taking the information that BP is decreased. So whenever your BP is decreased, automatically heart rate increases. Okay, inverse relationship. So what happened to heart rate? Heart rate is increased. You need to know. Clamping below and clamping above. Clamping below and clamping above. Now, what is the procedure which was shown in this image? Okay, what is the procedure which was shown in this image? Come on, guys. Carotid pulse? No. Actually, the person like doing like this. Okay, this is carotid sinus massage. Okay, carotid sinus massage. Now, whenever you do, okay, yes, excellent, deep. You are true. Okay, excellent, Ganesh Reddy, you are true. This is a carotid sinus massage. Very important image-based question. Now, whenever you do carotid sinus massage, what happens to your heart rate? Okay, whenever you do something like this, what happens to your heart rate? See, you are actually compressing the carotid sinus. Whenever you are causing vasoconstriction, whenever you are compressing the carotid sinus, what happened to the pressure inside the carotid sinus? Pressure increases, BP increases. Your central nervous system is thinking, your central nervous system is receiving the information that BP is increasing. So what your central nervous system will do? Will try to decrease your heart rate. So whenever you do carotid sinus massage, what happened to your heart rate? Your heart rate is decreased. MCQ. So upon doing the carotid sinus massage, your heart rate decreases. Clamping above, clamping below, carotid sinus massage. 3 important points which you need to know for your exam. Now after this, let's talk about some important laws and principles in cardiology. Laws and principles. The first law which is important for your exam is Frank-Starling law. Okay, what exactly is Frank-Starling law? Frank-Starling law says end diastolic volume is directly proportional to the stroke volume. What exactly is end diastolic volume? We know. Sir, what is the end diastolic volume? 120 to 140 mmHg. Not mmHg, sorry. 120 ml to 140 ml. 120 to 140 ml. Okay, end diastolic, at the end of the diastole. How much blood is going to be there inside the ventricle? At the end of the diastole, before contracting, 120 to 140 ml of blood is there. Okay, 120 to 140 ml of blood is there. Usually, out of which 70 to 90 ml will come out as in the form of stroke volume. 70 ml will come out. Okay, important point, guys. See, what Frank-Starling law says is more you put, heart is going to eject more. You put more blood, heart will contract more powerfully to eject the blood. Let's try to understand like this. For example, you put 120. Think like this. You put 120. Now heart is ejecting 70 ml blood. With one beat, heart is ejecting 70 ml blood. For example, you keep now 150. 150. End diastolic volume, think it as 150. Now heart will eject 90 ml. Keep here 190. Now heart will contract and eject 120 or 130. So more you load, more powerfully the heart will contract and more will be the stroke volume. In a physiological limits, in a normal physiological limits. So this is called as Frank-Starling law. So Frank-Starling law says end diastolic volume is directly proportional to the stroke volume. Or preload. This end diastolic volume is also called as a preload. Okay, end diastolic volume is nothing but preload. More you put, more powerfully the the heart will stretch, and more powerfully the heart will contract, and more will be ejected out. Okay, this is Frank Starling's law. End-diastolic volume is directly proportional to stroke volume. Next, what exactly is fixed principle? Okay, it's a fixed principle. I letter is very important. Okay, don't miss the I letter. It will become totally different principle. So, what exactly is fixed principles? Fixed principle is estimation of cardiac output by the rate of oxygen consumption. Okay. Okay, fixed principle. It's estimation of cardiac output by the rate of oxygen consumption. See, if you ask me, how good I am, or you just I just want to know. For example, think like this. I just want to know how good you study. I just want to know how good you study. So, what is the parameter? I will just take your mark sheet, okay, the progress card, whatever. I will just look at your marks. So, by looking at your marks, I can know how good you study. Okay, of course, this is not true, but anyway, by looking at the marks, I can say how good you study. In the same way, we know what is the cardiac output. The cardiac output is 5 liters. Everyone knows. But by looking at the amount of oxygen consumption, we can actually calculate how much is the cardiac output. So, what is the formula? See, Q is equal to, Q means cardiac output. Okay, cardiac output is equal to amount of oxygen consumed. Okay, we have kept a cylinder, and the person is breathing through the cylinder. So, VO2 means volume of oxygen consumed by arteriovenous difference. Okay, arteriovenous oxygen difference. So, what is the amount of oxygen present in the arteries? What is the amount of oxygen present in the veins? The difference between arterial and venous oxygen difference. Now, see, usually a person every minute will consume 250 ml of oxygen. 250 ml of oxygen a person will consume. And the arterial blood, here I am showing you arterial blood is having almost 200 ml of oxygen per liter. Per liter I am talking. Arterial blood, if you take 1 liter of arterial blood, in that 1 liter of arterial blood there is 200 ml of oxygen. In the venous blood, there is almost 150 ml. There is 150 ml of oxygen per liter. Now just tell me what is the difference? In venous blood also there is oxygen, and in arterial blood also there is oxygen. The difference is 200 minus 150 is 50. So 50 here and 250. So 250 divided by 50 is how much? 5 liters. So what do we get at the end of the day? We have made a lot of mess for calculating the cardiac output. So we all know cardiac output is 5 liters. But if you want to calculate it by looking at the amount of oxygen consumption, this is the formula. The amount of oxygen consumed by the arteriovenous oxygen difference. The fixed principle is knowing about the cardiac output by looking at the oxygen consumption. Frank-Starling law is end-diastolic volume is directly proportional to the stroke volume. Now after this, let's talk about the cardiac reflexes which were asked in the exam. Cardiac reflexes. Now the first reflex which I am talking is Cushing reflex. Okay, Cushing reflex. So what exactly is Cushing reflex? Cushing reflex is actually a bradycardiac reflex. Cushing reflex is bradycardiac reflex. What exactly is this? Whenever the person is having head trauma, okay, there is a bang on the head. What happens whenever there is head trauma? The intracranial pressure increases. Whenever there is increase in the intracranial pressure, what happens? Whenever there is increase in the intracranial pressure, sir, which cranial nerve will be activated? 10th cranial nerve. There is a vagus nerve will be activated. When the vagus nerve is activated, what happens? Parasympathetic nervous system is activated. So heart rate comes down. So Cushing reflex is seen in head trauma patients. Whenever there is head trauma, because of the hemorrhage, intracranial hemorrhage, the intracranial pressure increases, vagus nerve is activated, and heart rate comes down. So just answer this one point. Cushing reflex is an example of bradycardic reflex. Now after this, the second reflex is Bezold-Jaris reflex or Bezold-Jaris reflex. Okay, Bezold-Jaris reflex. Now what is this Bezold-Jaris reflex? Heart rate increases or decreases? This is also an example of bradycardic reflex. Even in this condition also, heart rate comes down. Example of bradycardic reflex. Heart rate is coming down. Now, what is happening in this Bezold-Jaris reflex? See, serotonin and capsaicin. These are the chemicals. For example, take like this. Understand like this. Whenever your heart is damaged, myocardial infarction is there. Now, whenever your myocardial infarction is there, now from the infarcted tissue, serotonin and capsaicin, these chemicals are getting released. Now, tell me, in this condition, when your heart is getting a problem, in this condition, your heart have to work more or your heart have to work less? Your heart have to work less. Your heart rate should have to come down. What happens is these chemicals, serotonin and capsaicin, they will stimulate the vagal C fibers. Okay. Now, why are the vagal C fibers? See, from the heart via the vagal C fibers, information is going to the nucleus of tractus solitarius. Nucleus of tractus solitarius will inhibit the sympathetic nervous system, stimulate the parasympathetic nervous system, heart rate comes down. The simple point is, what I want you to know is, sir, basal gyrus reflex is because of which chemicals? Serotonin, capsaicin. It's a bradycardiac reflex seen in infarcted tissues or post MI. Information is taken to the central nervous system. Information, these serotonin and capsaicin stimulates which fibers? The vagal C fibers. Vagal C fibers. Okay. Yeah. Now, last reflex is the Bainbridge reflex. Bainbridge reflex. This Bainbridge reflex is also called as atrial reflex. It's also called as the atrial reflex. Now, why we are calling it as the atrial reflex? Why? Because this reflex is mediated by the atria. Simple. Whenever you stretch the atria, think like this. Whenever you stretch the atria, whenever you stretching the atria, usually when atria will be stretched, whenever more blood is coming to the atria, atria will be stretched. Whenever there is more volume in your body, atria will be stretched. So, whenever you are having more volume in your body, just tell me, heart have to work more or heart have to work less? Definitely, whenever you are having more volume of blood, heart have to work more, right? More, right? So, whenever you stretch the atria, especially the right atria, now immediately heart rate will be increased. Simply atria is understanding, oh my god, there is more volume of blood. So, heart rate should have to increase. So, Bainbridge reflex is a tachycardiac reflex. Okay, heart rate increases. So what is happening? Whenever you put more blood into the right atria, heart rate increases. So this is Bainbridge reflex. Okay, it's also called as the atrial reflex. Done. Okay, all these important points are done, guys. Charging. Charge this. Now, after this, 2-3 important MCQs were there. See here, in the vascular physiology, the cardiac physiology is completed. Now, in the vascular physiology, 2-3 important MCQs which were kept on asking in the exam. Now, which blood vessels are having wind Kessel effect? Aorta is having wind Kessel effect. What is wind Kessel effect? Elastic recoiling. So, elastic recoiling is called as the wind Kessel effect. Aorta is contracting. Okay, when heart contracts, blood is going to come into the aorta. So, aorta will be stretched, and this aorta will again recoil back, collapse back, pushes the blood forward. So, wind Kessel effect is elastic recoil of the aorta. Okay, wind Kessel effect is seen in aorta. Done. Now, after this, let's talk about the velocity of blood flow and the cross-sectional area. In which blood vessels? See, we are having aorta, arteries, arterioles, capillaries, venules, veins, vena cava. We are having lot of blood vessels. Important point is, which blood vessels are having maximum velocity of blood and which blood vessels are having least velocity of blood? Slow blood flow. See, the formula is velocity is inversely proportional to the cross-sectional area. Which blood vessels are having more cross-sectional area? Just think logically and tell me. Sir, you are having millions and millions of capillaries. You are having millions and millions of capillaries, but you are only having one aorta. So, more cross-sectional area is seen in the capillaries. Least cross-sectional area is seen in the aorta. So, according to our formula, just tell me, where will be the maximum velocity of blood? So, wherever there is maximum cross-sectional area, there the velocity is going to be lesser. So, now based on that, see, aorta is having lesser cross-sectional area. So, it's having maximum velocity. Blood is ejecting like jet in the aorta. Very fastly blood is moving. Now, in the capillaries, what happens? In the capillaries, the cross-sectional area is more. There is more cross-sectional area. When the more cross-sectional area is there you will have minimum velocity, and this minimum velocity is very good, right? In capillaries, you are having least velocity. Now, whenever there is least velocity, good amount of exchange will happen. So, in capillaries, there is minimum velocities. After that, important direct single liners which you need to know. Sir, arterioles. After arteries, what do you have? Arterioles. Important point about arterioles. Lots of times the question was asked. Arterioles are having maximum smooth muscles, sir. Which blood vessels are having maximum smooth muscles? Which vasculature is having maximum smooth muscles? Arterioles. As they are having maximum smooth muscles, they can contract and relax. So they are called as the resistant blood vessels. Resistance blood vessels. If they contract, what happens? There is increased resistance to the blood flow. If they dilate, there is decreased resistance. So, important point is, arterioles are the blood vessels which are having maximum smooth muscles. So, they are having maximum vascular resistance. Okay, peripheral vascular resistance is maximum for arterioles. They contract, vascular resistance is increased. Direct question. Peripheral vascular resistance is maximum for arterioles. Okay, and last formula which you need to know is Poisson-Huygens formula. What exactly is this Poisson-Huygens formula? Poisson-Huygens formula is talking about the relationship between the blood flow. Okay, the relationship between the blood flow and different parameters. Okay, different parameters. Blood flow is directly proportional to the pressure difference between the blood vessel. For example, see, let's take it as a blood vessel. Blood flow is going to be directly proportional to the pressure difference. Okay, this point and this point, point number A and point number B. There is more pressure difference, more blood flow is going. Okay, if there is more pressure difference, more blood flow is going to be there. And radius. If, for example, if blood vessel radius increases means, if blood vessel dilates means, more blood flow will be there. So, blood flow is directly proportional to the pressure difference across the blood vessel, the two different points. And blood flow is directly proportional to the radius of the blood vessel. And blood flow is inversely proportional to, see, very, very important. The blood flow is inversely proportional to length. If the length of the blood vessel increases means, blood flow through that blood vessel decreases. More blood vessel means more surface area. More surface area means more resistance will be seen. Okay, more resistance will be seen. And viscosity. If a fluid is more viscous means the viscous fluid is going to flow very slowly. Blood flow is going to be very, very slow. So, blood flow is inversely proportional to length, inversely proportional to viscosity. Based on this, every time the kind of question that will kept on coming in your exam is, what happens if radius is double? If radius doubles, we all know if radius doubles means blood flow will also be increased. How many times? Not a direct relationship. Blood flow is directly proportional to the r to the power of 4 times. Now, what we are doing is we are doubling the radius. Okay, we are doubling the radius. So, what happened to blood flow? See, blood flow is directly proportional to the r to the power of 4. In the place of r, we are doubling, right? We kept 2 here. So, 2 into 2 into 2 into 2. 2 2s 4, 4 2s 8, 8 2 16. So, blood flow increases by 16 times. Blood flow increases by 16 times. If you double the radius, blood flow is not going to be double. Blood flow is not going to be increased by 2 times. Blood flow increases by 16 times. Okay, with this, I have discussed all the important concepts from the cardiology. Okay, all the important concepts from the cardiology is done. Okay, I know I took a lot of time, but after the exam, you come back to the video and check. All the questions will be from this rapid revision. Okay, all the questions, I can assure you, all the questions are going to be coming from this rapid revision, guys. My phone got switched off. I'm just starting it back. If you have any questions, you just ask in the chat box. Shall I continue, guys? Guys, shall I continue? It's even good for NEET PG exam. You can write the NEET PG exam also. I am 100% sure. Okay, I am not here just to time pass, like, usually coming here, like, just for the name's sake, like, no, I am discussing all the important concepts which were come in the previous exam. All question banks I am doing. If you just go through this, it's enough. 100%. Okay, so shall I continue with the respiratory physiology? In the next 40 minutes, 45 minutes, we will do the respiratory physiology. Okay, now chilo. Now, in the respiratory physiology, first let's start with the Weibel's airway generations. Okay, what exactly is this Weibel's airway generation? The entire respiratory tract was divided into small segments. Now, how many Weibel's airway generations are there? 23 Weibel's airway generations are there. There are 22 parts, 23 segments are there. The first generation, called as generation 0. Trachea is generation 0. Okay, see, trachea is generation 0, the first point. Okay, and the alveoli. Okay, alveoli, the last fellow, the alveoli are coming under generation 23. The alveoli are coming under generation 23 and trachea is generation 0. Important point which I want you to know is, sir, the first 16 generation up to here, okay, the first 16 generations, they are called as the conducting zone. Okay, so the first 16 generations are called as the conducting zone. See here, conducting airways. Now, why the hell do we call them as conducting areas? Because there is no gases exchange, there is only conduction. They are just there is no gases exchange, simply gas is going like this. Okay, air is going down like this, no gases exchange. So this area is called as a dead space. This area is called as a dead space. And how much this area, what is the volume of this conducting zone? The volume of this conducting zone is 150 ml. Okay, the volume of this conducting zone is 150 ml. Now the conducting zone ends with, see, the conducting zone ends with which bronchioles? Terminal bronchioles. Please concentrate here. Terminal bronchioles, don't forget about this transitional bronchioles. Transitional bronchioles are not that important. Terminal bronchioles are the last part of conducting zone, important. Okay, so conducting zone ends with terminal bronchioles. Just like, see, just try to recollect. In the cardiovascular system, in the vascular physiology, I have taught you which blood vessels are having maximum smooth vessels. The maximum smooth vessels are there for arterioles. They are the ones maintaining the total peripheral vascular resistance. In the same way, in the entire respiratory tree, which bronchioles are having maximum smooth vessels? So the maximum smooth vessels are seen in terminal bronchioles. Okay, after that, let's talk about the respiratory zone. Respiratory zone. Why we are calling it as a respiratory zone? Why? Because see, down all these areas, gases exchange is happening, oxygen exchange, carbon dioxide exchange is happening. Now, what are the segments which are coming under this respiratory zone? Respiratory bronchioles, alveolar ducts, and alveolar sacs. Respiratory bronchioles, alveolar ducts, and alveolar sacs are all coming under this respiratory zone. Okay, which are called as SCNS. Okay, which are called as SCNS. So SCNS includes respiratory bronchioles, alveolar ducts, as well as alveolar sacs. Now, let's talk about a few important points. The conducting zone, the first one, first 16 generation, the conducting zone. The conducting zone is lined by pseudostratified ciliated columnar epithelium. The lining epithelium is pseudostratified ciliated columnar. Important, cilia are there. Those cilia will take out all the mucus, will take out all the dust particles with the help of mucociliary exhalatory phenomena. All the mucus is going to be removed from the conducting zone. All the dust particles are removed. So, conducting zone is lined by pseudostratified ciliated columnar epithelium. And in this conducting zone, there are two important stem cells are present. The two important stem cells which are present in this conducting zone are basal cells and Clara cells. MCQ. Basal cells and Clara cells are the stem cells. Yeah. Now let's come to the respiratory zone. Now respiratory zone, gases exchange is there. Now for gases exchange, you need to have a very thin membrane. You need to have. So what is the lining epithelium? It's a simple squamous epithelium, sir. The epithelium is simple squamous epithelium. And here also you are having certain type of stem cells. Here also we are having certain type of stem cells. The stem cells which are present in the respiratory zone are type 2 pneumocytes. So in total, how many stem cells are there in the respiratory tree? There are basal cells. Here, please look at here. There are basal cells, Clara cells, and type 2 pneumocytes. Basal cells and Clara cells are present in the conducting zone. Type 2 pneumocytes are present in the respiratory zone. Done. Guys, I have taught you in the conducting zone there are cilia, right? There are cilia. The cilia will beat. They will take out the mucus. They will take out the dust particles. There are two important disorders where the cilia are not beating. They are immotile cilia. The cilia are not beating. Two important diseases which you need to know for your exam is the first ciliary disorder is Cartaginer syndrome. Okay, the first ciliary disorder is Cartaginer syndrome. Now, what is the problem in the Cartaginer syndrome? See, here I am showing you the cross section of the cilia. Cross section of the cilia. Now, here, are you able to appreciate these arms? These arms are in the central. You are having all these are the microtubules. Okay, these are the doublets of microtubules which you are having. When the cilia are beating, actually these dynein arms are very much important for the beating of cilia. These dynein arms. Okay, dynein, made up of dynein protein. Now in our Cartaginer syndrome, what is the problem is defective in the dynein protein. The dynein arms are defective. Now do you think now the cilia will beat? No, cilia will not beat. Okay, so whenever the cilia is not beating, what happens? Mucus will accumulate inside the respiratory tract. Mucus plugging will happen. Infections will start causing bronchiectasis. Bronchiectasis is infection, right? So bronchiectasis. Okay, bronchiectasis will happen. Okay, why we are discussing about the Cartaginer syndrome means it because it affects the lungs. It causes bronchiectasis, infection inside the lungs. Okay. So in Cartaginer syndrome, the triad is very, very important. If I am the patient who is having Cartaginer syndrome, I will suffer with a triad of symptoms, that is bronchiectasis, sinusitis. Even in the sinuses, all the time discharge is there, all the time that mucus need to be cleared. Now in Cartaginer syndrome, cilia are not beating, dynein arms are not there, they are not beating. So mucus plugging will cause inflammation inside the sinuses, causing sinusitis and situs invertus. Remember, during the embryonic stages. During embryonic stages, actually the heart was more towards the right side. Okay, the apex of the heart was more towards the right side. Even the heart was surrounded by the cilia because of the ciliary movement. Because of the ciliary movement, the heart was shifted towards the left side. Okay, so actually you are having dextrocardia, right side of the heart. But because of the ciliary beating, the heart will be shifted, the apex of the heart will be now shifted towards the left side. Now in Cardiovascular syndrome, what happens? Cilia are not beating. So now in this patient, heart was still present towards the right side. So that is dextrocardia or situs invertus, means the organs are placed in the opposite side, invertus. Okay, situs invertus. Now what are the triad of symptoms which are present in the Cardiovascular syndrome? Bronchiectasis, sinusitis, situs invertus. That is dextrocardia. One disorder completed, one immotile cilia disorder completed. Now the second immotile cilia disorder is cystic fibrosis. This recent NEET 2022 question. Okay, cystic fibrosis, inheritance pattern, autosomal recessive inheritance. Okay, the inheritance pattern is even from the genetics pathology. This is very important. Cystic fibrosis, the problem is autosomal recessive. It's an autosomal recessive condition. The main problem here is the mutation of a gene called as CFTR gene. Okay, CFTR gene. Because of the mutation of this CFTR gene, what happens is there is a defective chloride channels. The chloride channels in the body are defective. Okay, I am not going in detail. Because of this, what happens, sir? Because of this, entire body secretions, all body secretions throughout the body. Right now, I am not considering about the entire body. Right now, I just want to talk about the respiratory tract. So, the secretions inside the respiratory tract, the mucus inside the respiratory tract is also very thick, very, very thick. So, the patient is having a thick sputum. The patient is having very thick sputum. Now, do you think that this thick sputum can be cleared by the cilia? Cilia are okay, no doubt. But there is thick sputum. Because of the defective chloride channels, the sputum cannot be cleared. So, immotile cilia. Again, cilia are not able to beat properly because very thick sputum. So, again, mucus plugging will happen inside the respiratory tract. Okay, again it will cause infections in the respiratory. So, this is a ciliopathy. Cilia are not able to beat properly in Cardiovascular syndrome as well as in the cystic fibrosis. Important points are what? Cystic fibrosis is autosomal recessive inheritance pattern, CFTR gene mutation, defective in the chloride channels, mucus plugging will happen. Okay, thick sputum will be there, and especially if I am the person who is having this cystic fibrosis. Okay, these babies with cystic fibrosis are called as salty babies. Okay, these babies are called as the salty babies. Here I just want to see your knowledge. Okay, those whoever are going for the exam, I just want to see your knowledge. Guys, can you tell me what dead space mean? Dead space, don't worry, I will explain. Physiological dead space, anatomical dead space, pathological, alveolar dead space. Dead space I will explain in the respiratory system in the end. We'll discuss. Sir, can I ask you where exactly you will see these grey babies? Grey babies. In which condition you will see grey babies? Are using which drug will cause grey babies? Grey baby syndrome. Can you tell me? Those whoever are going for the exams. Can you tell me, guys? Chloramphenicol. Using of drugs called as excellent, Ankit. Your true grey babies are going to be seen with using of chloramphenicol. Okay, guys, can you tell me one more question? Where you will see salty babies is done, right? Where you will see floppy babies? In which condition you will see floppy babies? In which condition you will see floppy babies? Floppy baby syndrome. Floppy babies. If the baby is having botulinum toxicity. Yes, excellent, Ankit. In botulism, the baby is having flaccid paralysis. Floppy baby syndrome. Okay. And one more thing, where in which condition you will see happy babies or happy puppets? Happy puppets. In which conditions you will see happy babies or happy puppets? The babies are going to have this weird smile. Happy puppets. Happy puppets are seen in Angelman syndrome. All these are pathology. Just I'm just trying to integrate. Anyway, we have to complete the physiology here. Now, these babies with cystic fibrosis are called as salty babies, and the treatment, very, very important. Once an exam this question was asked, the treatment to again make the chloride channels functional, the drug which we will give is ivacaftor. Ivacaftor is the drug used for the treatment of cystic fibrosis. Okay, done. Now, after this, the next concept which I want you to know regarding the respiratory physiology, surfactant. Okay, surfactant. Now, surfactant is produced from which cells? It's produced from type 2 pneumocytes. Okay, see, type 2 pneumocytes. See, this is the alveolus, right? Alveolus is lined by type 1 and type 2 pneumocytes. alveolus is lined by type 1 and type 2 pneumocytes, and type 2 pneumocytes are the ones which produces the surfactant. Now, this surfactant is stored in which bodies? Surfactant, whatever is getting produced, it is stored in lamellar bodies. Surfactant is stored in lamellar bodies. Now, the surfactant, what exactly is this? The surfactant is actually a lipoprotein. It's made up of both lipid as well as protein. There are two important lipids, minor lipid as well as a major lipid. Major lipid and minor lipid are there. Now, the major lipid, direct questions which will come in your exam is the major lipid. The major lipid in surfactant is lecithin. The major lipid in surfactant is lecithin, which is also called as a DPPC, dipalmitoyl phosphatidylcholine. Again, I am repeating, dipalmitoyl phosphatidylcholine is also called as a lecithin, which is the major lipid. The minor lipid is sphingomyelin. The minor lipid is sphingomyelin. Two types of lipid are there. Okay, major lipid, minor lipid. First of all, okay, type 2 pneumocytes are producing the this surfactant. Important point is, why the hell do we need this surfactant? Why? Inside our alveolus, why do we need this surfactant, guys? It's because the surfactant, it decreases the surface tension inside our lungs. In our lungs, there is something called a surface tension. In your lung, in my lung, in our lungs, there is surface tension is present. That's a very bad force. It's a destructive force. See, let me show you. You all guys know it anyway. See, here is the air. Inside your alveolus, there is air. And inside your alveolus, there is also lining there, right? Water lining is there. Water lining will be there. So, wherever there is air-water interference, wherever air and water meet, there develops a very destructive force or collapsing force called as a surface tension. So, even in our lungs, there is surface tension. That is very bad. If it is there, our lungs will be collapsed. We are gone. So, to decrease that surface tension, this surfactant is produced. Okay, surfactant decreases the surface tension, and the surface tension is the collapsing force. Now, in a fetal lung, the surfactant is not there. Okay, in a fetal lung, the surfactant is not there. Somewhere around 28 to 22 weeks of period of gestation, the surfactant starts to produce inside the fetal lungs. Surfactant start to produce inside the fetal lungs somewhere around 28 to 32 weeks of period of gestation. How come we know that the fetal lungs are matured? How come we know that surfactant is produced inside the fetal lungs? So, the test which I am going to do is lecithin sphingomyelin assessment. Okay, the fetal lung assessment is done by checking the ratio of lecithin to sphingomyelin. If the ratio is coming more than 2 means, yes, done, the fetal lungs are matured. So, the ratio of lecithin to sphingomyelin greater than 2, it indicates, okay, fetal lungs are matured. Okay, fetal lungs are matured. But this is not the best test. There are other tests like lamellar body count, shake test. There are many tests. But what is the best test? The best test to assess the fetal lung maturity is checking the phosphatidylglycerol levels. This phosphatidylglycerol is actually, it's only present in the amniotic fluid. It's only present in the amniotic fluid. And this, if you see phosphatidylglycerol in the amniotic fluid, that's it. Fetal lungs are mature. I'm not going in detail how it is how it is a marker of fetal lung maturity, but as it's a rapid revision, I'm just touching the points. So the best test for fetal lung maturity is checking the levels of phosphatidylglycerol. Less than sphingomyelin ratio greater than 2 indicates fetal lungs are mature. Now imagine that there was this one baby who is a preterm baby. Okay, preterm baby. The baby got delivered somewhere around 31 weeks. Okay, 31 weeks. In this 31 weeks baby, now enough amount of surfactant is not there. If enough amount of surfactant is not there means more surface tension, more collapsing force. Now, do you think this baby can breathe properly? No. So, this baby is going to suffer with neonatal respiratory distress syndrome, RDS. So, respiratory distress syndrome, neonatal respiratory distress syndrome is because of the not enough amount of surfactant which is seen in preterm babies. And one more important question which was mainly important from the gynae point of view as well as from the pediatrics. If you have preterm labor, now you are the doctor. Now there was this one woman, okay, 30 weeks of period of gestation or 31 weeks of period of gestation, she is going into labor. Now you cannot stop the preterm labor, right? Maximum you can stop the preterm labor for 1 day or 2 days. 2 days you can maximum stop. If there is preterm labor, if the labor is started, means delivery will happen for sure. Now what is the most important? Your duty. You have to make sure that in the baby surfactant is produced. Otherwise, the baby will suffer with respiratory distress syndrome. So what you have to do? Immediately inject the mother with dexamethasone. So inject the mother with dexamethasone. Usually in India, if there is a preterm labor, means in India, if there is a preterm labor, we will give dexamethasone 6 milligrams, 12 hours, 4 doses. Okay, we'll give 6 milligrams of dexamethasone every 12 hours. Total of 4 doses. Okay, so why we are giving dexamethasone? Do you know? Why? Because see here, because the surfactant production inside the baby is mainly stimulated by glucocorticoids like cortisol. Cortisol is a glucocorticoid. Dexamethasone is also a glucocorticoid. So why we are giving dexamethasone to the mother who is going to the preterm labor? Because dexamethasone is a glucocorticoids. Glucocorticoids will stimulate the surfactant production. The question asked in the exam. So all of the following will stimulate the production of surfactant. Cortisol, true. Even thyroxine, these are not that important. At least remember the cortisol. Thyroxine and prolactin, they will stimulate the surfactant production. But very important point is, who inhibits the surfactant production in the baby? Insulin. Very bad. Imagine the mother is a diabetic mother, gestational diabetes. The mother is having diabetes. Okay. Now, if the mother is having diabetes, now she is taking the insulin every day. She is taking insulin. Do you know this insulin is very bad? Why? Because this insulin will inhibit the surfactant production in the baby. The baby is going to suffer with respiratory distress syndrome or highly membrane disease. So, very important point is, insulin inhibits the surfactant production. Cortisol stimulate the cortisol or glucocorticoid stimulate the surfactant production. Okay, is it clear, guys? Shall I go forward? Yeah, betamethasone. Yeah, usually in world we use betamethasone outside India. In India, in India dexamethasone is used. Okay, shall I go forward, guys? Okay, chalo. Now let's talk about inspiration and expiration and mechanics of breathing. Okay, fastly. So inspiration. Every student knows inspiration is an active process. Active process. You need to do it by yourself. Okay, inspiration is active process. And what is the major important muscle? It's the diaphragm. The major important respiratory muscle is diaphragm. Now, diaphragm is innervated by which nerve? Diaphragm is innervated by phrenic nerve. Phrenic nerve important. And what is the root value of phrenic nerve? The root value of phrenic nerve is C3, C4, C5. Okay, C3, C4, C5. Where's I forgot? Just 1 minute, guys. One minute. Listen. What happened is nothing happened to me. There is some technical issue. I don't know why these technical issues are coming. Is it happening only with me or with other faculties also, other rapid revisions also? You just go and have a sip of coffee or tea. Yeah, it's happening to me only. Okay, guys, let's take a break of 5 minutes. Okay, let's take a break of 5 minutes. We'll come back in 5 minutes. We'll do respiratory and all other systems. Don't worry. From now, we'll go little fast only. Okay guys, welcome back. Now let's continue with the topic. Now inspiration, it's an active process, we all know. The major inspiratory muscle is diaphragm, and the diaphragm is innervated by the phrenic nerve. The root value of phrenic nerve is C3, C4, C5. Now let's talk about the expiration. Expiration is absolutely passive process. There is no need of any contraction of any muscles. Simple relaxation of diaphragm. Simple relaxation of diaphragm will cause expiration process. Okay, but forceful expiration. See, whenever they ask the word forceful expiration do certain muscles, do require certain muscles. Which muscles? Internal intercostal muscles, internal intercostal, transverse abdominis, and rectus abdominis. This is very, very important. What is the major important muscle? What is the major important muscle involved in forceful expiration? Forceful expiration is rectus abdominis, but normal general inspiration. Which muscle do you need? Inspiration, it's a diaphragm. Okay. After seeing about the muscles, now let's talk about the concept of mechanics of breathing. Mechanics of breathing. Okay. How inspiration happens, how air enters into the lungs. Before that, see, in a resting state. Okay. In resting state, when I am like this, I am not breathing, I am not inhaling, I am not exhaling, I am like this. Now, what are the important pressures which you need to know? Here I am showing you the lung. The entire thing which I am just showing you here, this is the lung surrounding by the pleura. Okay, all this space which I am showing you, just take it as a pleura, and this entire thing which I am showing you here, just take it as a one single lung with the alveoli. Now, what is the pressure inside the alveoli? Intra-alveolar pressure. What is the intra-alveolar pressure? 0. What is the atmospheric pressure? 0. In the atmosphere, the pressure is, see, in the atmosphere, the pressure is taken as 0. 760 mmHg pressure in the atmosphere, it's considered as a 0. So the same atmospheric pressure is communicating into the alveoli. So outside 0, inside 0. Outside atmospheric pressure is 0, inside intra-alveolar pressure is 0. So two pressures, you know it. Remember, your lungs are surrounded by vacuum. Your entire lungs, both the lungs are surrounded by vacuum. This vacuum is nothing but called as intrapleural pressure. See, intrapleural pressure. This intrapleural pressure is how much? Minus 2.5 mmHg. All the time negative. Negative pressure means vacuum. Vacuum. Your lungs are surrounded by vacuum. True. Now, after seeing these three pressures, okay, some important points which you need to know is, all the time the intrapleural pressure is negative. In a normal healthy person, all the time it is negative only. Okay. Now after this, what exactly is the transpulmonary pressure? What is the formula of transpulmonary pressure? The formula of transpulmonary pressure is intraalveolar pressure, IAP, intraalveolar pressure minus intrapleural pressure. Intraalveolar pressure is how much? 0. Inside the alveoli the pressure is 0. Outside also 0. What is intrapleural pressure? Minus 2.5 mmHg. So 0 minus of minus 2.5 mmHg, how much it will come? Plus 2.5 mmHg. So how to understand this, sir? Sir, the transpulmonary pressure is plus 2.5 mmHg. Now with the help of this transpulmonary pressure, this is a distending pressure. With the help of this transpulmonary pressure, the alveoli are kept open. Right now I am not breathing. My alveoli are kept open, right? My alveoli are kept open. With how much pressure? The transpulmonary pressure plus 2.5 mmHg. Lungs are surrounded by vacuum. The vacuum is keeping the lungs open. The vacuum is keeping the alveoli open. The transpulmonary pressure is the distending pressure. Okay? Plus 2.5 mmHg is the transpulmonary pressure. Now, during inspiration, what happens? Simple events. Diaphragm contracts. Okay, everyone knows it. Now, during inspiration, what's the first change is the intrapleural pressure. Okay, changes to the intrapleural pressure. It changes from minus 2.5 mmHg to minus 6 mmHg, which means lungs are surrounded by now more vacuum. Lungs are surrounded by more vacuum. Now, vacuum will open the lungs. Okay, now what happens is, see, the intrapleural pressure is moving from minus 2.5 mmHg to minus 6 mmHg, more vacuum. Okay, now what happens to the intraalveolar pressure? Now see, now during inspiration, alveolus are expanding, sir. Alveolus are expanding. The vacuum is stretching the alveolus. Alveolus is expanding. So the intraalveolar pressure is moving from 0 to minus 1. Okay, 0 to minus 1. Inside it is minus 1. Outside it is 0. Outside it is more, right? So immediately air from outside will start to enter into the lung. So what are the important MCQs which you need to know for your exam? What happens during inspiration? During inspiration, what happened to intrapleural pressure? Intrapleural pressure is moving from minus 2.5 mmHg to minus 6 mmHg. What happened to intraalveolar pressure? Intraalveolar pressure is moving from 0 to minus 1. Outside is 0, inside is minus 1. So automatically air will move from high pressure to low pressure. high pressure, 0 is high when compared to -1. So high pressure to low pressure, air will move. So during expiration, what will happen? Expiration, lungs are collapsing, diaphragm is relaxing, lungs are also collapsing. Now again everything getting reversed back. So from -6 mmHg, the intrapleural pressure will again become to -2.5. Lungs are collapsing, alveoli are also collapsing. So when alveoli are collapsing, when the volume decreases, the Boyle's law, you all know Boyle's law, right? When volume decreases, pressure increases. When volume decreases, inside the alveolus pressure increases. Now inside the alveolus pressure is going to +1 mmHg. Outside is 0, inside is +1. So immediately what happens is air is going out. Air is going out. Okay. So during expiration, air is going out. So what are the important points which you need to know? Intrapleural pressure from -6 mmHg it becomes -2.5 mmHg. Intra-alveolar pressure it becomes a positive. Inside it is positive, outside is 0. So air goes out. Air goes out. Okay. So mechanics of breathing are completed. Okay. You know how air is coming in, how air is going out. You know it. Now let's talk about the concept of compliance and elastance. Okay, very important. Most of the students doesn't even understand the concept of compliance and elastance. Very simple. Compliance means stretchability. Okay, take a rubber band. If I am able to stretch it, most of the students will think this is elastance, elastic rubber band. No. If I am able to stretch it easily, you should say it is having more compliance. It is more compliant. Easily you are changing its shape. Easily it is stretching. So compliance is the other term for stretchability. Now what is elastance? Elastance means getting back to its original position, recoiling back, recoiling force. Okay, when I stretch a rubber band, the stretching is called as compliance. When I just leave it, it will collapse back, it will recoil back. The recoiling nature is called as elastance. Okay, the recoiling property is called as elastance, elastic recoil. Now after this, what is the normal compliance of the lung? Right now I am talking about the concept of compliance only. Okay, I am not worried about elastance. I'm just talking about compliance only. What is the normal value of compliance? Your lungs are stretchable, right? Your lungs can also be stretched during inspiration. How much stretch? See, with 1 centimeter of water pressure, important MCQ, this was asked long back. With 1 centimeter water pressure, with this much amount of pressure, you can increase the lung volume by 200 ml. So 200 ml of lung volume expansion will happen just with 1 centimeter water pressure. Very good compliance. Okay. Now, in which conditions compliance increases? What are the diseases where there are certain diseases like emphysema, alpha-1 antitrypsin deficiency. Okay, elastic fibers are gone. In alpha-1 antitrypsin deficiency, in emphysema, elastic fibers in the lungs are damaged. Whenever the elastic fibers are not there, there is no elasticity. Easily lungs will be stretched. So very important MCQ. In emphysema they will ask you. In emphysema, lungs are more compliant or less compliant? Lungs are more compliant, sir. In pulmonary fibrosis, lungs are getting totally fibrotic, total fibrotic material, hard lungs. Now, do you think lungs will be easily stretched? No. So what happens to what happened to compliance? The compliance is going to be decreased. In pulmonary fibrosis, compliance is decreased. Okay. Now after this, the formula of compliance is very important. See, what is the formula of compliance? The compliance is equal to delta V by delta P. Put 5-star marks. If I am the examiner, definitely I will give a question from here only, compliance of the lung. What is the formula of compliance? Delta V by delta V. What does it mean by? With a given amount of pressure, given amount of pressure, how much volume is changing? With a given amount of pressure, how much volume is changing? For example, if more volume is changed means good compliance. If little volume is changed means bad compliance or less compliance. So compliance is change in the volume with the change in the pressure. Okay, that will give you compliance. Now, why I am explaining all this compliance is because there is something called as pressure volume loop. Pressure volume loop. The concept of pressure volume loop, very important. Here, see, in this graph I am showing you the pressure volume. See, during inspiration, this is the compliance of lung. This is the compliance of lung during inspiration. This is the compliance of lung during expiration. Now you will get it out. Sir, how many lungs do we have? We are having the same lungs, right? During inspiration, during expiration, we are having same lungs. But important point is, just like your girlfriend, she will behave totally oddly, right? Sometimes she will behave in a very good way. Sometimes she will behave very, like, annoying. She is very irritating. In the same way, your lung compliance also changes with inspiration and expiration. Lungs are more compliant. Most of the students will think like this, sir, lungs are more compliant during inspiration. Students will think like this, no, lungs are more compliant during expiration. I will show you, I will prove you here. This is not a class of proving. What I want to show you, see, this is the compliance graph. How can we say this is the compliance graph? Simple. Here is the pressure delta P, pressure changing, pressure intrapleural pressure changing. Now with the change in the intrapleural pressure here, the volume of the lungs are also changing, that is delta V. So delta V by delta P is a compliance curve. The curve is compliance curve. Now let's take something like this, not 4, let's take it minus 2.5, or we are taking the values of 2.5. During inspiration, what happens? The pressure is moving from, intrapleural pressure is moving from minus 2.5 to minus 6 or not. Intrapleural pressure changes. So see here, this is the compliance during inspiration, and this is the compliance during expiration. This is the compliance curve. Now let's take one intrapleural pressure. Let's see one intrapleural pressure. Intrapleural pressure of minus 5. Now let's draw something like this. Very simple. Draw like this. At minus 5 intrapleural pressure. See, at minus 5 intrapleural pressure, what is the volume of lung during inspiration? The volume of lung during inspiration is 100. Let's take it as 100. But at the same minus 5 intrapleural pressure, the volume of lung during expiration is how much? Somewhere around 350. So, with same minus 5 intrapleural pressure, when lungs are having more volume, when there is more volume change, the more volume change is seen during expiration, not during inspiration. So one thing I can say, I am not going in detail, we are not having enough time. So one thing I want you to know is, sir, lungs are more complaint during expiration than inspiration. Now the difference in the path, the difference between inspiration and expiration, the difference is called as hysteresis. Okay, the difference is called as hysteresis. Now why the hell do we have this hysteresis? Why the lungs are behaving differently? Now this hysteresis, this difference in the path is due to surface tension in your lungs, in my lungs. Surface tension during inspiration changes, during expiration changes. Simple. Let me tell you as simple as possible. For example, this is the normal alveoli. Take it as a normal alveoli. In a simple way, let's take it as a normal alveoli. During inspiration, what happens, guys? Alveoli are becoming bigger in size. When alveoli are expanding, when alveoli are becoming bigger in size, what happened to surfactant concentration? The surfactant molecules are moving far away from each other. Lungs are expanding. The surfactant is getting diluted away. When surfactant is diluted away, what happened to surface tension? Surface tension increases. When inspiration, surface tension increases, collapsing force increases. So lungs are not compliant during inspiration. So lungs are having less complaints during inspiration. But talk about the exact opposite thing. During expiration, what happens? During expiration, alveoli are collapsing. When alveoli are collapsing, what happened to surfactant concentration? Surfactant concentration increases. Surfactant is more and more concentrated. When surfactant concentration is more, what happened to surface tension? Surface tension decreases. When surface tension is decreased, means no collapsing force, no collapsing force. Now the lungs can be easily stretched. No collapsing force, no recoil. Lungs can be easily stretched, sir. So what I am saying is, the hysteresis, this difference is because surface tension changes. During inspiration and expiration. Surfactant concentration changes during inspiration and expiration. Okay, I hope the concept is clear. Guys, is it clear? Shall I go forward? Okay, I am going forward, guys. Now, in one of the exam, the question asked is compliance of a saline filled lung. What happens to the compliance of a saline filled lung? Compliance increases or compliance decreases? You just try to answer it. Compliance increases or compliance decreases? See, in saline filled lung, what exactly you are doing is, this is the alveoli. You have totally filled the alveoli with the water. You have totally filled the alveoli with the saline. Now there is no water interference, no air-water interference. There is no air-water interference. So there is no surface tension. If there is no surface tension, there is no collapsing force. If there is no collapsing force, easily you can stretch the lungs. So what happens in a saline-filled lung? What happened to compliance, sir? Compliance increases. Okay, compliance increases. Now if you see the graph, first of all, there is no surface tension at all. If there is no surface tension, can you have hysteresis? Hysteresis is not going to be there. So see, this is the compliance curve. This is the compliance curve of saline filled lung. There is no hysteresis. more complaints. Okay, more complaints. Graph is more towards the y-axis, more complaints is there. Okay, so this is one important question which you need to know. Now just try to answer these two graphs. Guys, here in the first graph, in this graph, complaints is more or complaints is less? More towards the y-axis, more towards the y-axis means more complaints. Simple. If a graph is more towards the y-axis, see, this is just taken as the average complaints, normal complaints. Here, the graph is more towards the y-axis. Just simply blindly trust me, more complaint. In which conditions complaints increases? Can you tell me? Saline filled lung. But this is not a saline filled lung. Why? Because still hysteresis is there. Now this is an example of emphysema. Okay. See, in this condition, complaints increases. This is an example of emphysema. In emphysema, complaints increase. Don't forget. And here, what is happening? Complaints is getting decreased. Okay, there is decreased complaints. Now, this is an example of pulmonary fibrosis. This condition is example of pulmonary fibrosis. Okay. Now, some important MCQs. Just try to answer this. What is A, B, and C? You just try to answer it. You have 3 subjects. Now you are having 3 subjects, 3 equivalent graphs A, B, and C. Now what we are seeing is the complaints curves. Okay, one subject is normal, the second guy is having emphysema, and the third guy is taking drugs like amiodarone and bleomycin. Now who is A, B, and C? See, I have already discussed with you. More towards the y-axis, more complaints. If the curve is more towards the y-axis, more complaints. See here, the A curve is more complaint. The A curve is showing more complaints, which means this curve is the person's, like, no, this is the curve of emphysema. Okay, this question is emphysema. B is normal and C is the person who is taking amiodarone or bleomycin. Why? Why amiodarone and bleomycin? Why? Because using of these drugs, okay, using of these drugs like amiodarone, bleomycin, busulfan, carmustine, cyclophosphamide, methotrexate, all these drugs, they will cause what? All these drugs will cause pulmonary fibrosis. In pulmonary fibrosis, what happened to complaints? Complaints decreases. Okay, I will just share the PPT. You can just go through them. Okay. Now lung volumes and capacities. I hope all you guys are very good with the lung volumes and capacities. Okay, lung volumes and capacities. Now, what is the first volume? Normal inspiration, expiration, inspiration, expiration. What is this? Normal inspiration, normal expiration. This is tidal volumes. Okay, tidal volume. Normal inspiration, normal expiration. But if you ask me to take extra air, I can take more. This is inspiratory reserve volume. Okay, inspiratory reserve volume. This up one is the inspiratory reserve volume. If you ask me to exhale more, other than the tidal volume, I can exhale more. That is the expiratory reserve volume. Okay, tidal volume, inspiratory reserve volume, expiratory reserve volume. Done. Now, important point is, whatever you try, you cannot take out the some amount of air from the lungs. Whatever you try, you cannot take some amount of air out of your lungs. So that is called as residual volume, RV. So RV, residual volume, is you cannot take that air out of your lungs, whatever you try. Okay, that is the residual volume. Now after this, we have seen three volumes, that is inspiratory reserve volume, tidal volume, expiratory reserve volume. 4 volumes. That is a residual volume. We have seen 4 volumes. Okay. Now let's talk about the capacities. What exactly is vital capacity? Okay, vital capacity. Simple. Add inspiratory reserve volume, tidal volume, as well as expiratory reserve volume. If you add all these 3, you will get vital capacity. So vital capacity is a combination of, okay, vital capacity is a combination of inspiratory reserve volume, tidal volume, as well as expiratory reserve volume. All these 3, adding of these 3 volumes will give you vital capacity. Okay. Now vital capacity along with residual volume, vital capacity along with residual volume is total lung capacity. Or you can say something like this: total lung capacity means inspiratory reserve volume, tidal volume, expiratory reserve volume, residual volume. If you add all volumes, you will get total lung capacities. But in your exam, no one is going to come and ask you what are these volumes. No one is going to ask you. They will ask you which volumes you cannot measure. See, all the volumes and definitions I have given clearly here. Okay, in the PDF you can go through. But in the exam point of view, what are important? See, volumes and capacities that cannot be measured. You cannot measure certain volumes and capacities. What are they? The residual volume, whatever you try, it cannot come out. So with spirometry, okay, you cannot measure residual volume. If you cannot have residual volume, you cannot measure functional residual capacity. Now you will get it out. What exactly is this functional residual capacity, sir? Very simple. See here. Functional residual capacity means these two, combination of expiratory reserve volume and residual volume. If you add these two, expiratory reserve volume and residual volume, if you add these two, you will get functional residual capacity, FRC, functional residual capacity. So, functional residual capacity is a combination of expiratory reserve volume and residual volume. If you don't have residual volume, how can you calculate the functional residual capacity? It's not possible. And total lung capacity is a combination of all volumes. If you cannot calculate the residual volume, you can also cannot calculate the total lung capacity. So, what are the three important volumes and capacities which cannot be measured? It is residual volume you cannot measure, functional residual capacity you cannot measure, and total lung capacity you cannot measure. These three things you cannot measure with the normal spirometry. But importance is this one, functional residual capacity, a combination of residual volume and expiratory reserve volume. You can measure it with the help of certain studies. So, what is that? The methods used to measure functional residual capacity, repeatedly asked MCQ, are body plethysmography is the technique, and nitrogen washout, body plethysmography, nitrogen washout, and helium dilution methods. These are the methods. As a doctor, these are not important for us, but as the exam point of view, you need to know them. Okay, nitrogen washout, body plethysmography, and helium dilution technique. These are the techniques which are used to measure the functional residual capacity. Now, after this, let's talk about the concept of alveolar ventilation and perfusion. Okay, alveolar ventilation and perfusion, ventilation perfusion ratios, ventilation perfusion mismatches, we'll discuss now. Now, what is the alveolar ventilation? Simple. Alveolar ventilation, not the minute ventilation, not the tidal volume. How much actually is going into your alveolus? See, with every breath, 500 ml is going into your lungs. Tidal volume, normal inspiration, expiration. With every breath, 500 ml is going into your lungs. So, alveolar ventilation, see, normal tidal volume is how much? 500. Out of this 500, how much is staying in the conducting zone? Almost 150 ml is wasted. 150 ml is wasted in the conducting zone itself. Now, if you remove 150, how much is actually going into the alveolus? Into the respiratory zone, how much is going? 350 is going. Okay, so 350 is going into your alveolus. Okay, now how many times a person is breathing? Now 350 into 12, respiratory rate. The respiratory rate is 12. Every time 350 ml is going, and the person is breathing 12 times a minute. So 350 into 12 is 4000 ml. So how much actually the what is the alveolar ventilation? Alveolar ventilation is 4 liters per minute. Okay, alveolar ventilation is how much? 4 liters per minute. So you are putting 4 liters of air into your lungs. But how much blood is going into your lungs? 5 liters, right? Every minute, cardiac output, 5 liters is going to the lungs for the purpose of oxygenation. Okay, so you are putting 4 liters of air into your lungs and sending 5 liters of blood into your lungs. So what is the perfusion of your lungs? The perfusion of your lungs is 5 liters per minute. So what is the ventilation perfusion ratio? Ventilation is 4 liters. Ventilation is 4 liters. Perfusion is 5 liters. So the ventilation perfusion ratio V by Q. Okay, V by Q, ventilation perfusion ratio. What is the normal value? 0.8. That's a normal statement. Ventilation perfusion ratio in a healthy lung in you and me, it is 0.8. Okay, you are sending 4 liters of air and 5 liters of blood. But some important points which you need to know. See, ventilation perfusion ratio is 0.8, especially it's an average value. It's an average value, especially the middle lobes of the lungs. But some exceptions which are very, very important. If you look at the apex, of the lung, see here, ventilation is less. Ventilation is not, alveolar ventilation here is very less amount of air is going. But when compared to the ventilation, perfusion is very, very less. So ventilation and perfusion both are less. Remember this one point for your entire life. When compared to the apex, both the ventilation and the perfusion are more in the bases of the lung. Okay, but head to head comparison. Now I am comparing head to head. In the apex, ventilation is a little more when compared to perfusion. Both are less only, but when compared to perfusion, ventilation is little more. Ventilation is less, but perfusion is very, very less. So what happens to ventilation perfusion ratio here? Is it going to be 0.8? Definitely not. Here in the apex of the lung, the ventilation perfusion ratio is maximum 3.2. Why? Because no blood is going there. Only air is left over there. More air is there. Ventilation perfusion ratio of 3.2, it indicates what? More availability of air, more availability of oxygen. So that is the reason why Mycobacterium tuberculosis affects the upper lobes of the lung, because of the more availability of the more oxygen tension available in the upper lobes of the lung. So in the upper lobes of the lung, important point is ventilation perfusion ratio is maximum 3.2. Okay, who is more? Well, in the apex of the lung, ventilation is more or perfusion is more? Sir, ventilation, perfusion both are less, but ventilation is more when compared to perfusion. Okay, and one more important anatomically relevant point for your exam is, see, in the apex of the lung, what is the size of the alveoli? See, I have made the alveoli intentionally like this. Why? Because in the apex of the lung, the alveoli are bigger in size. Bigger alveoli are there. Okay, bigger alveoli are there in the apex of the lung. But please look at the base of the lung. In the base, you are having small alveoli. Okay, so the kind of question that will come in your exam is, bigger alveoli are seen in the apex of the lung, smaller alveoli are seen in the. Okay, and bigger alveoli, they are more complaint or less complaint? Already they are bigger. They are not further complaint. So complaints is less. Complaints is less. The alveolar complaints is less in the apex. Alveolar complaints is more in the base. Because small alveoli you can stretch it. Complaints is more. But anyway, forget about it. Now let's talk about the base of the lung. Remember, in the base of the lung, ventilation is more, perfusion is more. Both are more. But when compared to ventilation, perfusion is more. Head-to-head comparison. Ventilation, perfusion are both more in the bases only. But ventilation is less when compared to perfusion. So again, ventilation perfusion ratio is not going to be 0.8. Now it is. Just give me 1 minute. Yeah, actually in the base it is 1.6 or 1.2. Okay, the bases of the lung. Okay, so in the bases of the lung, the ventilation perfusion ratio is 1.6. Now see here, I have given you a note. As we move from apex to the base, both ventilation and perfusion progressively increases. Both increases. Okay, now VQ mismatch, ventilation perfusion mismatches. A lot of time the question was asked. Okay, a lot of time this question was asked. VQ mismatch. What is the normal V by Q ratio? 0.8, right? Now V by Q mismatch means there are certain conditions where ventilation is normal but perfusion is affected. That is, see, 4 liters of air is coming, 4 liters of alveolar ventilation is there, but perfusion is 0. So if you divide anything by 0, the answer will be infinity. So ventilation perfusion ratio is infinity in which condition? Ventilation perfusion ratio is infinity in conditions like pulmonary embolism. The conditions of pulmonary embolism, ventilation perfusion ratio is 0. Now there is one more condition where VQ mismatch will be there. When ventilation is affected, air is not going into the lungs, air is not going into the alveoli. Alveolar ventilation is affected. But perfusion is good. See, no air is going to the lungs, but blood is going to the lungs. So 0 divided by anything is again 0. So in which condition V by Q mismatch, ventilation perfusion ratio is 0? In which condition? Conditions like foreign body obstruction. If there is any foreign body obstruction, no air is going, right? Ventilation is affected, no air is going. Okay, and the conditions like atelectasis, completely lungs are collapsed, no air is going, but blood is going. And airway compression, because of a Pancoast tumor or because of a tumor in the apex of the lung, that tumor is compressing the bronchioles so that air is not going, no ventilation, but perfusion is there. So ventilation perfusion ratio will become 0. So what are the two conditions which you need to know? Ventilation perfusion ratio is infinitive, it becomes infinitive in conditions like pulmonary embolism, and ventilation perfusion ratio is going to be 0 in conditions like foreign body obstruction or atelectasis or compression of the respiratory tract. Done. Concept is done. Now the next concept which you want to know for your exam is dead spaces. How many types of dead spaces are there? There are 3 important types of dead spaces. That is anatomical dead space, that's a conducting zone, nothing but the conducting zone. The anatomy, the conducting zone, first 16 generations, no gases exchange, only conduction. So 150 ml. So first anatomical dead space, it is a conducting zone, 150 ml, no gases exchange, wasted. All that gas is wasted away. Now next dead space is called as the alveolar dead space. Actually in you and me, in healthy people, there is no alveolar dead space. Whatever the air goes into the alveoli, that will be exchanged. So in a healthy person, there is no alveolar dead space. It's always pathological. Okay, absent in healthy individuals. So which dead space is absent in healthy individuals? Alveolar dead space is absent. Now what is physiological dead space? Physiological dead space is a combo of its combination of anatomical dead space plus alveolar dead space. Anatomical dead space is 150 ml. Alveolar dead space is 0. So 150 plus 0 is 150. So remember, in a healthy individual, okay, anatomical dead space is equivalent to physiological dead space. Done. Okay. Now, two important MCQs which you need to know here: direct single liners, anatomical dead space, that 150 ml. Is that right? You can actually measure it with a type of technique, with the help of a technique called as single breath yeah, single breath nitrogen method. That's not important, but important is Fowler's method. This was the exam MCQ. Fowler's method is used to measure. Fowler's method is used to measure anatomical dead space. Fowler's method is used to measure anatomical dead space. And physiological dead space is measured with physiological dead space. The combo physiological dead space is measured with the help of an equation called as a Bohr's equation. Bohr's equation. Okay, no one will ask you the equation. Okay, no one will ask you the equation. Here I have given you the equation, but simple. Bohr's equation is used to measure the physiological dead space. Fowler's method is used to calculate the anatomical dead space. That's it. You know this for your exam. It's enough. Now let's talk about the diffusion of gases. Okay, diffusion of gases. Normally, diffusion is something measured with the help of a substance called as carbon monoxide. Not carbon dioxide or not the oxygen. Carbon monoxide. It's such a beautiful gas. It have higher affinity. It's having 210 times more affinity with the hemoglobin. When compared to the oxygen, it's having 210 times more affinity. It will immediately go and love to bind with the hemoglobin, carbon monoxide. So we are using this carbon monoxide for the study of diffusion. Okay, so diffusion in lung measured with the help of carbon monoxide. Now see, carbon monoxide, it's 210 times more affinity to hemoglobin. What is the normal DLCO? Normal DLCO value not needed for your exam, not needed for your exam. But diffusion is something explained by a law called as Fick's law. A Fick's law. A Fick's law. Now what is this Fick's law tell to us? Fick's law says us that diffusion is directly proportional to the concentration gradient of the gases. Gases will all the time move from high concentration to low concentration. More the difference, more fastly the gases will move. Concentration gradient. And if there is more surface area, means more easily gases will be diffused. So diffusion is directly proportional to the concentration gradient and directly proportional to the surface area. Okay, done. Diffusion is inversely proportional to the thickness. The thickness of the respiratory membrane. For example, see here, this is the alveolus. Okay, the membrane here is the blood vessel. Okay, here is the blood vessel. Now, here is the respiratory membrane will be there, right? Here, the respiratory membrane, alveolar basement membrane will be there. For example, if it is thickened, do you think diffusion will happen properly? No, diffusion is not going to happen properly. So, the thickness of the membrane is inversely proportional to the diffusion. So, important point is diffusion is explained by Fick's law. Diffusion is directly proportional to the concentration gradient and also directly proportional to the surface area, but inversely proportional to the thickness. Now, here important MCQs which you need to know. Sir, in a disease called as emphysema, what happens? Do you know? Normally, alveoli are just like a grapes like this. Okay, cluster of grapes. In emphysema, what happens is that surface extra membrane, all that membrane is lost. Now, alveoli are become something like smooth, one round, a big, huge alveoli. Okay, so what happens is all this extra membrane is lost in emphysema. Now, the surface area is lost, extra membrane, surface area is lost. So, in emphysema, all that membrane is lost. So, what happened to diffusion? Surface area is decreased, so diffusion decreases. So, in emphysema, tell me, in emphysema, compliance increases, but diffusion decreases. Okay. Now, in pulmonary fibrosis, what is happening? The lungs are becoming fibrotic, like this. Lungs, entire lung, alveolar basement membrane is becoming fibrotic. Now, if the thickness of the membrane increases, what happens to diffusion? Thickness is inversely proportional to diffusion. So, thickness is increased. So, what happened to diffusion? Diffusion. Okay. Now, let's see what are the conditions in exam. This kind of questions will come. DLCO is increased in, DLCO is decreased in. DLCO increase means diffusion increases. DLCO decreases means diffusion decreases. Already we have discussed diffusion of gases is decreased in emphysema. Diffusion of gases is decreased in pulmonary fibrosis. So, DLCO automatically decreases. And DLCO increases in, first let's see, DLCO increases in polycythemia. Polycythemia means more number of RBCs, right? How to understand this, sir? See, imagine this is the alveolus. Here is the blood vessel. Okay, here is the blood vessel. Now, polycythemia means what? More number of RBC. More number of RBC means more amount of hemoglobin. So, here you are having more amount of hemoglobin. More amount of hemoglobin means readily take up all the carbon monoxide molecules. Readily take up all the carbon monoxide molecules. So, in polycythemia, what happens? DLCO increases, diffusion increases. Okay, and exercise. During exercise, what happens? More amount of blood is going to the lungs, more amount of RBC going to the lungs, more hemoglobin is going to the lungs. So, readily take up all the carbon monoxide from the lungs. So, DLCO increases. Like exact opposite. If in polycythemia, DLCO increases means what happened to the DLCO in anemia? DLCO decreases. Why? Because less amount of hemoglobin. No hemoglobin is there, so diffusion is not happening properly. DLCO increases and DLCO decreases in different conditions. Now let's talk about the concept of transport of gases. Okay, sir, please teach biochemistry. Why? Because biochemistry is already done, guys. I'm not good with the biochemistry, so even if I teach you, that won't be beneficial for you. Okay, sir, diffusion and transport of gases. Okay, let's talk about the transport of gases. Important points which you need to know. Transport of gases. What are the two important gases which I'm going to talk here is oxygen and carbon dioxide. Oxygen transport, carbon dioxide transport. Now, mainly oxygen is transported in which form? In the blood. Oxygen is transported along with the hemoglobin. So, oxyhemoglobin, all the time oxygen is bind to the hemoglobin. So, 97% of the oxygen is bind with the hemoglobin. 97% of the oxygen is bind with the hemoglobin. So, this is the major form. My minor form is some amount of oxygen, very important. See, some only 3% of oxygen is actually dissolved in the water. Actually, that's the plasma. 3% of the oxygen is dissolved in the plasma. But importance is, see, this dissolved oxygen is responsible for partial pressure of oxygen. This dissolved form is responsible for partial pressure of oxygen. If I say partial pressure of oxygen in the artery, partial pressure of oxygen in the veins, that partial pressure of oxygen is because of what? It's not because of the oxygen which is bound to hemoglobin. It is because of the dissolved oxygen in the plasma. Okay, so dissolved oxygen is the one responsible for partial pressures. I'm repeating, very important point. Okay, so dissolved oxygen. Two forms, oxyhemoglobin, and other form is dissolved oxygen, which is responsible for partial pressures. Next point, guys. Now, carbon dioxide. The majority amount of the carbon dioxide is transported in which form? The major amount of carbon dioxide is transported in the form of bicarbonate ions. How much form? How much percent? 70% of the carbon dioxide is transported in the form of bicarbonate ions. But a little amount of carbon dioxide, okay, 30% of the carbon dioxide is bound with hemoglobin also, carboxyhemoglobin, 30%. Repeatedly asked MCQ, which will come from this slide, especially in the FMGE exam, is what is the oxygen responsible for partial pressures? Dissolved form of oxygen. Second thing, the major transport for the carbon dioxide is the form of bicarbonate ions, the plasma. Bicarbonate ions in the form of plasma. Okay, now let's talk about the Haldane's effect and Bohr's effect. See, every student knows, before discussing about the Haldane's effect and Bohr's effect, let me show you. See here, I am showing you the alveolus. This is the alveolus. Now, in the alveolus, the partial pressure of oxygen is 100 mm Hg. Okay, lot of oxygen is there, 100 mm Hg oxygen is there. Okay, so let's start from here. This is the tissues. Okay, here is the tissues. Here is the alveolus. This is alveolus. In the alveolus, 100 mm Hg is there. Now, please see. Here, the molecule which I am showing is the hemoglobin molecule. One hemoglobin molecule can carry 4 molecules of oxygen. One hemoglobin molecule can carry 4 molecules of oxygen. At the level of lungs, what is happening? At the level of lungs, all 4 pockets, all 4 active sites are occupied with the oxygen. Hemoglobin is 100% saturated. Okay, hemoglobin is 100% saturated. So, what is happening at the level of alveolus? At the level of alveolus, there is loading of oxygen onto hemoglobin. Loading of oxygen onto hemoglobin, and carbon dioxide will go back into the alveolus. So, this effect is called as Haldane's effect. So, what exactly is Haldane's effect? It's a loading of oxygen onto hemoglobin. Okay, and releasing of the carbon dioxide into the lungs. Carbon dioxide go back into the lungs, oxygen will come and attach to the hemoglobin. This is called as Haldane's effect. Now, what exactly is Bohr's effect? Simple, Bohr's effect. It is a release of oxygen to the tissues. See, now this hemoglobin molecule, where it is coming? Via the arterial bed, it is coming to the tissue. Now, in the tissue, see, in the tissue, what the partial pressure of oxygen is? How much? Only 40. In the arterial bed, see, in the arterial bed, P small a O2. P small a O2 means partial pressure of oxygen in the arterial bed. Small a means arterial bed. How much? 100 mm Hg. Now, this partial pressure is because of what? This partial pressure is because of the dissolved oxygen. Remember, the 3% dissolved oxygen is there, right? This partial pressure is because of the dissolved oxygen. Now, important MCQ is, see, the partial pressure of oxygen in the arterial bed is, I am taking the round figure. Actually, it is somewhere around 95 mm Hg, but round figure I am taking. Let's take it as 100 mm Hg. In the tissues, the oxygen concentration is very less. In the tissues, it is only 40 mm Hg. So, So from where to where gases move? From high partial pressure to low partial pressure, the gases are moving. So oxygen molecule is delivered to the tissue. And the venous blood, see, this hemoglobin is only 75% saturated, which means even in the venous blood there is oxygen. Even in the venous blood, the hemoglobin is 75% saturated. Important point is, what is the partial pressure of oxygen in the venous blood? The partial pressure of oxygen in the venous blood is 40 mmHg. Okay, in the arterial blood it is 100 mmHg. In the venous blood is 40 mmHg. Now, important MCQs which you need to know for your exam. This is Halden's effect, sir. Unloading of oxygen to the tissues. Unloading of oxygen to the tissues is Halden's effect. Loading of oxygen to the hemoglobin molecule is, unloading of oxygen is Bohr's effect. Unloading of oxygen to the tissues is Bohr's effect. Loading of oxygen to the hemoglobin molecules is Halden's effect. This is Halden's effect. Halden's effect happens at the level of pulmonary capillaries. Bohr's effect happens at the level of capillaries, that is in the tissues. Okay. Now, after seeing this, the entire respiratory system, if I am the examiner, if I have to know one point, I will just study this one thing. I will just, if I am the examiner, I will give question from this area only, that is oxygen hemoglobin association dissociation curve. Oxygen hemoglobin association dissociation curve is the utmost important area for your exam. Now, how to understand this, sir? Let's keep it as simple as possible. See, hemoglobin molecule, again it's like your girlfriend. Sometimes it behaves in a very good way, sometimes it behaves very oddly, very irritating. Why I am saying this is because, see, if I ask you, hemoglobin molecule, does it love to bind with oxygen or it doesn't like to bind with oxygen? If I ask you, usually students will say, sir, hemoglobin love to bind with oxygen. Usually people will say, see, hemoglobin at the level of lungs binds with oxygen. But the same hemoglobin molecule at the level of tissues, you throw the oxygen, it will release the oxygen to the tissue. So hemoglobin is behaving differently. At the level of lungs, partial pressure of oxygen at the level of lungs is high. So at high partial pressures, hemoglobin love to bind with oxygen. At high partial pressures, hemoglobin love to bind with oxygen. At the level of tissues, partial pressures are very less. So hemoglobin releases the oxygen. It will simply release the oxygen. So the nature of hemoglobin is different according to the different partial pressures. Okay. Now let's see normal. What is normal? And let's see what is right shift and left shift. Okay. What is right shift and left shift? Just for the next 5 minutes, please be very attentive. Guys, this blue color curve is a normal. This is something absolutely normal. Normally, see, this is 100 mmHg partial pressure. 100 mmHg partial pressure at the level of lungs. 100 mmHg partial pressure. At 100 mmHg partial pressure, hemoglobin is how much percent saturated? The arterial blood, the blood which is coming to the lungs is having hemoglobin. At high partial pressures, all 4 molecules are occupied. So hemoglobin is how much percent saturated? Sir, hemoglobin is 100% saturated. But when the hemoglobin is coming to the level of tissues, what happens? Partial pressure comes down. The partial pressure will become 40. Partial pressure will become 40. Now one molecule of oxygen will be delivered to the, only one molecule of oxygen will be delivered to the tissues. So hemoglobin is how much percent saturated? Just tell me. Sir, at 40 mmHg partial pressure, hemoglobin is how much percent saturated? See, blue curve. Hemoglobin is 75% saturated. 75% saturated in a normal person. At 100 mmHg partial pressure, hemoglobin is 100% saturated. At 40 mmHg partial pressure, see, at 40 mmHg partial pressure, hemoglobin is 75% saturated, which means one molecule of oxygen is delivered to the tissue. Just throw one molecule of oxygen to the face of tissue. But hemoglobin is a very good molecule. Okay, your girlfriend, though she is irritative, sometimes she will try to adjust according to the situation. She will change according to the situation. For example, hemoglobin is also like your girlfriend. For example, see, when your muscles are more and more working, in a more and more working muscles, now these working muscles, do they need more oxygen or not? Now these working muscles, you are doing marathon running, in a more exercising muscles, they need more and more oxygen, right? Now see, hemoglobin, instead of delivering one oxygen, now hemoglobin, very good molecule, it will deliver 2 molecules of oxygen with the same partial pressure of 40 mmHg. See, now let me discuss with you the right shift. Okay, right shift. This is the right shift, guys. This is the right shift. Okay, this green color dotted line, the green color dotted line is the right shift. Normally, let's start with the basics. You all know at 100 mmHg partial pressure, hemoglobin is how much percent saturated? Sir, 100% saturated. Every student knows this. But right now, what is happening? Exercising. The muscles are exercising. They need more and more oxygen. When they need more and more oxygen, hemoglobin have to easily deliver the oxygen. See, now what is happening is, at the level of tissue, whenever there is 40 mm Hg partial pressure, see, now I am drawing like this. Normally, see, normally, hemoglobin is delivering one molecule of oxygen. That is, hemoglobin is 75% saturated. But in right-sided curve, see, in right-sided curve, hemoglobin is, sorry, hemoglobin is how much percent saturated? Hemoglobin is only 50% saturated. Only 50% saturated, which means it delivered two molecules. According to the condition, hemoglobin nature is also changing. It is delivering more and more oxygen. Now, same opposite thing. Now I take you to Antarctica or Arctic region. Now there is absolute cold. You are hibernating. All your functions, all your metabolic rate is coming down. Your tissues are not doing any metabolism. Now, whenever your tissues are not working, whenever they are not doing any metabolism, do they need oxygen? No. So what happens? Now hemoglobin will say, you don't need oxygen. I won't deliver you oxygen. Simple. Now that is left shift, guys. Now in the conditions of where there is a decreased temperature, decreased metabolic activity, or alkalosis happening in the body, now hemoglobin nature will be changed. See here, the exact opposite thing in the right sided shift curve. At the same 40 mm Hg partial pressure, at the same 40 mm Hg partial pressure, see hemoglobin is how much percent saturated? Instead of 75% saturated, it is 90% saturated, which means it is not delivering, it's not properly delivering the oxygen to the tissues. Why? Because tissues doesn't need oxygen. Okay, so according to different situations, hemoglobin nature will change. Okay, now why that hemoglobin nature is changing? That's important. Why? Because see, right shift is an example of low affinity state. Low affinity means hemoglobin is simply releasing the oxygen. Right shift. Okay, in the right shift, hemoglobin is simply releasing the oxygen. Why? Because see, it is seen in exercising muscles. Whenever you are doing exercise, there is more production of carbon dioxide at the level of tissues. Hypoxic conditions will be there. Acidotic conditions will develop in your body. Low pH, high amount of protons, and temperature levels will be increased. So all these conditions, all this environment at the level of tissues will change the molecular structures in the hemoglobin in such a way that hemoglobin is easily delivering the oxygen. So they will ask you, right shift is happening in which states? Hypercarbia, hypoxia, acidosis, low pH, high amount of protons, increased temperature, and with the presence of chemicals like 2,3-DPG. Okay, 2,3-DPG. All this will bring the changes in the hemoglobin in such a way it will easily deliver the oxygen to the tissues. That is the right shift. Right shift. You need to know. And exactly opposite thing is left shift. Okay, before discussing about the left shift, I want you to know one more important point, P50 value. What is this P50 value? And P50 value is increased in which conditions? P50 value is decreased in which conditions? You need to know this. Okay, sir, P50 value is increased in and P50 value is decreased in. Now, very simple. It's very simple. What exactly is this P50 value? Guys, I know I'm taking a lot of time, but watching worthy. It's watch worthy. Rather than simply just going on normal points, I'm discussing all important concepts. Okay, whenever you have time, just share it with your friends. Those FMGE students who are not even knowing this, just share with your friends. After the exam, you will feel happy for attending the class. Okay, now what exactly is P50 value? Okay, what exactly is P50 value? P50 is the partial pressure at which hemoglobin is 50% saturated in you and me. In you and me, if you want to saturate the hemoglobin 50%, you need to bring the partial pressures down to somewhere around 27 mmHg. This is the normal value, sure shot direct value. If you bring the partial pressure, normally at the level of tissue, it is 40. But if you decrease the partial pressure to 27 mmHg, now hemoglobin is only 50% saturated, will deliver 2 molecules of oxygen. This is normal P50 value. In you and me, in a normal resting state, the P50 value is 27 mmHg. Now, what is happening to P50 value in right shift? Just tell me. See, in right shift, what is happening to P50 value? P50 value is increased. Normal value is 27 mmHg. In right shift, the P50 value become 40. So that's the important point which you need to note. Please take the note. P50 value increased in right shift. Right is something good increased. And left shift. See, left shift is an example of high affinity state, which means oxygen is not getting delivered. Okay, oxygen is not getting delivered. Now, in which conditions you will see left shift, sir? Left shift is seen in those conditions where temperature is coming down, temperature is decreased. Okay, when temperature decreases, like somewhere like your total activity is going down. In alkalosis, when low amount of protons are there, less amount of carbon dioxide, especially in the fetal hemoglobin, all these conditions will change the hemoglobin nature in such a way hemoglobin is not delivering the oxygen to the tissues. Okay, so these are the examples of right shift and left shift, the conditions of right shift and left shift. And in left shift, what happened to P50 value? The P50 value is decreased. Okay, in left shift, P50 value is decreased. Please look at this graph. See, this is the P50 value, right? The P50 value is decreased. Normal value is 27. Here the value is somewhere around 15. Okay, so in right shift and left shift, what happened to the P50 values? Already I have discussed with you. And the last topic which you need to know from the respiratory physiology is the carbon dioxide transport. Very, very important. There is something called as the chloride shift or Hamburger's phenomena. Okay, chloride shift or Hamburger's phenomena you need to know for your exam. So what exactly is this chloride shift and Hamburger's phenomena? Let's see one by one. Normally your tissues, what they are doing? They are producing the carbon dioxide. Okay, they are producing the carbon dioxide. Now we all know carbon dioxide is majorly transported in which form? Bicarbonate form. So carbon dioxide, it is entering into the RBC. Now this carbon dioxide is going to react with the water. CO2 is going to react with the water. CO2 plus H2 will give H2CO3, carbonic acid. This carbonic acid is going to split into HCO3 minus and H plus. This H plus, see, this H plus is a proton, very bad fellow. This proton need to be totally neutralized, right? Because it's a free radical, right? It can damage the RBC. So this proton is going to bind with the hemoglobin, forms HbH. Important point is, what is the fate of this bicarbonate ion? The bicarbonate ion HCO3 minus, okay, now it want to go into the plasma. See, it is coming out into the plasma. One negative charge is coming out. So in order to maintain the ionic balance, one negative charge is coming out, right? In order to maintain the ionic balance, HCO3 is coming out. So one negative charge is brought into the cell. So Cl minus is brought into the cell. So this is chloride shift or Hamburger's phenomena. Okay, to throw the bicarbonate into the plasma, one chloride is brought into the cell. This chloride shift or Hamburger's phenomena. And reverse chloride shift at the level of alveolus, what happens? Exactly opposite will happen. Now the bicarbonate, whatever is present, okay, the bicarbonate, whatever is present in the plasma, it will again go back into the RBC. Why? Because carbon dioxide, we have to form the carbon dioxide, right? We don't want the bicarbonate, we want to take out the carbon dioxide from the body. So HCO3 minus is going to again enters into the RBC. So not to maintain the ionic balance, again chloride is again going to come back into the plasma. So this is reverse chloride shift. Okay, reverse chloride shift. Now this HCO3 is again going to bind with that proton, forms H2CO3, split into H2O and CO2. This CO2 is going to enter into the alveolus. Why? Because in the alveolus, the partial pressure of carbon dioxide is all the time 0. The partial pressure of carbon dioxide is negligible, it is 0. So from here, the carbon dioxide is going to diffuse into the alveolus. So carbon dioxide transport, the concept of Hamburger phenomena and reverse chloride shift are also done. So all the important topics are discussed, guys, from the respiratory physiology. Now shall we go on with the one small topic that is GIT? Shall we go on with the GIT? Shall we go on with the GIT, guys? Okay. If we do central nervous system, it takes a lot of time. First, let's do the GIT. Because GIT is simple and we can go a little faster. Okay, gastrointestinal system. Now I will ask you direct questions. This GIT is a straightforward subject. Okay. Now I will ask you questions. You just try to answer them. Now the GIT wall is made up of how many layers? GIT wall is made up of 4 layers. What are they? Mucosa, submucosa, muscularis as well as serosa. There are 4 important layers in the GIT. 4 important layers are there. Out of these 4 important layers, what is the strongest layer? Mucosa, submucosa, muscularis, serosa. The strongest layer of the GIT is serosa. The strongest layer is serosa. Okay, the strongest layer is serosa. But the serosa is absent in esophagus. Okay, serosa is the layer which is absent in the esophagus. Now, if you can remember, see with the just 1 minute, guys. I just made a small mistake. Serosa is not the strongest layer. Submucosa is the strongest layer. Okay, submucosa. Okay, Submucosa is the strongest layer. Just small correction. Okay, not the serosa. Serosa, strongest layer is the submucosa, and serosa. Serosa is absent in esophagus. Okay, very important. Now, let's talk about the Meissner's plexus. In your GIT, there is something called as the Meissner's plexus. If you look at the wall of the GIT, there are a lot of these nerve connections, right? There are a lot of these nerve connections which are present over here. This is the submucosa. You can see a lot of nerve network is there. And here also in the muscularis, a lot of nerves are there. Now, these are called as Meissner's plexus and Myocyte plexus. Meissner's and Myocyte plexus. Now, this Meissner's plexus is present where? So, the important point is the Meissner's plexus is present in which layer? Submucosa. Submucosa. Meissner's plexus is present in the submucosa, and its Meissner's plexus is helping in what? It helping in GI secretions. Okay, it helping in GI secretions. All the GI secretions, like all the hormones, all the enzymes which are getting produced for the purpose of digestion. All these enzymes are produced because of the Meissner's plexus. Meissner's plexus is for secretions. Now, after this, let's talk about the myotic plexus. Now, what is this myotic plexus? This myotic plexus is also called as R-back plexus. R-back plexus. Okay, R-back plexus, myotic plexus or R-back plexus. Now, this R-back plexus is helping in what? GI motility. Okay, R-back plexus is helping in GI motility, guys. R-back plexus is helping in maintain the GI motility for the peristalsis purpose. Now, let's talk about the gastric acid first. Now, there are different types of GI secretions starting from the saliva, gastric acid, bile is there, intestinal juice is there, pancreatic juices are there. Okay, different types of secretions are there. But important point, a lot of times the question was asked is gastric juice. Now, gastric acid, the HCl, the gastric acid is nothing but the HCl. What is the important point? It's a maximum secretion. Maximum GI secretion is, okay, maximum GI secretion is gastric acid. Maximum GI secretion is gastric acid. And second important point is it's having maximum, not maximum pH, lowest pH. It is having lowest pH, which means highly acidic. Okay, the most acidic secretion in your body is your gastric acid. Now, can you tell me, if you are really good, can you tell me the most basic secretion in your body? The pH of 8.9, highly basic secretion in your body. Can anyone tell me? The most basic secretion in your body is? Anyone? The most acidic secretion in your body is gastric acid. The most basic secretion in your body is? Come on, guys. Pancreas? Bicarbonate, someone is saying. No, which secretion? Is it bile? Is it saliva? Or is it pancreatic secretions? Or is it intestinal juice? See, no one is answering here, but important. The most basic secretion in your body is Brunner glands. Yes, Ganesh Reddy, you are true. It's a Brunner glands secretion. Okay, it's a Brunner gland secretions are the most basic secretion in your body. Now, students will get it out. Sir, what exactly are these Brunner glands? Okay, what are these Brunner glands? Brunner glands are the mucus producing glands in duodenum. Okay, mucus producing glands in the duodenum, they are having highest concentration of the bicarbonates. So these secretions are highly basic. Why? Because acid is coming from the stomach, right? That acid needs to be neutralized in the duodenum. So duodenal Brunner glands produces more amount of bicarbonate rich mucus which will neutralize the upcoming acid. Now let's talk about the other GI secretion, that is the saliva. Let's start with the saliva. So what is the major salivary gland? Can you tell me? There is parotid salivary gland, there is submandibular salivary gland, there is sublingual salivary gland, there are Ebner glands, tubarial glands. There are different types of salivary glands. Can you tell me major salivary gland? See, goblet. Now I will tell you. This is very important. See, mucus cells. Mucus cells in stomach. Mucus cells in stomach are called as foveolar cells. Foveolar cells are the mucus producing cells in the stomach. Mucus producing cells in the duodenum are called as Brunner glands. Mucus producing cells in like the duodenum, like jejunum, ileum, there they are called as the goblet cells. Okay, goblet cells in the intestines. Okay, goblet cells. Goblet cells are also the mucus producing cells in the intestines. So, jejunum, ileum, in that region. Okay, mucus producing cells in the stomach are called as the foveolar cells. Foveolar cells. Now, what is the major salivary gland? Can you tell me? The major salivary gland is submandibular salivary gland. Submandibular salivary gland. Submandibular salivary gland is a major salivary gland. Can you tell me minor salivary gland? The minor salivary gland. The minor salivary gland is called as Ebner's gland. Ebner's gland. Now, this Ebner's gland is produced what? It produces what? Ebner gland produces something called as lingual lipase. It produces which enzyme? It produces lingual lipase. Okay, so Ebner's gland produces the lingual lipase. Now, after this, see in the saliva, what are the different enzymes are there? So, in the saliva, there is an enzyme called as Thiolin. Put 10 star marks. This is repeatedly asked MCQ. Thiolin is for the digestion of carbohydrates. Okay, in the saliva, there is something called as the lingual lipase. This lingual lipase is helping in the digestion of lipids. Don't forget, lingual lipase is produced by which glands? Ebner's glands. Okay. Now, in the saliva, there is no enzyme for, see, carbohydrates are getting digested in the saliva, lipids are getting digested, but there is no enzyme for protein digestion. There is no enzyme for protein digestion. Saliva does not have any enzymes to digest the proteins. And saliva, it contains antibodies. Which type of antibodies? So, it contains secretory antibodies called as IgA antibodies. Which antibodies are present in all your body secretion? The secretory antibody, which is called as the IgA antibody, present in all your mucosal secretions. Okay, nerve innervation, very important. You are having parotid gland, the major glands, the parotid gland and the submandibular salivary gland. Now, parotid gland is innervated by which nerve? Remember, like parotid, P for, remember like this, reverse the P. So, parotid gland is innervated by the 9th cranial nerve. And submandibular salivary gland, S for 7th cranial nerve. So, 7th cranial nerve is innervating the submandibular salivary gland. Okay, so the nerve innervation to the salivary glands is done. After this, let's talk about the gastric glands. Here I am showing you the mucosa of the stomach, the small part of the mucosa of the stomach, where you can see these gastric pits. Okay, you can clearly see these gastric pits with lots of different colored cells. Okay, lots of different types of cells were there in these gastric glands. Now we'll see one by one. Okay, this is one gastric gland with the different types of cells. What are the different types of cells present, sir? See, the first cell which I am showing you on the top. Here, no labeling was given. I am just showing you. I am just telling you. So, the topmost cells are called as surface mucus cells. Surface mucus cells are also called as foveolar cells. Foveolar cells are the surface mucus cells. Down to surface mucus cells, these cells which I am highlighting right now, these are in the neck. These are called as mucous neck cells. Important point about the mucous neck cell is, so these mucous neck cells, these are the stem cells. The stem cells in the gastric gland, are the mucous neck cells. Important point. Now, after that, there are these parietal cells. What is the function of these parietal cells? These parietal cells produce acid, the real acid, the gastric acid. The gastric acid is produced by the oxyntic cells or the parietal cells. Now, these parietal cells not only produce the gastric acid, also produce something called as intrinsic factor. Intrinsic factor helps in absorption of vitamin B12. Mainly important. Acid production, B12 absorption. Next important point is the other cells called as the enterochromaffin cells. These enterochromaffin cells produce histamine. What is the importance of the histamine? This histamine will go and act on the parietal cells. Helps in the production of more and more acid. Histamine is coming from enterochromaffin cells. Don't forget. Parietal cells produce gastric acid. And there are cells called as the chief cells. Chief cells helps in production of enzymes like pepsinogen and gastric lipase. Helps in digestion of proteins. Gastric lipase helps in digestion of fats. Simple. And there are cells called as the D cells. D cells helps in production of somatostatin. Wherever you listen the word somatostatin, it inhibits everything. Here it inhibits acid, inhibits the acid production. Inhibits. And last cells are called as the gastrin cells, G cells. G cells helps in the production of gastrin. Just like histamine, see, histamine helps in stimulation of acid production. Just like that, this gastrin also helps in production of acid. helps in production of more and more acid. Just close your eyes and tell me. Now, pepsinogen is coming from pepsinogen and gastric lipase. Sir, pepsinogen and gastric lipase are coming from chief cells. Somatostatin is coming from B cells. Histamine is coming from enterochromaffin cells. Parietal cells are producing acid and intrinsic factor. G cells are producing gas. Okay, these are the cells which you need to know for sure, 100%. Now, can you identify this disease? The name of this disease, can anyone identify this disease? Guys, can anyone identify the disease which I am showing you? This is an image based question where I am just cutting and showing you the stomach, the gastric mucosa. It's looking like a brain. This is called as cerebriform appearance of gastric rugae. Okay, cerebriform appearance of the gastric rugae, where the stomach is looking like a brain with the gyra and sulci. This is called as, anyone? Harshpalson, yes, you are absolutely true. Excellent, excellent. This is not Barrett's esophagus. This is Meninter's disease. See, sorry, Harpalson. This is not Meniere disease. Meniere disease is absolutely different. Okay, this is Meninter's disease. Okay, so what I am showing you is Meninter's disease. What exactly is happening here? It's the foveolar cell. Okay, let me write down here. The disease is Meninter's disease. The appearance is, cerebriform appearance. Already I have discussed with you cerebriform appearance. Now, what is the problem here? The problem here is foveolar. The topmost surface mucous cells, I have said you right. The surface mucous cells are the foveolar cell. There is foveolar cell hyperplasia. Okay, because of the foveolar cell hyperplasia, there is hypertrophic appearance of the gastric rugae. Now, my questions, just tell me, guys. Digestion inside the stomach. Gastric lipase is there, right? Just think. Gastric lipase and pepsinogen, from where they are coming? Chief cells. Chief cells. Gastric lipase is helping in the digestion of lipids. Pepsinogen is helping in the digestion of proteins. Simple. Now, important point is, which digestion is not happening in the stomach? Which digestion is not happening in the stomach? In stomach, there is no. Just give me 1 minute, guys. Oh my god, my Apple Pencil got absolutely zero charge. But just give me just 1 minute. I will just talk to you so that it will charge within just 1 minute. It will charge. Normally in stomach, which digestion is not happening, guys? In stomach, carbohydrate digestion. In stomach, carbohydrates are not getting digested, proteins are getting digested, and lipids are getting digested. Now, see, pepsinogen. Wherever you see the word ogens, ogens means they are inactive, zymogens. So here, pepsinogen need to be converted into pepsin. Pepsinogen will be converted into pepsin with the help of which hormone? Pepsinogen will be converted into pepsin with the help of HCl. So HCl is helping in the conversion of pepsinogen into pepsin. Okay, pepsinogen into pepsin. Now, substances and their absorption sites. There are different substances like, see, iron, vitamin B9 and vitamin B12. Where iron is mostly absorbed? In which area iron absorption happens? Is it in stomach? Is it in esophagus? Is it in duodenum? Is it in jejunum, ileum, colon, rectum, cecum? See, iron is mainly absorbed in duodenum. Okay, vitamin B9 is absorbed in jejunum. Okay, jejunum, and jejunum is the most common site for maximum, see, not most common site, jejunum is the site for maximum water reabsorption. Not, I didn't say reabsorption, for the maximum water absorption. Okay, maximum water absorption. So maximum water absorption happens where? In jejunum. And iron is mainly absorbed in which part? Duodenum. Okay, duodenum. B12 absorption. B12 absorption happens where? Especially in the terminal ileum. Terminal ileum. Okay, terminal ileum, jejunum, and duodenum. These are the three important sites for different absorption of different substances. Now let's talk about the pancreatic secretion sites. Now, your pancreas is there, right? It's producing lots of different types of digestive enzymes. What are the different types of digestive enzymes? One is pancreatic amylase. The name itself is there, amylase, helps in digestion of carbs. Okay, next, trypsinogen, chemotrypsinogen, procarboxypeptidase. So trypsinogen, chemotrypsinogen, procarboxypeptidase are helping in digestion of proteins. Now repeatedly ask MCQ, they will ask you simply trypsinogen, chemotrypsinogen or procarboxypeptidase. They will simply give this thing. Procarboxypeptidase is produced from stomach, parietal cells, G cells, enterochromaffin cells. Where this procarboxypeptidase is coming from the pancreas, not from the stomach. So procarboxypeptidase is helping in the digestion of proteins, and pancreatic lipase and colipase. This was the question asked a lot of times. This colipase. Okay, a lot of students they simply messed up. Colipase is produced from not gastric lipase. It's not lingual lipase. Colipase. Colipase is coming from pancreas. It's actually coming from the pancreas. So colipase, it's helping in the digestion of lipids. So one thing I can clearly say, in the pancreas there is digestion of carbohydrates, there is digestion of proteins, there is digestion of lipids. So pancreas means pan, it digests everything. Pan means like a pan-Indian movie, something like that. Okay, pan-Indian things. Usually these days it's getting more and more famous, right? So pan means it digests everything. Pancreas digests everything. Okay. Now next thing, pepsinogen is converted into pepsin. In the stomach, pepsinogen is converted into pepsin with the help of HCl. Now, trypsinogen is converted into trypsin with the help of enterokinase, guys. Enterokinase. What exactly is this enterokinase? We'll discuss later. Enterokinase is nothing but the intestinal juice. Okay, it's intestinal juice which is coming from the intestinal glands. So, enterokinase is helping in the conversion of trypsinogen to trypsin, but pepsinogen to pepsin will be converted with the help of HCl. Will be converted with the help of HCl. Now, let's talk about two important cells which are must and should for your exam. If I am the examiner, I will mainly concentrate this area. See, look at here, guys. Right now, I am talking about S cell and I cell. They are just like a gatekeepers in the duodenum. S cell is producing a hormone called as secretin. I cells are producing this CCK-PZ. CCK-PZ means cholecystokinin pancreozymin. So direct MCQs. S cells produce what? Secretin. Remember, secretin is the first hormone discovered in the humans. Take a note. Secretin is the first hormone discovered in the humans. Secretin is the first hormone discovered in the humans. Secretin is the nature's antacid. Secretin is the nature's antacid. It's actually anti-acid. Now, what this I is doing? The I cells in the duodenum, they help in production of cholecystokinin pancreozymin. Now, let's see the functions. Okay. Now, the secretin, it will come and act on the pancreas. When secretin is acting on the pancreas, do you know what happens? The pancreatic juices will become more and more rich in the bicarbonates. Pancreatic juices have become more and more rich in bicarbonates. Now, why? Because secretin is anti-acid. Now, these bicarbonates, now they will go into the duodenum. They will go and release into the duodenum. They will neutralize the upcoming acid. So, anti-acid. Secretin helps in production of more bicarbonate rich pancreatic juices. Those pancreatic juices will neutralize the acid. Simple. Now, what is the function of this cholecystokinin pancreozymin? Now, name itself is there. Cholecystokinin. Cholecyst is gallbladder. Kinin means movement. So, contraction of gallbladder. Now, this cholecystokinin pancreozymin, this cholecystin part will cause a contraction of gallbladder, helps in release of bile. Okay. Now, this is the major function, cholecystokinin. But the cholecystokinin pancreozymin, the name itself is there, pancreozymin. So, this cholecystokinin pancreozymin will also act on the pancreas. It will also act on the pancreas, but when it acts on the pancreas, do you know what happens? Now, pancreatic juices, just give me a minute. Now, pancreatic juices will be rich in enzymes. So, enzyme-rich pancreatic juices. Okay. Previously, when secretin is acting on the pancreas, bicarbonate-rich pancreatic juices are released. Now, when cholecystokinin pancreozymin, when pancreozymin is acting on the pancreas, enzyme-rich, digestive enzyme-rich pancreatic juices will be released. Why? We'll discuss now. See, what is the major stimulus for the release of? The major stimulus for the release of secretin is what? Secretin is anti-acid. See, whenever acidic chyme enters into the duodenum, acidic chyme will stimulate the these S cells. S cells produce secretin. Secretin will act on pancreas. Pancreas will release more bicarbonate-rich pancreatic. Simple. So, what is the major stimulus for the secretin? It is the acidic chyme. Next thing. What is the major stimulus for cholecystokinin pancreozymin? Major stimulus for the cholecystokinin pancreozymin is, just think logically. Whenever you have cholecystokinin pancreozymin, what it will do? It helps in release of bile. What bile will do? emulsification of fats, helps in digestion of fats. So fat rich food, whenever you eat fat rich food, that fat rich food will come and stimulate the eye cells. Now these eye cells release cholecystokinin pancreasomin. Cholecystokinin helps in the contraction of gallbladder. Bile is released, helps in emulsification of fats. Fats are digested. Simple. Okay, done. So I have discussed with you the major stimulus for secretin as well as cholecystokinin. Now here I am just showing you these are the crypts inside the intestine. These are the crypts of Lieberkühn. These are the crypts of Lieberkühn. The question which I want you to know is, in the deepest part of the crypt, there are these cells called as the Paneth cells. The question asked in one of the PG exams, this was the question asked in the PG exams, Paneth cells, what they will produce? They will produce substances like defensins. This was the exact question. Defensins are produced by, okay, defensins. Defensins are produced by Paneth cells, also lysozyme. So lysozyme and defensins are produced by the Paneth cells. Done. Now let's talk about a few important points about the gastrin, cholecystokinin, pancreasomin, and secretin. See, try to understand like this. The secretin, these S cells. Just let me clear it here so that it will be easy for you to understand. So try to understand like this. The S cells and I cells, they are side by side. They are side by side means they are in one neighborhood. They are just like in one locality. They are just like friends. So S cell and I cell. So secretin and cholecystokinin, pancreasomin, they are coming from one locality. Their actions are also similar. What is that action? You know that I have in the beginning of the topic I have said you they are just like gatekeepers. Okay, they are just like gatekeepers. Now they inhibit the gastric emptying. They doesn't allow the gastric chyme to enter into the duodenum at a time. So inhibits gastric emptying. Gastric emptying means emptying of the gastric contents into the duodenum. So our cholecystokinin and pancreasomin and secretin, what they do? They decreases gastric emptying. They decrease the gastric emptying. And gastrin, what it will do? Gastrin, where it is coming? Gastrin is coming from the G cells, sir. Now this gastrin will act on the parietal cells, helps in the production of acid. Now the same gastrin fellow increases the gastric emptying. So who increases the gastric emptying? Gastrin. Who decreases the gastric emptying? Cholecystokinin, pancreasomin as well as secretin. Now what are the substances with fast gastric emptying? The substances with a fast gastric emptying, which substances? So here there are three major important substances, that is carbohydrates, proteins, fats. Carbohydrates, proteins, fats are there. Now whenever you eat carbohydrates, it's a very logic thing, right? Whenever you eat something, the food which is rich in carbohydrates, the halt over time is very less. Immediately they are going to enter into the duodenum, and immediately you will get the digestion is going to be completed. You will immediately get the glucose. So for carbohydrates, the gastric emptying is very, very faster, followed by proteins, followed by lipids or fats. Okay. Now whenever you take carbohydrates, within just 2 to 3 hours, the food is going to enter down into the duodenum. But if you take proteins, it will take almost 4 to 6 hours for the proper digestion to happen in the stomach. And if you take fats, it almost take 9 hours. 9 hours. So the gastric emptying is very fast for carbohydrates, followed by proteins, followed by fats. The hormone produced during fasting. The question asked in the one of the FMGE exam, what is the hormone that is produced during fasting? Whenever you are doing fasting, the hormone produced, which is called as the ghrelin. Okay, so ghrelin is the hormone which is produced during fasting. What this ghrelin will do? It increases the hunger. So hunger, who increases the hunger? It is ghrelin. Okay, ghrelin. Okay, someone is saying insulin. No. So especially during fasting state, ghrelin is produced. Ghrelin increases the hunger. Okay. Now let's talk about the GI motility. The concept of GI motility very, very important. If I am the examiner, definitely I would like to ask a question from here. Now, can you tell me what are the pacemaker cells of GI? The pacemaker cells. The pacemaker cells. The pacemaker cells are called as interstitial cells of Cajal. Okay, the interstitial cells of Cajal are the pacemaker cells, which are starting from the body of the stomach. They start from the greater curvature body of the stomach. Important point is, see here I am showing you the one interstitial cell of Cajal. Okay, one interstitial cell of course. 90% of the students doesn't even understand properly what exactly here, what is this BER, basal electrical rhythm, what is the spike potential. Very simple. See, normally these interstitial cells of course, in these cells, the voltage is fluctuating. See, normal the resting membrane potential is -60. These are pacemaker cells, right? They are not, they won't simply sit like this all the time. Their action, their voltage is fluctuating. They will go near to the threshold potential, but again they will come back. Again they will go near to the threshold potential. Again they will come back. They will never fire. They are not fired. They are not firing. Simple electricity is fluctuating. Okay, so can I call them as action potentials? These are they real action potentials? No, they are not the action potentials. These are basal electrical rhythm. Electricity is rhythming, okay, changing. Basal electrical rhythm. But whenever you eat food, the moment you eat food, parasympathetic nervous system is activated. Vagus nerve is firing. Vagus nerve is releasing the acetylcholine. When vagus nerve is releasing the acetylcholine onto the interstitial cells of causal, now real action potentials are generated. Now these real action potentials, see, are you able to appreciate these spike potentials? These spike potentials are the real action potentials. So never ever say the basal electrical rhythm, also called as, these are also called as the slow waves. Never ever say the slow waves are basal electrical rhythm as action potential. They are not action potential. What are real action potentials? The spike potentials are the action potential. Okay, if I show you here, see, now here is the electrical recording, here is the mechanical recording. Mechanical recording means actual motility, actual GA motility. Now see, here coming like this, are you able to appreciate the spike potential? See, whenever there is a spike potential, there is a contraction. Whenever there is only one spike potential, there is only little contraction. So more the number of spikes, more powerful contraction. In the same way, here also you can see, here is the electrical recording. Now see, this is the normal basal electrical rhythm, normal BER, normal flow wave. Whenever there is a normal BER, is there is any mechanical recording? There is no mechanical recording, sir. But whenever you eat food, whenever acetylcholine is there, see, there is spikes coming. The more the number of spikes, more powerful contractions are coming. Okay, so these spikes are because of the acetylcholine. More the number of spikes, more powerful contractions. Okay, the spike potentials are the real action potentials. The down thing, basal electrical rhythms are not the action potential. Now, the kind of question that was asked in one of the, not in one of the FMGE exam, lots of times this question was asked, BR frequency, basal electrical rhythm frequency. The interstitial cells of causal are present throughout, okay, they are present throughout the GI tract. Now, in the duodenum, the basal electrical rhythm is somewhere around 12 waves, basal, the slow waves, 12 waves are going to come in 1 minute, and in ileum, the waves is going to be 8 in number. In cecum, the basal electrical rhythm is 2 in number. Important, basal electrical rhythm is a maximum in duodenum. Maximum in duodenum. Okay, that. So electrical motility, electrical fluctuations we are done. Now let's talk about the peristalsis. Okay, peristalsis. Peristalsis means it happens when during a fed state or during fasting state. It happens during fed state. So whenever you eat food, that food need to be propulsed. Okay, that food need to be kicked forward. Okay, that food need to be kicked forward. See guys, now here is the food bolus. This is the food bolus. Now, in order to prevent the regurgitation back, the proximal segment is contracting. The proximal segment is contracting with the help of release of neurotransmitters like acetylcholine. We all know acetylcholine causes a contraction. So, with the help of neurotransmitters like acetylcholine and substance P, the proximal segment is contracting, but the distal segment is relaxed and receiving the food. So, this is an example of a peristalsis, that the distal segment is dilated with the help of neurotransmitter like nitric oxide and vasoactive intestinal peptide. VIP means vasoactive intestinal peptide, which causes smooth muscle relaxation. Receiving the food. Nitric oxide, smooth muscle relaxation. Receiving the food. Okay, this is one type of GI motility. The other type of GI motility is segmentation. Now, what exactly is happening in the segmentation? See, segmentation is mainly, it's a major GI motility. Most of the students will think peristalsis is the major GI motility. No, peristalsis is not the major GI motility. It's a segmentation which is the major GI motility. Okay, see guys, in segmentation, the proximal segment is contracted as well as the distal segment is also contracted. Both the proximal segment and distal segment are both are contracted. Now, what is happening? See here, food bolus is just made into a pocket. It was kept in a pocket. Now this food bolus is getting digested. All the digestive enzymes are released here. Now with the digestive enzymes, food will be digested. So segmentation mainly helps in digestion. Peristalsis mainly helps in movement of the food, propulsion of the food. Okay, done. Now, the third type of GI motility which you need to know for your exams is MMC, migratory motor complex. Migratory motor complex, do you know when it will happen? It will happen during fasting state. Fasting state. Right now, I am not eating anything. I am fasting. Okay. Now, even then also, your GIT will contract, clean away the leftover food. Means cleaning the GIT, taking away the leftover food, preparing your GIT for the next meal. So, this is called as migratory motor complex. It occurs during fed state or unfed state. It occurs during fasting states. It starts from the stomach. The wave of contraction will start from the stomach. It will go to the colon. It is also called as the broomstick of GIT or sweeper of the GIT. It's cleaning the GIT. Okay, and it is mediated by what? Which hormone mediates? Anyone knows? Guys, anyone knows which hormone mediates? Excellent, excellent. Sivaprasad, motilin. Okay, motilin, excellent. So, motilin is a hormone mediating the migratory motor complex. One migratory motor complex, one wave, one MMC is going to be seen every 90 minutes. One wave will come, starts and cleans the GIT. Okay, so motility in GIT. The motility in GIT is mainly divided into how many types? Electrical motility, guys. Electrical motility. What is that? Basal electrical rhythm, which is also called as slow waves. Okay, slow waves, not the action potentials. The spike potentials are the action potentials. Mechanical motility, the real contractions. See, during fasting state, what do you have? Migratory motor complex. During fed state, what do you have? Two things. One is peristalsis. Okay. One is peristalsis. The other thing is segmentation. Who is major? Segmentation is major. Segmentation is major. Okay. So with this, we're also done with the gastrointestinal system. Gastrointestinal system is done. Shall we do the endocrine system now? Shall we go on with the endocrine system, guys? Is it helpful? Is it helpful? Guys, please share the video with as much as this FMGE graduates as possible. Because this will be very helpful for them at this last moment. If they can just they can watch like that. Yeah, I'm just trying to recall everything. Shall we start with the so shall I go with the CNS? Okay, a lot of students are asking the CNS, so I will do with the CNS. CNS is a little big chapter. Let's try to do it as fast as possible. So, what I want you to know as an FMG graduate, see, in CNS, eyes were there. Okay, in the special senses, eyes will be coming. In ophthalmology, the entire subject is about eyes, right? So, I'm not going to discuss about eyes, hearing here. Why? Because entire ophthalmology is dedicated for eye vision. Entire ENT is dedicated for the hearing thing. Okay, so here I'm not going to discuss about vision, hearing, all these things. Okay, what I want you to know is first let's start with the basics. Okay, let's start with the basics. Now, order of neurons. How many order of neurons are there? First order neurons, second order neurons, third order neurons. Three order neurons were there. Now, what exactly are these neurons? See, first order neurons, they will start from the level of receptor. They start from the level of receptor, and they first order neurons take the information to the spinal cord. So, the neuron which is extending from, see, the neuron here I am showing you, the neuron which is extending from the receptor into the spinal cord is the first order neuron. Taking the information, touch information, pain information, temperature information from here. If someone comes and touch me here, the touch information is going like this and entering to the spinal cord via the first order neuron. Second order neuron will start from the spinal cord, it will go into the thalamus. So this is the second order neuron. So from the spinal cord, it will go to the thalamus, the second order neurons. Third order neurons will start from the thalamus and go to the cortex. Okay, somatosensory cortex, area number 312. Area number 312 is the somatosensory cortex. All the information, touch, pain, temperature, pressure, vibration, proprioception, 2-point discrimination, all the information is going like this by the first order, second order, third order neurons. So all the sensations are going like this. Okay, from the receptor to the somatosensory cortex. Here you are feeling, all the sensations are felt here. So this is first, second and third order neurons. Okay, the basic thing. Now after seeing this, let's talk about the first touch. Okay, touch. Now if someone comes and touches you, definitely you will feel the touch, right? So first of all, you need to have a receptor. Someone is coming and touching like this, is a mechanical force. That mechanical force need to be converted into the electrical impulses. What receptor is doing? Receptor will convert mechanical force into the electrical impulses. So what I am saying is there are different types of touch receptors in your skin. What are they? First one is Meissner's corpuscles, Merkel's, Pacinian and Ruffini's endings. These are the 4 different types of touch receptors. Meissner's corpuscles, Merkel's, Pacinian corpuscles and Ruffini's endings. These are the different types of touch receptors. Okay. Now they will respond to different types of touch. Okay, they will respond to different types of mechanical sensation. Repeatedly ask MCQs, which I want you to know, especially for the exam, is Meissner's corpuscles. They are going to be responded to which type of touch? Miss means girls. How you will behave with the girls? Gently, fine touch. Okay, so gentle tapping. You are going to have low frequency with them. Low frequency talking like that. Okay, so gentle tapping, low frequency vibrations will stimulate the Meissner's corpuscles. Meissner's corpuscles and Merkel cells. Merkel cells, they are very much important. See, they are very much important, especially for detecting the edges and corners. Okay, for detecting the edges and corners. Which cells? Which receptors do you need? Merkel cells. Now, these Merkel cells are also very much important for knowing the Braille script. Okay, the Braille script is for the those persons who are having visual impairment, right? Okay, those persons who are blind, they are having a special kind of script that with the help of tactile sensations they will know what is written. Okay, so that's the Braille script. So Braille script reading is with the help of which receptors? Merkel cells. Low frequency vibration, gentle tapping, Meissner's and Pacinian corpuscles. Pacinian corpuscles, they are the biggest receptors. If you see here, the Pacinian corpuscles, they are capsulated, they are biggest and they are deep situated inside the skin. Very important. Pacinian corpuscles, they are capsulated, they are the largest, they are having deep, they are situated deep. So they are going to be responded to which types? Deep touch. Not the gentle tapping, deep touch. Someone is coming and doing like this. Okay, deep touch. Important. So Ruffini's endings are present in the joint capsules, in the joints. So simple. I will ask you a question, you just tell me. For reading Braille script, what do you need? Merkel cells. Which receptors are responding to the deep touch? Pacinian corpuscles. Largest are Pacinian corpuscles. Capsulated are Pacinian corpuscles. Which receptors will detect the edges and corners? Merkel's. Low frequency vibrations, gentle tapping, Meissner's corpuscles. Done. Okay, these are the receptors. Now, remember one important point, guys, from all the receptors, first order neuron have to start, right? First order neuron have to start and take the information to the spinal cord. So what is the first order neuron? See, from this receptor, the first order neurons are the A beta fibers. MCQ. The first order neurons are the A beta fibers. So A beta fibers are the first order neurons from these receptors. Touch receptors, different types of touch receptors, and the first order neuron from the touch receptors. First order neuron is called as the A beta fiber. That's it. Now pain. Now let's discuss about the different types of pain. How many types of pain are there? If you have love failure, definitely you will have pain, heartbreaking pain. But I am not concerned about that here. I am talking about the acute pain or sharp pain. Okay, whenever someone comes to you, your girlfriend comes to you and prick you with a pin. Okay, she's coming and pricking you with a pin. She's a sadistic girl. She's coming and pricking you. Definitely, are you going to have pain or not? Yes. What type of pain? Slow pain? No. Sharp pain. Okay, or acute pain. And there is some one more type of pain called as a chronic pain, dull pain, diffuse pain. Okay, this is coming from viscera. Whenever you're having stomachache, that kind of pain is called as a dull pain or visceral pain. Important point is, see, acute pain or fast pain is carried by which nerve fibers? It's carried from A delta fibers. Okay, first order neuron. Which first order neurons are carrying sharp pain? A delta fibers. They are fastest. They are highly myelinated. Mark my word, they are highly myelinated. They are the fastest fibers. And chronic and dull and diffuse pain is carried by lot of time this question was asked C fibers. C fibers carry dull and diffuse pain or visceral pain. Okay. Now, what is the most potent allergen? See, serotonin, bradykinin, all these chemicals will come and accumulate around the nerve endings. They will cause pain. They will cause pain. They will decrease the threshold for pain. That's a total different thing. But direct question is, what is that chemical which will cause more pain? Bradykinin. The most potent allergen is bradykinin. Okay, bradykinin. The most potent allergen is bradykinin. Now, one more important MCQ which I want you to know, the first order neurons carrying the pain sensation. For example, someone is coming to you and someone is pricking you like this. Now, you will definitely, the pain information should have to go right. The pain information is going like this. First order neurons should have to end where? The first order neuron have to end in the spinal cord. The first order neuron ends in the spinal cord in a nucleus called as substantia gelatinosa. See, the first order neuron, okay, the first order neuron, here will be the cell body. The first order neuron, it will come and it will end here in this green color region called as substantia gelatinosa. Okay, pain fibers ends in the substantia gelatinosa, important point. Now, after this, here I am showing you the cross section of the spinal cord. Some important points, one important law is there which I want you to know. See, here the orange color fiber which I am showing you, this orange color fellow, it's carrying what? It's all carrying the sensations from the body, touch, pain, temperature, vibration, all the sensations are coming and entering where? Entering into the spinal cord. In which region? In a region called, see this region is called as a dorsal horns. Dorsal horns. So, sensations are coming where? Sensations are coming into the dorsal horns. The first order neurons are ending where? In the dorsal horns. So, dorsal horns are sensory in nature. Sensory in nature. Now, there are these horns which I will let me show you with the pink color. These horns which are present anteriorly called as anterior horns or ventral horns. These horns. Now, are you able to appreciate from the ventral horns, this green color nerve fiber is coming out. This green color fiber neuron is coming out and it is going. Do you know where it will go? It will go to the skeletal muscles. It will cause what? Contraction of the skeletal muscles. This is the anterior horn or the ventral horn is a motor horn. So, what I am trying to put into your mind is, see, the dorsal horns are purely sensory. These fellows, dorsal horns, they are receiving the sensations, purely sensory, and the ventral horns are purely motor. This law is called as Bell-Megendi law. So, Bell-Megendi law states as the dorsal horns are purely sensory and the anterior horns or the ventral horns are purely motor. Okay, very good. And one more important point which I want you to know is, sir, what exactly is this? This thing and this thing. So, this one which is carrying the sensory neuron inside it. Okay, the one which is carrying the sensory neuron, the orange color fiber, this one is called as the posterior root or dorsal root. This one which is carrying the motor fiber is called as a anterior root or ventral root. Anterior root or ventral root. So, posterior root is sensory in nature. Posterior root is sensory in nature. Anterior root is motor in nature. Okay, either they are purely sensory or they are purely motor. But see, the roots, they will come and they will fuse and form spinal nerves. The roots will fuse and they will form what? The roots will fuse and they will form a spinal nerve. In a spinal nerve, both there is sensory neuron as well as motor neuron. So, spinal nerves are mixed. Very, very important point, guys. See, roots are all the time pure. Please concentrate here. Roots are all the time pure, but the spinal nerves are mixed in nature. They contain both sensory as well as motor nerves. Now, after discussing this, let's start with the somatosensory pathways. Okay, let's start with the somatosensory pathways. Now, somatosensory pathways, what exactly are they? Very simple. They are ascending tract. They are taking the information to the spinal from the spinal cord into the cortex. Touch, pain, temperature, pressure, vibration, all these sensations, advanced sensations as well as primitive sensations, all of them from the body, they are going into the spinal cord. From there, they are going to the cortex. And in the cortex, you are feeling all the sensations. In the somatosensory cortex area number 312. How many ascending tracts are there? Mainly. How many somatosensory pathways? How many somatosensory pathways are there? Mainly two. What are they? They are called as anterolateral pathways, dorsal column pathways. The somatosensory pathways, other name is spinothalamic pathways. From the spinal cord to the thalamus. From the spinal cord to the thalamus and from the thalamus to the cortex. Sensations going like this. Now, how many types of somatosensory pathways are there? Anterolateral pathways, dorsal column pathways. Two different pathways are there. Now, Both these pathways, what they are doing, taking the sensory information to the brain. Which area? Area called as the post-central gyrus, this blue color area. Post-central gyrus, that's called as the somatosensory cortex, area number 312. All the sensations are processed here. Now, first let's start with the anterolateral pathways. Anterolateral pathways. Now, why they are calling as anterolateral pathways, we'll see. Anterolateral pathways are again further divided into anterior and lateral. Anterior spinothalamic pathway, lateral spinothalamic pathway. I hope you have already studied all these things in anatomy, but I will just explain it in a very simple way. Anterolateral pathway. See, anterolateral spinothalamic tracts. They are sensory or not? Definitely they are sensory. They are carrying which information? See, they are carrying a primitive information. Anterolateral path, primitive information. Which information? Crude touch, pain, temperature, pressure, touch, pain, temperature, pressure, crude touch. All the primitive sensations, even like these sensations were there, like almost at the ape level also. These are primitive sensations. Important point is, see, these pathways, they cross at the level of spinal cord. What does I mean by? Please look at this image, guys. Okay. Now, look at here. Imagine this is first order neuron. This is the first order neuron. Okay. This is the first order neuron. It is coming into the spinal cord and it is terminating here. First order neuron is taking the touch, pain, temperature information into the spinal cord. First order neuron is done. Now, see, second order neuron is starting in the spinal cord. Second order neuron is crossing to the opposite side. So that's what I'm talking. The information is crossing to the opposite side. Okay. Now, see, the second order neurons are ascending up like this, and second order neurons are getting terminated in the thalamus. In which nucleus? Ventroposterolateral nucleus. The nucleus name, I hope you already know this. The nucleus called as the ventroposterolateral nucleus of the thalamus. The second order neuron is terminated, done. Now, from here, the third order neuron is starting and it is going where? To the somatosensory cortex, area number 312. Brodmann's area number 312. So, what is happening? The pathways are crossing to the opposite side at the level of spinal cord itself. Second order neurons are crossing to the opposite side. Okay. Now, based on this, now let's see the anterior spinothalamic tract, and lateral spinothalamic tract. First, right now, let's talk about the lateral spinothalamic tract. Why we are calling it as a lateral spinothalamic tract? See, the first order neuron. Just give me 1 minute. Yeah. This is the first order neuron. Is happening. Yeah, this is the first order neuron. It is carrying which sensations, guys? That direct question that you want to know, that the examiner want to ask you is, see, the lateral spinothalamic tract. The lateral spinothalamic tract carry which type of sensations? Primitive sensations. But which type of primitive sensations? Pain and temperature. Pain and temperature. If someone wants to come and hurt you, where they will hurt you? Someone will come and pinch you somewhere over here, right? So lateral pain. Okay, thermometer is kept on the lateral aspect of the body. So pain and temperature, remember it like this. Okay, just like a mnemonic. Pain and temperature are carried by the lateral spinothalamic tracts. First order neuron is carrying the pain and temperature information. The first order neuron is terminated, see, getting terminated in the substantia gelatinosa. And the second order neuron, see guys, second order neurons are crossing to the opposite side. Okay, and where? They are traveling in the lateral column, not in the anterior column. They are traveling in the lateral column, see. Laterally they are traveling. That's why they are called as lateral spinothalamic tracts. Okay, they are traveling in the lateral columns, second order neurons. Now the second order neurons, where they are going? To the ventroposterolateral nucleus, VPN, ventroposterolateral nucleus. Now from here, the third order neuron will start and go to area number 312, somatosensory cortex, done. So lateral spinothalamic tracts carries pain and temperature information, done. Now anterior spinothalamic tracts carry which type of sensation? Primitive sensations. Which type of primitive sensations? Crude touch and pressure. The first order neurons are carrying crude touch and pressure. First order neurons are getting terminated in the dorsal horn. From here, the second order neurons are starting. Important point is they are now crossing and traveling in the anterior column. Now they are traveling in the anterior column like this, and now they are getting terminated in the again ventroposterolateral nucleus. Just difference is traveling either in the lateral column of the spinal cord or traveling in the anterior column of the spinal cord. That's the only difference. Okay. So at the end of the day, third order neurons again will go to area number 312. So anterior spinothalamic tracts done, lateral spinothalamic tracts done. Okay, primitive sensations are done. Now let's talk about the dorsal column tracts. Okay. Now let's talk about dorsal column tracts, guys. Simple. Now, dorsal column tracts, which type of information they are carrying? Dorsal column tracts will carry advanced sensations, not the primitive sensations, touch, pain, temperature, not. They are carrying the advanced sensations. What are those advanced sensations? Like fine touch. Okay, like fine touch. Here I have the list I have given you. Fine touch, vibration, okay, vibration sensation, conscious proprioception, 2-point discrimination, stereognosis. Okay, I'm not explaining what exactly stereognosis is because it takes a lot of time. Stereognosis means just without even looking, I can say this is cell phone. So this is also a type of sensation, right? So all this information, fine touch, 2-point discrimination, vibration, stereognosis, all this information are the advanced sensations. They are carried by the dorsal column tracts. They are traveling in the dorsal column of the spinal cord. These tracts are uncrossed tracts. They do not cross at the level of spinal cord. They do not cross. Okay, I will show you. See here, from the lower limbs, the advanced sensations. The advanced sensations from the lower limbs are coming like this. This is the first order neuron. Now the advanced sensations coming like this, coming like this. The first order neuron, see, it's not getting terminated. The first order neuron is directly jumping into the dorsal column, back side of the spinal cord. It's just directly jumping into the dorsal column and it is traveling like this in the form of fasciculus gracilis. So what exactly is fasciculus gracilis? Fasciculus gracilis is a fascicle which is nothing but the first order neurons carrying the advanced sensations from the lower limb. In the same way, from the upper limb, the advanced sensations are carried into the spinal cord. In the spinal cord, there is no crossing happening. These first order neurons, they will jump into the dorsal column and travel in the form of fasciculus cuneatus. The fasciculus gracilis and fasciculus cuneatus, they are carrying advanced sensations. They are nothing but the first order neurons. Now, both these fasciculus gracilis and fasciculus cuneatus, now see, they are terminating in nucleus gracilis and nucleus cuneatus. First order neurons are terminated, not in spinal cord, but in medulla. Okay, but in medulla, they are terminated. Now, the second order neurons started in nucleus gracilis and nucleus cuneatus, second order neurons. Now, the second order neurons, they are crossing to the opposite side. So, crossing is happening. The advanced sensations, they will cross at the level of medulla, not in the spinal cord. The advanced sensations are crossing. This crossing is called as internal arcuate fibers. Now, what exactly are internal arcuate fibers? Nothing but the second order neurons carrying the advanced sensations crossing to the contralateral side. Now, these second order neurons, they will ascend up like this. Now, ascend up in the form of a fascicles, in the form of a bunches. These are called as a medial lemniscus. Okay, so again, medial lemniscus is carrying which type of sensations? Advanced sensations. Medial lemniscus. Now, this medial lemniscus, where it is going? Again, it have any sensation have to go to the ventroposterolateral nucleus of thalamus, and they have to reach the area number 312 of the cortex. From the thalamus, the second order neurons are terminated. In the thalamus, the second order neurons are terminated, and third order neurons have started from here, from the ventroposterolateral nucleus, and the third order neurons are carrying the advanced sensation to the somatosensory cortex, area number 312. So, this is how the advanced sensations are traveling. So, primitive sensations, anterolateral tracts done. Advanced sensations, dorsal column, medial lemniscal tracts are also completed. Okay. Now, after understanding this, now a very famous question which is repeatedly asked in the exam, that is Brown-Sequard syndrome. So, what exactly is Brown-Sequard syndrome? Simple. I just don't want to explain further here. Very simple. It's a hemisection of the spinal cord. The half of the spinal cord, see, because of a bullet injury or stab injury, half of the spinal cord got transected. Okay, at that particular segment, half of the spinal cord is damaged. If half of the spinal cord is damaged, definitely the patient is going to have certain sensory losses as well as motor losses. Okay, now which sensations are lost? Remember, just by heart, guys. Okay, now ipsilaterally on the same side, for example, see here, I am just showing you the right side. Okay, left. Now the lesion is on right side. Okay, half of the spinal cord is dissected. Okay, half of the spinal cord got damaged. Now what happens on the same side, on the right side, there is ipsilateral loss of dorsal column sensations. Advanced sensations are lost on this side. Why? Because advanced sensations do not cross to the opposite side. So they are traveling on the same side lesion, same side gone. So advanced sensations are lost on the same side. And from the opposite side, fibers will cross to this side, right? Primitive sensation fibers will cross to this side. So they are also gone. So there is contralateral loss of anterolateral column sensation. Anterolateral column sensations means primitive sensations. Ipsilateral loss of advanced sensations, contralateral loss of primitive sensation. Okay, this is what is seen in Brown-Sequard syndrome. This is sensory loss. Motor loss. Whenever there is damage to spinal cord, definitely the patient is going to have paralysis, like Okay, which paralysis? Same side paralysis. Ipsilateral side, the patient is going to have motor loss. On the same side of lesion, the patient is going to have paralysis. Why? Because see, I have explained to you already. From here, which neurons will come out? Motor neurons will come out, right? They will go to the spinal cord. Sorry, they will go to the skeletal muscles. So whenever these motor neurons are damaged, definitely the patient is going to have ipsilateral paralysis. Okay. So these are the important points which I want you to know. Ipsilateral, dorsal column sensation loss, contralateral, anterolateral column sensation loss, and ipsilateral motor losses. Now, what else you need to know? Syringomelia. Okay, the topic of syringomelia is also very, very important. What exactly syringomelia? Syrinx means cavity, a cavitation, abnormal cavity is forming in the spinal cord. Abnormal cavity is getting formed in the spinal cord. Now, even in this image, you can clearly see in the spinal cord you have an abnormal cavity. Okay, this cavity, it's dilated, it's expanding, and it's damaging the motor horns and the sensory horns. Now, in the syringomelia, there is something very special is saying. See, whenever you listen this word dissociative sensory loss, the moment you see this word dissociative sensory loss, you can 100% keep, okay, this condition is syringomelia. What is happening? See, in the syringomelia, to understand this, see, I'm just talking about this neuron, this orange color neuron, the brown color neuron. You just tell me, is it carrying advanced sensations or primitive sensations? Just tell me, guys. Screen gone. Guys, is it clear? Screen is good or gone? Guys, are you able to see the screen? Is it clear? Now good, okay? Yeah, it's good. Okay, okay. Now just tell me, what is this nerve fiber? What is this nerve fiber? See, it is coming like this. It is coming, it's jumping into the dorsal column. It is going up. So definitely, is it carrying advanced sensations or is it carrying primitive sensations? It's carrying advanced sensations. Carrying advanced sensations. It's the dorsal column tract, right? Okay, it's now next. Now, please see, look at this green color fiber. Now, this green color fiber, it is ending in the spinal cord. The first order neuron is ending in the spinal cord, and the second order neuron is crossing to the opposite side. It's crossing to the opposite side. So definitely it is anterolateral tract. It's an anterolateral tract, definitely. Now what is happening? Please look at the syrinx. Here is the syrinx. Whenever syrinx is there, which fibers are damaged? Just tell me, sir. This fiber, the green color fiber, which is carrying the primitive sensations, is gone, but there is no problem to this dorsal column tract. So there is a loss of temperature and pressure. Okay, there is loss of temperature and pain. There is loss of temperature and pain, or there is loss of other primitive sensations. But the patient is normally having advanced sensations. So this is called as a dissociative sensory loss. It means certain senses are lost, certain senses are preserved. So this is called as dissociative sensory loss. Loss of pain and temperature. Primitive sensations are gone, but dorsal column sensations are spared. This is seen in syringomelia. Especially the syrinx, this cavity, this cavitation is especially seen in C3, C4 segments. Okay, in the cervical spinal cord, especially this is going to be seen in C3, C4 segments. This cavity, abnormal cavity is going to be seen, and very, very important, especially from the medicine point of view, the syringomelia is going to be associated with a condition called as Arnold-Chiari malformation type 2. This is absolute medicine. I just don't want to go into detail. Arnold-Chiari malformation type 2. Those persons who are having Arnold-Chiari malformation type 2, the cerebral peduncles, they will herniate down onto the spinal cord to the foramen magnum. That is Arnold-Chiari malformation. Those who ever have Arnold-Chiari malformation, they are also having the syringomelia usually. Okay, done. Now let's talk about something called a sensory homunculus. Whatever I am showing you is this image. Whatever I am showing you, this is called as the sensory homunculus. Okay, sensory homunculus. What exactly sensory homunculus is? Mapping. I'm actually mapping the brain areas. See, I'm just telling you, this brain area is receiving the information from the foot. This brain area is receiving the information from the hip, like that. This brain area is receiving the information from the hand, something like that. I'm mapping the brain areas, okay, dedicated to the sensory processing. This is called as a sensory homunculus. I'm just mapping different brain areas, different somatosensory cortex for different different regions of the body. Okay, for receiving the different sensations from different regions of the body. Now, maximum representation is there for face. Okay, maximum representation is there for face. Even in the face, lips are taking more area, which means there is a lot of area on your brain, especially dedicated for the processing the sensory information from the lips. Okay, so face and hands are taking more area. Even in face, lips are taking more area, and in hands, thumb is taking more area. Now, least representation is there for trunk and hips. Direct singular question from trunk and hips. Okay, the sensory processing is done by a very little area, but more area is given for sensory information from the face as well as from the hand. In the face, it is lips. In the hand, it is thumb. Okay, done. Now, let's talk about a phenomena called as the law of projection. Repeatedly asked MCQ in your exams. Now, what the hell is this law of projection, sir? See, this law of projection tells you, it explains you a phenomena called as phantom limb phenomena. Let me tell you. So, normally this patient, he met with a road traffic accident. During in that road traffic accident, he lost his limb. Okay, he is an amputee. We have amputated his limb. But see, he can still feel irritation from his little finger. He can sometimes, not every time. He can still feel the sensations which are coming from his foot. How this is possible? Because see, his lower limb is gone. But still this pathway is still present, right? Okay, all this pathway which was supposed to carry the information, from the lower limb, it is still present, right? So what happens by chance? If you irritate anywhere, okay, if you stimulate, for example, but because of some reason, if you stimulate this nerve ending, which was left over in that stump area, if you stimulate here, what happens? Now the somatosensory cortex, okay, which was supposed to, the somatosensory cortex still is there. The somatosensory cortex, which is dedicated to process the information from the foot, is still there. Now the person feels like he is getting the information from the thumb. So what exactly is this law of projection? Is anywhere in this sensory pathway, if you stimulate, the person will feel the sensations from the receptor level. The person will feel the sensations, they are coming from the receptor level. They don't feel the sensations are coming from this area. No, they will feel the sensations are coming down from the receptor level. So this is known as the law of projection. It explains you phantom limb phenomena. Phantom limb phenomena means even the person loses his limb, he can still feel the sensation from that amputated limb. Okay, so done. Now let's start with the motor pathways. Sensations are done. Okay, ascending pathways are done. Now let's talk about the corticospinal tracts. Hope already you done really good with the anatomy. Corticospinal tracts, it means from the cortex, information is coming down into the spinal cord. So corticospinal tracts. The upper motor neurons are coming like this. Upper motor neurons will come down into the spinal cord, and in the spinal cord, the upper motor neurons will control the lower motor neurons, and the lower motor neurons are the ones which helps in contraction of the muscles. So upper motor neurons, lower motor neurons. That I will show you now. See here what I am showing you. First, let's see one side. Okay, let's see on the yellow side, guys. Here. Now this cortex, is it a sensory cortex or motor cortex? Right now I am talking about the descending tracts, motor tracts. Here most of the students will make mistake. Most of the students will think upper motor neurons are coming from the motor cortex. No. Yes, motor cortex, upper motor neurons will come. See, 30% of the upper motor neurons, they are coming from the primary motor cortex. 30% of the upper motor neurons are coming from the premotor as well as supplementary motor cortex. But very, very important, see, the majority of the upper motor neurons, 40% of the upper motor neurons, they are coming from the post-central gyrus, that is area number 3, 1, 2, somatosensory cortex. So motor fibers, upper motor neurons are originating where? They are originating in the sensory cortex. Now why it is called a sensory cortex? Because it receives the sensation, but the same somatosensory cortex will also contribute to 40% for the upper motor neurons. Okay, anyway, sensations are going, you got some, like, you just want to initiate the movement, so upper motor neurons are firing. So upper motor neurons are carrying the information. Now what happens? This upper motor neurons, 80% of the upper motor neurons, they are going to cross to the opposite side. So this crossing, upper motor neurons are crossing at the where? At the level of medulla. Very, very important. Pyramidal decussation happens where? Direct question. Pyramidal decussation happens at the level of medulla. 80% of the upper motor neurons, they will cross to the opposite side. Okay. Now what they are doing? Concentrate on the yellow fiber, guys. Concentrate on that yellow one. See this upper motor neuron, it is coming. Okay, it's coming like this. It is coming like this. It's coming like this. Where it is traveling? It is traveling in the lateral columns of the spinal cord. It is traveling down in the lateral columns of the spinal cord, and this upper motor neuron, it is ending where? Ending on the lower motor neuron. So upper motor neurons will actually come down. They will end on to the lower motor neurons. They will regulate the activity of the lower motor neurons. So lower motor neurons are directly going where? Lower motor neurons are directly going to the skeletal muscles. The skeletal muscles are contracted with the help of lower motor neurons. So what I am trying to put into your mind is upper motor neurons regulate the activity of lower motor neurons. Upper motor neurons, 80% of the fibers will cross at the level of medulla. That is called as a pyramidal decussation. Upper motor neurons, majority of upper motor neurons are originating in the somatosensory cortex. Okay, somatosensory cortex. 30% from the primary motor cortex and 30% from the supplementary motor cortex. Okay, but 20% of the fibers, see, 20% of the fibers, they do not cross. Even here I can show you. See guys, here, these are the upper motor neurons. Okay, all these are the upper motor neurons. All these upper motor neurons, see, they are coming down ipsilaterally. They are coming down. They are coming down, coming down, coming down. Now, see, in the medulla, what they are doing? 80% of the fibers, they will cross to the opposite side. But 20% of the fibers, they are not crossing. Now, they are traveling in the anterior side. They are called as anterior corticospinal tracts. All the other which are crossed, they are called as the lateral corticospinal tracts. So how many types of corticospinal tracts are there? Lateral corticospinal tracts, the majority ones, 80% ones, 20% are the anterior corticospinal tracts. Even this 20% corticospinal tracts will also cross the opposite side at the level of respective segments. At the level of their respective segments, they will also cross, and finally they will control the lower motor neurons. Lower motor neurons. Okay. Now comes the topic of lower motor neurons. Very important, which I want you to know. How many types of lower motor neurons are there? Lower motor neurons are coming from where? They are coming from the ventral horns. They are coming from the ventral horns. Now there are two different types of lower motor neurons: alpha motor neurons, the gamma motor neurons. Alpha motor neurons and the gamma motor neurons. They are the two different types of lower motor neurons. Alpha motor neurons goes where, and lower motor neurons goes. Gamma motor neurons goes where? Both of them, they will go to spinal cord only. Sorry, not spinal cord. They are both of them. They will go to skeletal muscle only. Alpha motor neuron go to the skeletal muscle. Gamma motor neuron goes to the skeletal muscle. Both of them goes to the skeletal muscles only. But what is the difference? See, alpha motor neurons are going to which area? Extrafusal fibers in the skeletal muscle. In the skeletal muscle, there are extrafusal fibers, intrafusal fibers. The alpha motor neurons innervate. Repeatedly ask MCQ. Alpha motor neurons innervate extrafusal fibers like actin and myosin. The gamma motor neurons innervate the intrafusal fiber. What is the example of intrafusal fiber? It's the muscle spindle. So muscle spindles are innervated by the gamma motor neurons. See, here I am showing you the muscle. Okay, all these outer fellows. Okay, all these outer ones. Okay, these are the actin and myosin. These are the extrafusal fibers. Now, in the deep inside the muscle, are you able to appreciate this thing? This is the intrafusal fiber. Intrafusal fiber is nothing but the muscle spindle. Okay, so this is the muscle spindle. Please see, alpha motor neuron, where it is going? To the extrafusal fibers. Intrafusal fibers are innervated by gamma motor neurons. Okay. Now, after understanding this, what is the importance of alpha motor neuron, gamma motor neuron? We'll see in a minute. But here I want you to know, repeatedly ask MCQ in your exam, is upper motor neuron lesion and lower motor neuron lesion. Because of some reason, because of stroke, because of some trauma, whatever might be the reason. If there is upper motor neuron lesion, means upper motor neurons are dead. If upper motor neurons are dead, what will be the symptoms? And if the lower motor neurons are dead, what will be the symptoms? These are upper motor neuron lesions and lower motor neuron lesions. I have already explained to you, upper motor neurons are like upper motor neurons are the regulatory ones. They regulate the activity of the lower motor neurons. Then upper motor neurons are dead. Now lower motor neurons, they are free. They are overactive. They are overexcited. So unnecessarily, they will cause activation of the muscles, and muscles are abnormally contracted. The muscles are in spasm like this. The person is in paralysis. This type of paralysis is called as a spastic paralysis. Spasms are there. Muscles are contracting, but he cannot use his muscles because abnormal contraction is there. So upper motor neuron lesions will cause which type of paralysis? Spastic paralysis. Lower motor neurons are overexciting, so that cause hypertonia. Muscles are having hypertonia, hyperreflexia. Okay, so muscles are still contracting, right? There is no problem with the muscle. Okay, lower motor neuron is still giving the trophic action to the muscles, so there is no muscle loss. So muscle loss is very less, and upgoing Babinski sign is seen. So I am not going in detail about the upgoing Babinski sign. Just remember, in upper motor neuron lesion, upgoing Babinski. Upper motor neuron lesion, upgoing Babinski. So whenever you see upgoing Babinski sign, you know, right, on the plantar aspect, whenever you do like this, there is a fanning out of fingers. Okay, that's absolutely totally different thing. I just don't want to enter into the medicine area. So upgoing Babinski sign is seen in upper motor neuron lesions. Okay, now let's talk about the lower motor neuron lesions. See, lower motor neurons are the real ones. Lower motor neurons are the real nerves which directly innervate the muscles. So whenever, because of some reason, whenever there is a lower motor neuron loss, upper motor neuron is there, but lower motor neuron is lost. So muscle is, do you think muscle will contract now? No, muscle is not going to contract. So hypotonia, hyporeflexia, muscles are not like, muscles are like this. Okay, whenever you do, muscles are like, totally flaccid, there is no contraction, it's absolutely flaccid. So flaccid paralysis is seen. There is, if you cannot use these muscles, automatically muscular atrophy can occur. So prominent muscular atrophy is seen. So these are the differences between upper motor neuron lesions and lower motor neuron. Important upgoing Babinski is seen in upper motor neuron lesions. Okay, done. So after this, let's talk about a few important reflexes which you need to know for your exam. Stretch reflex, simple reflex, stretch reflex. Guys, is it clear? Shall I continue, guys? Stretch reflex. What I will do is, okay, first let me uh, continue with the stretch reflex. Stretch reflex. This is also called as a myotactic reflex. Stretch reflex is also called as a myotactic reflex, and very important, it's a monosynaptic reflex MCQ. Which of the following is an example of monosynaptic reflex? They will give in your exam. Which of the following is an example of monosynaptic reflex? Stretch reflex. I will show you why it is called as a monosynaptic reflex. It's a very simple reflex. Let me explain to you in a very easy way. So what exactly is stretch reflex? Simple. Whenever you suddenly stretch a muscle, immediately that particular muscle will undergo contraction like this. Okay, so whenever you suddenly stretch a muscle, that muscle will undergo contraction. This is stretch reflex, which is a protective reflex. Okay, muscle got like startled up and immediately it will start contraction. Okay, so this is stretch reflex. How this will happen? See, in all the reflexes, one point, in all the reflexes, the main center is present in the spinal cord. Main center is present in the spinal cord. Now we'll see what exactly happens. Sir, in your muscles, I have discussed with you, there is something called as a muscle spindle. Muscle spindle, intrafusal fiber, innervated by gamma motor neuron, already I have discussed with you. Muscle spindle, what is the function of muscle spindle? A receptor, remember, it is a receptor. It all the time monitors what? It all the time monitors the length of the muscle. What is the length of the muscle? Is the length of the muscle is normal or not? It's all the time checking the muscle length. Okay, so now already I have explained to you. See, I am just showing you this fiber, this muscle spindle. I am just showing the muscle spindle in a detailed way. See, these muscle spindles are innervated by, already I have discussed with you, these muscle spindles are innervated by the gamma motor neurons, no doubt. But I said you, these are receptors. Receptors means they will take the information, they know the information, give the information to the central nervous system. So they are also innervated by the sensory nerves. Which type of sensory nerves? Guys, these are all general physiology. I am just trying to integrate as much as possible. So primary 1A fibers and secondary fibers. 1A fibers and secondary fibers are the sensory fibers, sensory innervation to the muscle spindles. Close your eyes and tell me, what is the motor innervation to muscle spindle? Gamma motor neuron. What is the sensory innervation to the muscle spindle? It is primary 1A fiber as well as the secondary fibers. Okay. Now, what happens, sir? Whenever in a stretch reflex, see, example is a knee jerk or elbow jerk. See, whenever someone comes and taps on your patellar tendon, okay, that's the tendon of the quadriceps muscle. Whenever someone comes and actually taps on the patellar tendon, what exactly we are doing? We're actually stretching the muscle. See, whenever someone comes and taps here, what exactly happens? The muscle is going to be stretched, pulled like this, right? So whenever you stretch a muscle, it will immediately start contraction. How, sir? How? See, Now, whenever you stretch a muscle, who is going to be get activated? Just tell me, who is going to be activated? Muscle spindle will be activated. From the muscle spindle, the information via which fiber? See, from the muscle spindle, the information is going via the 1A fiber as well as the secondary fiber. 1A fiber and secondary fiber takes the information to the spinal cord. These are protective reflexes. Information is not going to the cortex. Information is getting processed into the spinal cord itself. Immediately what will happen? Now this fiber, 1A fiber and secondary fiber directly come, and what they are doing? They are directly stimulating the alpha motor neuron to that specific muscle, So how many synapses are there here? One single synapse. Whenever alpha motor neuron is stimulated, just tell me, alpha motor neuron is nothing but a lower motor neuron. Alpha motor neuron innervates what? Extrafusal fibers like actin and myosin. So immediately muscle contraction will happen. Immediately that muscle will contract. So alpha motor neurons are stimulated. So this is stretch reflex. Now tell me, in stretch reflex, what is the stimulus? Whenever you stretch a muscle, the stimulus is a stretch. What is the receptor? Receptor is muscle spindles, intrafusal fibers. Now what are the afferents? Which nerve fibers are taking the information to the spinal cord? It is group 1A fibers and secondary fibers taking the information about the length of the muscle to the spinal cord. Now what is the center? Yes, simple, spinal cord is the center. Now what are the efferents? Efferents are the alpha motor neurons. So that particular muscle will be activated. Alpha motor neurons gives the information, gives the action potentials, electrical impulses, so that particular muscle is going to contract. The response is muscle contraction. And this is simple reflex, stretch reflex. Stretching causes contraction. Now, the second reflex which I want you to know for your exam is inverse stretch. Okay, inverse stretch reflex, also called as a Golgi tendon reflex. Inverse stretch reflex or Golgi tendon reflex. Now, what is the receptor here? What is it? Simple. Imagine a condition something like this. You came to me and you gave a 5 kg dumbbell to me. So what I'm going to do? I'm going to just hold it. Now, I'm just trying to hold it. Now, what happened to the tension inside my muscles? Now, my muscle, the tension inside muscles is going to increase. Muscles are contracting more. The tension inside my muscles is going to increase more. Now, you take out that 10 kg dumbbell. Now, you gave me 15 kg dumbbell. Now, I'm just trying to show off and I'm just trying to hold it. What happens inside my muscle? The tension is so much increasing. The pressure is building. It's very bad for the muscle. But still, I'm trying to hold it. Why? Because I'm just trying to do the show off. You take that dumbbell. Now, you gave me 25 kg dumbbell. Even if I want to hold it, I could not hold it. Why? Because immediately reflux will happen. Do you know what will happen? Immediately, all these muscles will undergo relaxation. As a protective mechanism, immediately I will leave the dumbbell. Immediately, all these muscles will be relaxed. Do you know how? Now, let's see one by one. Now, in your muscle tendons, there is a receptor called as a Golgi tendon organs. There in the tendon, Golgi tendon organ. Now, what these Golgi tendon organs are doing? They are all the time monitoring the tension inside the muscle. They monitor the tension inside the muscle. Whenever tension inside the muscle increases, okay, from here, the information will go to the central nervous system via which fibers? Group 1B fibers. Previously, in stretch reflex, it is group 1A fibers and secondary fibers. But here, what are the afferent guys? These are the afferents, means information is going into the spinal cord. So, what are these fibers? Group 1B fibers. Group 1B fibers taking the information to the spinal cord. Okay. Now, this group 1B fibers, what they are doing? Now, they are coming like this. See, they are coming like this. Please look at here. Don't forget all the, see, very simple. Now, this group 1B fibers, now what they are coming and doing, this red color neuron is there, right? What is this red color neuron? It's called the inhibitory interneuron. Now, that inhibitory interneuron is activated. Now, when inhibitory interneuron is, if it is activated, what it will do? It inhibits this lower motor neuron. So, the alpha motor neuron to that particular muscle is inhibited. When alpha motor neuron is inhibited, there is no contraction. Immediately, relaxation will occur. I'm going to leave the dumbbell. So, this is inverse stretch reflex, again protective reflex. Important points what you need to know here is, what is the stimulus? Increase the tension inside the muscle. What is the receptor guys? Golgi tendon organ is a receptor. What are the afferents? Group 1B fibers. What is the center? Spinal cord. What are the afferents? Inhibition of alpha motor neuron. When the alpha motor neuron is inhibited, what happens? Muscles are going to be relaxed. The next topic, very important topic, EEG and sleep. EEG and sleep is utmost important topic. Okay. I feel in the entire central nervous system, if I am the examiner, definitely I will give a question from the EEG only. Electroencephalogram. Now, just like ECG, in EEG, different types of waves are produced, like alpha waves, beta waves, gamma waves, delta waves, theta waves. Different types of waves are produced. Now, these waves are also called as simple burger waves. Just it's a simple 15 minutes topic, a 10 minutes topic, simply we can complete it. Alpha waves, beta waves, gamma waves, delta waves, theta waves. These waves, EEG waves, are also called as a burger waves. Okay. Now, the frequency of these waves is directly proportional to the brain activity, which means, for example, if you are having high mental activity, intense thinking, now the frequency of the waves are going to be increased. More frequency waves are going to come. Don't worry, I will explain you in a minute. For example, see here. Normally, let's start from here. Delta waves. The delta waves are having less frequency. The frequency is 1 to 3, means 1 to 3 waves are going to be produced in a second. Very less frequency. Only 1 to 3 waves are going to be produced. So, which waves are having less frequency? Delta waves. Delta waves are having less frequency, and delta waves are produced when? During sleeping, during absolute, like, deep sleep. In deep sleep, in NREM 3 and 4, we'll discuss about the sleep. In deep sleep, we are having delta waves. Means lesser activity, less frequency waves are produced. That's what I have discussed. The frequency is directly proportional to the mental activity. If no activity means less frequency waves are produced. So in sleep, you are having 1 to 3 frequency delta waves are produced. Now theta waves means little drowsiness, not sleeping, drowsiness is there. Initial sleep, light sleep, you are going to have theta waves. The frequency is going to be 4 to 7 hertz. 4 to 7 waves are produced. Okay. Now alpha waves. Now you are awake. You are not thinking about anything. You are almost like meditating. You have closed your eyes. You are not thinking about anything. You are not paying attention to anything. Just you are awake. Just close your eyes, like you are doing absolute meditation. So then you are going to have alpha waves. Okay, alpha waves. The frequency is 8 to 12 hertz. And beta waves, like, busy, like right now we are having the lecture. You are like listening. Now in the normal day-to-day regular activity, beta waves are going to be reduced. The beta wave frequency is 13 to 30 hertz. But whenever you are thinking about your girlfriend and your life, intense mental activity, what's happening with my life, what's happening with my exam, intense mental activity, or you are thinking about some theorem, okay, then you are going to have gamma waves. Gamma waves are going to be produced in the EEG. The gamma wave frequency is somewhere around more than 60 hertz. 60 hertz. Okay, so different waves with different frequencies according to the mental activity. Okay. Now after this, let's talk about simple alpha waves. Some important points. Alpha waves, already I have explained to you. 8 to 12 hertz is going to be seen. Alpha waves are produced with eyes closed in a relaxed state. These alpha waves are coming from which area? These alpha waves are coming from the occipital cortex. The alpha wave, every wave is having one name. Alpha wave is called as inattention wave. The person is not paying attention to anything. He is absolutely meditating. Inattention wave. Next thing, beta wave. Beta waves are going to be produced in a normal, like, normal awake state. Day-to-day mental activity is like, paying attention. And these beta waves, the name is called as the EEG desynchronization wave. Just don't go too deep into it. Just try to by heart it. EEG desynchronization wave is beta wave. That's it. Okay. And these electrical activity is coming from which area? Not occipital cortex. It's coming from the frontal cortex. Done. Gamma waves. Gamma waves means high frequency, more than 60 hertz. Now these gamma waves are going to produce when the person is having intense focus or extreme focus. Now he is thinking about solving some problem, or he is like, thinking about something like a scientist. Okay, intense mental activity, intense focus. Okay, gamma waves are going to be produced. Now theta waves. Theta waves are going to be produced during, like, drowsiness. Theta waves. Okay. Now these theta waves are going to be produced from the hippocampal region. These here theta waves are called as the memory waves. Theta waves are called as memory waves. Now delta waves. Now delta waves, I have already explained to you. Delta waves for deep sleep. Delta waves having less frequency. Delta waves are having a frequency of 1 to 3 hertz. Delta waves are going to be produced in a deep sleep, NREM 3 and 4, and these are also called as a slow waves. Remember, slow waves, only 1 to 3 hertz is there. But remember, slow waves we have also discussed in the GIT. Basal electrical rhythm, also called as slow waves. They are not the action potentials, don't forget. Okay. Now let's talk about the cycles of sleep. Now we are discussing about sleep. How many phases of sleep are there? Sir, every student knows. Okay, you are all exam going batches. There is something called as NREM sleep, REM, NREM, REM. NREM, REM. So whenever you sleep, you will go into NREM, REM. NREM, REM. Fluctuation will happen. Now, just by looking at this, just tell me, first you will go into NREM or REM? First you will start with which sleep? NREM or REM? See here, first you are falling asleep. Now the first stage is NREM, the NREM stage 1. Later we will go into NREM stage 2, NREM stage 3 and NREM stage 4. So here you can clearly see NREM stage 3 and NREM stage 4 are absolutely deep sleep. Light sleep is, see, lightest sleep is NREM stage 1. NREM stage 1 is a light sleep. Deep sleep is NREM stage 4. Okay. Now, after NREM, you will go into REM. This is called as the one sleep cycle. One sleep cycle. One NREM, one REM is called as sleep cycle. Important points which you need to know is, sir, sleep is divided into how many phases? NREM sleep, REM sleep. NREM means no rapid eye movement, non-rapid eye movement. Eyes are not moving. In REM sleep, rapid eye movements is happening. Eyeballs are moving. Rapid eye movement is seen. In NREM, no rapid eye movement is seen. Now let's talk about NREM. Okay, we have seen here NREM was divided into stage 1, stage 2, stage 3, stage 4. What is the important points which you need to know? Stage 1 is light sleep, right? Light sleep. In light sleep, which waves are seen? Theta waves are seen. What is the frequency of theta waves? 4 to 7 hertz. Simple. Now NREM stage 2. See, a frequency of 8 to 12 hertz waves are produced. Now you start to think 8 to 12 hertz means alpha waves, right? Now these are not alpha waves, don't confuse. Alpha waves are produced with eyes closed, but still the patient is awake. Now the patient is sleeping. Okay, now these waves are totally different waves. These are also having a frequency of 8 to 12 hertz, but these are not alpha waves. Okay, in NREM stage 2, important point I want you to know is, in stage 1, see, in stage 1, theta waves are produced. In stage 2, please see, in stage 1, just give me 1 minute. In stage 1, you are having theta waves, no doubt. No one is going to like draw these waves and no one is going to ask you which wave. Just they will ask you these only terms: sleep spindles and K complexes. Directly, sleep spindles, these overriding waves. Okay, the sleep spindles and K complexes are seen in NREM stage 2. NREM stage 1, theta waves. NREM stage 2, sleep spindles and K complexes. In NREM stage 3. In NREM stage 3 and NREM stage 4, already I have explained to you, these are deep sleep. Deep sleep. In deep sleep, delta waves are seen. Delta waves means 1 to 3 hertz. Delta waves. See here, in NREM stage 3 or deep sleep, what waves we are having? Delta waves. NREM stage 2, K complexes as well as sleep spindles. Stage 1, it is theta waves. Okay, NREM, done. Now let's talk about the REM sleep, REM sleep. Now, in REM sleep, what frequency waves are produced? 30 to 30 hertz. 30 to 30 hertz. What is 30 to 30 hertz? It's actually the frequency of beta waves, right? So beta waves are getting produced during REM sleep. So this is something abnormal, right? That's the reason why this REM sleep is called as paradoxical sleep. Paradox means absolutely abnormal. Why? Because beta waves are supposed to produce during wakefulness. But the same frequency beta waves, 13 to 30 hertz beta waves are produced during REM sleep. So this is called as a paradoxical sleep. Now important points which I want you to know is, here in REM sleep, which types of special patterns are going to produce? It is PGO spikes. PGO spikes are seen. These PGO spikes are the ones. PGO means pons, geniculate body, occipital cortex. Okay, PGO spikes are seen. These PGO spikes are the ones responsible for the rapid eye movement. Rapid eye movement. Okay, so just remember, PGO spikes are seen in NREM or REM? REM. REM. Okay, and during REM sleep, the entire body muscles are relaxed. The entire body muscles are relaxed. In REM, all muscles are relaxed. Now, why this is? Because I will ask you, in REM sleep, sleepwalking is possible. Just tell me. In REM sleep, all muscles are relaxed except diaphragm, except sphincters, and except ocular muscles. All other muscles are relaxed. So walking is possible? No. In REM sleep, all muscles are relaxed. So night walking is not possible. Bruxism, grinding of the teeth, is possible during REM sleep? Not possible. Why? Because all muscles, these are muscles, right? All the muscles are relaxed during REM sleep. So bruxism, night talking, night walking, all these are not possible during REM sleep. Only they are possible during NREM. Okay, and during REM sleep also, penile erections will happen. Penile erection happens during REM. Okay, now let's talk about the concept of parasomnias. Parasomnias. What are parasomnias? Abnormal sleep activities. In NREM, What type of abnormal sleep activities can be seen? So there can be night terrors. Night terrors means the person is having a dream. The person is having a dream that cannot be remembered. Remember this one point. Remember it like this. REM means remembrance. Whatever happens in REM, whatever happens in REM, you can remember. Okay. See, imagine you are thinking about a beautiful woman. You are having a crush, and she is coming into your dream. The morning, you can feel like she came. She is coming in your REM sleep. That's the reason why you can remember her. Okay, so whatever happens in REM means remember it like remembrance. You can remember it. NREM means no remembrance. You have a dream, you are having a very bad dream, but you cannot recollect. There is something like something came, but I couldn't recollect. Suddenly, I jumped out of my bed. I couldn't able to recollect. Very bad dream. So night terrors are dreams which you cannot remember. Nightmares are bad dreams which you can recollect and remember. And somnambulism. Okay. So somnambulism, the person is walking and he is going somewhere. Okay, somnambulism, it especially happens during NREM 3 and 4, stage 3 and 4. Okay, deep sleep. NREM stage 3 and 4. And sleep talking, bruxism. Bruxism means teeth grinding like this. Some people will do like this during the sleep. Now, this somnambulism, bruxism, sleep talking, everything happens in NREM. Especially bruxism happens in NREM stage 2. NREM stage 2. Now, I will ask you, in NREM stage 2, which type of waves are produced? Can you tell me? Sleep spindles and K complexes. Don't forget. Okay. The same way, nocturnal enuresis. Some persons will just let the urine out. That's a nocturnal enuresis, bedwetting. So bedwetting, especially the children, happens also in NREM stage 3. Okay. So these are parasomnias. The parasomnias especially happens in NREM. Okay. Now I will ask you one question. Just tell me, dreams happens in NREM or REM? Guys, just tell me, dreams happens in NREM or REM? Guys, dreams happen in NREM or REM? Can anyone? Dreams happen in both NREM as well as REM. But dreams can be remembered. Remember, dreams can be remembered in REM but cannot be remembered in NREM. Okay. Last, we are coming to the last. Hormonal changes, guys. What are the hormonal changes which can be seen during sleep? In NREM, growth hormone, we all know growth hormone levels increases, right? During sleep, pulsatile doses of growth hormone will be released. Growth hormone will be increased during NREM sleep, but the same growth hormone will be decreased during REM sleep. Very important. During REM, growth hormone levels decreases. During NREM, growth hormone levels increases, especially NREM 3 and 4. Prolactin level increases in REM sleep. MCQ for your exam. Prolactin levels are increased during REM. Growth hormone levels are decreased during REM. Now after this, last topic, that is the hypothalamus. Now in hypothalamus, you can see here, this is the pituitary gland. Below to, up to the pituitary gland, you are having lots of nuclei. You are having lots and lots of nuclei. Now this different nuclei helps in production of different substances, and they will regulate different activities. For example, see, direct questions, these things. Suprachiasmatic nucleus. Suprachiasmatic nucleus. It regulates what? The suprachiasmatic nucleus, it regulates which activity? Circadian rhythm. That is the sleep-wake cycle. Sleep-wake cycles. See, all of you guys at 11 o'clock, 12 o'clock, immediately you will have to, you will go into the bed, right? You will get that sleepiness. Who regulates that? It's a suprachiasmatic nucleus. Suprachiasmatic nucleus maintains your sleep-wake cycle, circadian rhythm, every 24-hour activities. Okay. So suprachiasmatic nucleus is called as a biological clock. Now the lateral nucleus of hypothalamus. Okay, lateral nucleus. I used to remember something like this. Whenever I am getting late, I will get hunger. Okay, now the class is getting late. Now I will have hunger and thirst, right? So lateral nucleus, just simple lateral nucleus is the thirst center. Sorry, not thirst center. It is a hunger center. Hunger center. What is the hunger center in your brain? It is a lateral nucleus. Lateral preoptic nucleus is the thirst center. Thirst center is lateral preoptic nucleus. Now VMN, ventromedial nucleus. What the hell is this ventromedial nucleus? Ventromedial nucleus, it's a satiety center. Satiety center. It's a satiety center. Means whenever you eat a pizza, cheesy pizza, you will have a feeling like, I'm done. I don't want to eat anything. So the satiety center is the ventromedial nucleus and supraoptic nucleus, SON, supraoptic nucleus. Even endocrinology also will study this, and even renal also will study this. The supraoptic nucleus of the hypothalamus produces what? Antidiuretic hormone, ADH. And the paraventricular nucleus, PVN, just try to remember it like this. Every time I used to give this mnemonic, SOAP. Supraoptic nucleus produces the antidiuretic hormone. Paraventricular nucleus produces the oxytocin. So paraventricular nucleus produces which hormones? Oxytocin. These are all the different nucleuses which are present in the hypothalamus. Now, anterior hypothalamus. Hypothalamus was divided into two regions: anterior hypothalamus and the posterior hypothalamus. Anterior hypothalamus, I used to remember like AC. AC means it cools your body, cools down the body. Okay, which means it helps in heat adaptation. Okay, it cools down your body. Whenever you were kept in a Sahara desert or wherever, automatically you will start to sweat, right? It will cool your body. The anterior hypothalamus will cause sweating. Okay, it will cause sweating. Now, so anterior hypothalamus, AC, remember, cools your body, and posterior hypothalamus makes your body warm. It makes your body warm. Okay, one thing cools your body, other thing warms your body. And the last fellow, just nucleus accumbens. Nucleus accumbens along with the medial forebrain bundle. Lot of times this question was asked. Nucleus accumbens is your addiction center or pleasure center or addiction. Okay, the pleasure center or addiction center, whenever the person is involved in the sexual activity, or whenever the person is taking the drugs, alcohol, he is having that kind of pleasure, right? Because of the release of serotonin and dopamine into these areas. Now, this nucleus accumbens and the medial forebrain bundle are called as the pleasure center or addiction center or reward center. Okay, reward. Whenever you do those activities, you will feel like you are getting a reward. Okay. So these are different nucleuses and important points which you need to know. So with this, central nervous system is also done. Guys, it's what's the time now? It's already 10:30. We are done with the most important systems with lot of important concepts. I hope this will be enough for today. If I further prolong it, it won't be like even you can't sit and even I can't sit. What I will do is I will take one more session for the remaining systems. What we are left with is the renal and endocrine. Okay, what we are left with is the renal and endocrine. Yeah, definitely. I won't leave it. Why? Because still you are having, I think, 61 days. Still 61 days is there for exam. Whenever possible, means if possible tomorrow, if not day after tomorrow, I will sit and I will do endo as well as renal. Okay, hope the session is helpful. Share with as many friends as possible. If it's helpful for you, I'm also happy. Okay, guys, thank you. See you in your next session. Good night, guys. Good night. Done.